an anaesthetist in Leicester, and I'm also the clinical lead for the One NHS Finance programme, which brings you the study day. So I'll be chairing this session today along with Pam Core. Pam, are you there?
Yes, hi everybody. Welcome to today's session.
Pam's finance. What's your current title, Pam?
I'm Pam Core. I'm Head of Financial Development at University Hospitals, Coventry and Warwickshire NHS Trust, which I've been there for about 11 years, but I have just over 20 years financial management experience within the NHS and 10 years of finance experience in other sectors. Thank you.
Great. So I'm going to be starting off and kicking off the morning and chairing the morning, and then Pam will do most of the afternoon's chairing. Now I'll be back at the end of the day to talk about business cases. So this day is basic level. It's we assume no knowledge. The idea is that we try and discuss the kind of building blocks, the elements, the kind of key fundamentals of NHS finance. There are quirks, there are differences regionally and locally. So we are going to be very generic about how we discuss things. The speakers may give you examples from their own experience and from their own areas, so whether it be Coventry, whether it be Leicester, whether it be other parts of the country. The elements and the concepts will apply across the board, but some of the specifics may differ between the different within your hospitals, within your organisations. So that's the first thing to mention. The sessions are all recorded, so feel free to drop in and out as you wish. So there'll be some sessions that are more relevant to you, some that are less relevant to you, so you can pick and choose as we go through the day. So I'm going to kick off with kind of an introduction and a little bit about how money flows within the NHS. So let's get going. To share my sound as well. So my computer's a bit slow today. Okay. So, as I said earlier, this is about navigating the healthcare system. It is not trying to make you into accountants. It's a very basic level of knowledge. We're going to start very broad and hopefully slowly build down to the specifics that may be more relevant to you in your individual organisations. At no point are we saying that that finances are everything. We are aware that in the current financial climate that there is always going to be pressure on all organisations financially, but ultimately we want people to be clinically driven. Patient safety, patient care is going to be the #1 driver of everything we do, but within a finite healthcare system and environment, we need to be aware of the decisions and the impact our financial decisions make. So saving money in one area can hopefully allow you to spend it in another. And that's the idea. And the word you'll hear across the day and across all manner of these kind of discussions is the concept of value. But what we really don't fully appreciate is what value is. So what we're going to talk about first is trying to define value. For us in organisations and in the broader sense of the concept. So there are three kind of types of value. There's something called allocative value, which is about how the resources that you have are divided up. So whether it be staff, whether it's money, it's how it's allocated. And that's done at national level, that's done at regional level, and to a smaller degree done at local level. Okay. So that's something called allocative value, or also known as economic value. What we're going to talk about a lot more today is something called technical value. And that is how you make best use of the resources that you have. All right, so that's what technical value is, also known as efficient value. All right. And we're going to talk a bit more about that in a second. And the final thing is something called personalized value. Now, that's the understanding that what you value, what I value, what our patients value vary and differ. Okay. And to kind of quantify this, the Virginia Mason Institute, which a lot of organisations have started working with, but they're an American-based healthcare system or accountable care organisations, what they're called over there, and they are very big on value in healthcare and value-based healthcare. And they worked with an organisation in one of the health boards in Wales, and they did this project where they looked at the key outcomes that the patients wanted. They rated on a scale, what they wanted out of consultation, and they did the same for the clinicians. And the clinicians, and this is a neurology clinic, so about brain disorders, and the clinicians wanted to diagnose the patient. They wanted the condition, to prevent disease progression, and then treat the underlying symptoms. The patients mostly wanted better sleep, more energy, to be able to go to work, to do things they enjoy. Now, often, and in most cases, those things align, but in some cases they differ, and it's just an understanding that value is different. That's also called effective value. So we're going to try and make this a little bit interactive. So if we were to make this the technical value, so we're going to focus on technical value, and if we had one word for the top line and one word for the bottom line, what would they be? So how would you define value as an equation? It's a finance talk, let's make it into a finance equation. So one word for the top line, one word for the bottom line. You can put it in the chat, you can shout it out, whatever you like.
Benefit divided by cost.
Okay, benefit divided by cost, okay. So we've got cost. That seems to be a consistent answer so far. Is there a better word than benefit? Is there a better word than outcome? So traditionally you might see outcome used, okay, but increasingly there's a better word for that, or what we're trying to achieve. So goals, efficiency, yeah, okay. We've kind of got it in quality of life. It's a simpler word than that. It's just quality. Okay. So true technical value in the current definition we're trying to use is quality over cost. Okay, and that's because it tries to encompass a slightly broader amount of just a broader concept. Okay, so then the next question is, what are the three domains of quality? So quality in both in definition, and most organisations have a quality commitment or a quality strategy. What would quality mean to you? So what are the three domains of quality? So we've got some of them, okay. Yeah, so we've got most of them in there. So we've got outcomes, clinical effectiveness outcomes, however you want to term it. That's the first bit. And it's important to note that there is no specific outcome measure that we're using here. Okay, so when you're using these in business cases or in kind of in proposals to expand your service or improve your service, and you want to show an improvement in quality, and you want to show there's a better clinical outcome, there isn't a specific one you've got to use. You've got to find the best one for your for what you're trying to demonstrate. So, it could be mortality, it could be readmission rates, it could be length of stay. All of these things are signs of effectiveness. Okay? And the reason I say that is that it doesn't have to be time specific. So one of my colleagues in Leicester, they developed a new way, or they started a new way. I'm not sure if it was them that developed it, but they use a new way to close a big cut in the abdominal wound. Okay, it adds 30 minutes onto the operation, so it increases the time of the operation, but it doesn't affect pain scores. It doesn't affect discharge rates. It doesn't affect readmission rates, 30-day readmission rates, or length of stay, or anything like that. In 5 to 10 years, over that period, it reduces the rate of a hernia coming back in that cut. Okay, and those are complex operations to fix. So, in your standard metrics, it wouldn't show any benefit. But if you pick the correct metric, the most appropriate metric, it does show benefit. So you've got to pick the clinical outcome that's most suited to whatever you're trying to show. And the other two, as people have demonstrated, is experience and safety. Okay. When we talk about cost, we focus on your revenue costs, which are your day-to-day running costs. Okay. So most budgets are split into day-to-day running costs, which are your revenue costs, and your capital costs, which are your big one-off payments, okay, big purchasing. And the guy that came up with this, Michael Porter, who's a Harvard business professor in America, he basically said there's two bits to it. One is that if you have to demonstrate, if you want to demonstrate good value, that the increase in quality is worth the cost. And that's what you've got to show in your business cases or proposals. But he also said that if you improve quality, you will reduce cost. The problem is, and it's a problem of working in silos that we have tended to do over the last 20, 30 years, is that it may not be the cost to your department. It may not be to the cost to your hospital, your organisation. It may be to primary care or to the wider health economy. Okay, to the wider regional health system. Okay, and there are also environmental societal costs which we never used to factor in. We're starting to factor it in. I also think that in this particular year it's less of a factor because of the current financial squeeze. So they are costs that are there. So quality does reduce cost. The problem is it may not be the cost to your organisation, and that's where we struggle. Okay, so I'm going to talk a bit more about structure, how money flows through the system and some of the changes, and a bit about payment systems at the end. And then the next speaker when we talk about payment or commissioning, we'll talk a bit more about that as well. So it's a kind of we're building on things as we go through the day. So the NHS started in 1948 and it's constantly evolved. One of the things that happened in 1948, the NHS wasn't a planned system. It was nationalising what was already in existence. Okay. And in year one, it ran out of money. It overspent what was predicted. Okay. So this is nothing new. Financial issues are nothing new in the NHS. It's been there for the whole duration of its existence. In 1962, they started to make a planned NHS. So they tried to build a DGH, a District General Hospital, for every 125,000 of the population. They ran out of money. So there's a theme. They started doing various changes. So in 1974, you had the development of health authorities. In 1990, you had the internal market. Now, the internal market was designed to make organisations compete for services. And in the capitalist market that we were in then, the idea was that if you, by asking organisations to compete, you would not only improve quality, you reduce cost. Okay, that works at times of boom when there's when the economy's growing, when there's money in the system that's available, that system seems to work. At times of a recession, of constraints, that competitiveness in a national health system doesn't seem to work, and that's been shown a couple of times now. So in 2000, the NHS plan, the last really big major reforms was the Health and Social Care Act of 2012, okay, also known as the Lands reforms. Now, they were, again, they entrenched the internal market they put it into law. They created NHS England and various other bodies to try and put the NHS at arm's length from political machinations, and therefore was going to be less of a political football. We've kind of withdrawn that back again more recently. So the lands reforms were the last major reforms that happened, and they were as with a lot of things in the NHS, the idea, the concept of it was probably not bad, because it was all about clinically led decision making, trying to make local decisions for local people. The concept, that the kind of strategy behind it wasn't bad. The problem was the implementation wasn't great, and the world changed between its concept being thought of and it being implemented. So it was probably designed and discussed in 2007, 2008, and then you had the economic crash, and then so by the time it was implemented in 2012, the world had changed by then. So it didn't really work, and for the subsequent 10 years, the NHS basically had to manoeuvre itself within that legal framework to reduce the amount of competition, to increase the amount of collaboration, because that's what they felt in times of recession needed to happen. So the 2022 Health and Care Act wasn't as major a restructure as the 2012. It was more tidying up the legislation to allow it to continue to push for collaboration rather than competition. Okay. So that's basically what's happened. And there is likely to be another health bill in the next next year or so to redo a lot of the changes, or to make further changes to the structure of the NHS. Okay, and we'll come on to some of those in a bit later. So the money that the NHS gets is determined by Parliament, and more specifically the Chancellor and the Treasury. It's set by the spending review, which we had last week, hence we've had to update these slides, and then it's adjusted annually by the budget report. So you may or may not have heard in the news about the budgets and stuff, but if we can rank in order what you think the budgets of the Department of Health, Education and Defence are. So when I do this in person, I do a higher and lower game, but for Teams I just rank it. So if you can rank 1, 2, 3, Health, Education, Defence, or Defence, Education, Health. Okay, so the numbers I'm going to show you in a second are the numbers for the current year, so for 25-26. Okay, and then it doesn't dramatically change over the course of the spending review. There's increases, but the rankings don't change. All right, so for current year, okay, health budget is going to be £215 billion altogether. So total health spending is £215 billion. Okay. Now these are the three biggest departments of planned spending. So this excludes pensions and benefits that come out of separate pots because they're not predictable. They vary a lot. So of the planned spending, so that's what the budgets are set at. You have health at 215 billion, you have education at 100 billion, and defence, even with the increases recently, is 62 billion. Okay, so health outspends the two other biggest departments. Well, we almost doubled the education budget. Okay. Whilst the department is called the Department of Health and Social Care is funded not via the Department of Health and Social Care. It's funded via the local authorities. Okay. So this is purely on health, and health is a devolved function. So this is purely on health in England. There are some aspects of it that have national remits, but most of it is for health in England. The majority of it is for the health in England. So we spend an awful lot of money on health in England. And as a proportion of all public spending, we are getting very close to 50% of all public spending is on health. So to increase spending on health any further, there are two ways of doing it. We either have to grow the economy, so there's more money coming into the government. Okay. So whether that's by increasing taxes or increasing the economic benefits, okay, or we have to cut other departments. So that's the current climate that we're in, is that we already have almost half of all public spending, day-to-day public spending, so that's your revenue budgets, are on health. So it's an interesting slide from the King's Fund. It suggests that we need about a 3% increase on average just to maintain the status quo. Okay. And improve slowly, very, very slowly. And when you only have a 1 to 2% increase, you end up having a slow decline in your services. So between 2010 and 2018-19, essentially, we had growth of budgetary growth of between 1 and 2%. Okay. COVID was a bit of a skewed number, but we did get to 3%, and then since then we've maintained around 3%. Across the whole history of the NHS, we've managed about 3.6% in real terms. So when they say real terms, if you factor in inflation, then you get 3.6% since its foundation. Okay. So this is how the money is spent and split. So this is again the whole thing. This is the total budgets for the NHS, the Department of Health and Social Care. Okay. So you have, you can see it slowly increases. We're at the midpoint there, 3 up, 25-26, with about 215. The spending review last week gave us a bit more numbers, so we got more detail. We are getting close to 250 billion pounds by 28-29. Okay. It's been divided into capital funding, which is the grey bit, which is pretty static. We had a big increase this year in 25-26. Well, it's not massive. Yeah, from 11.6 to 13.6, and then it's about static after that, really, the capital budgets. The orange is the NHS England budget, which is basically the money that's going down to commissioning and spending on directly on healthcare. Okay. Even when it gets absorbed into the Department of Health and Social Care, which it will at some point, a lot of that money will go towards commissioning health services, essentially. Okay. The blue bit at the beginning, okay, which is slowly grows, kind of falling, is Department of Health and Social Care and its funding of its bodies that it has to fund, okay, excluding NHS England. So there are 10 bodies that the Department of Health and Social Care funds. Okay. So excluding NHS England, there are 10 bodies. So organisations that are funded by the Department of Health and Social Care, how many can we name? Okay, so UK Health Security Agency, yeah, okay. NHIR is not directly funded. It's a mixture, so it's not one of the ones that's budget's completely reliant on the Department of Health and Social Care. MHRA, yeah, that's 2. So that's these 2. So Medical and Healthcare Products Regulatory Agency, which is basically responsible for it's the equivalent of approving medications and devices. You have the UK Health Security Agency, which used to be called Public Health England. Public Health England doesn't exist anymore, so you've got that. And so what they do is they get their budget, which is around about £3 billion, and they give their money to local authorities. So public health sits at local authorities, so it goes from the Health Security Agency to the local authorities, and then the local authorities pay back in to the NHS for screenings, immunisations, and all those other things that we may provide. So it's kind of a circular route. So we've got some more. So NHS Blood and Transplant. So I think so far all of these bodies have UK-wide remits. And then you've got the Business Service Authority, which was also mentioned. NHS Resolution is the litigation authority, or they administer the clinical negligence scheme for trusts, which is basically an insurance scheme for negligence, and then have a big public safety role, a patient safety role increasingly. So that's what NHS Resolution is, and you've got the Counter Fraud Authority. And then currently you have NHS England, though it is expected that in the next year and a half, 18 months to 2 years, that will be absorbed into the Department of Health and Social Care. And then you have NICE, National Institute of Health and Care Excellence. And you used to have Health Education in England and NHS Digital, but they've been absorbed into NHS England. Then you've got regulators, so as people have mentioned, CQC, Human Fertilisation and Embryology Authority, Human Tissue Authority, the Health Research Authority, and the relatively new Health Services Safety Investigations Body. So they are the arm's length bodies that are funded by that little blue bit at the beginning. So often what happens in the NHS is that governments will say we'll protect the budget of the NHS, but what they mean by that is they'll ring fence the budget of NHS England. And often what happens is that these arm's length bodies have their budgets cut. So whilst the budgets, the spending review had NHS England budget had a 3% on average in real terms increase, the overall spending, so total healthcare spending, was only 2.8%, because what happened was the other bits were cut. Okay, so I'm going to show this video. It is about 18 months to 2 years out of date. We're waiting for the new 10-year plan in hopefully the next few weeks, and then we'll make another video that's probably going to be out in September, October. But this gives you an idea. It repeats some of the stuff that I've talked about, but hopefully will give you a bit more information about how commissioning currently works, and we'll update it with the talk.
Fancy new razor, arriving today with Prime. That's off your...
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the spending review. which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. Create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and the ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Okay. So one of the things that has happened with the tidying up with the 2022 bill was they merged NHS Improvement and NHS England to form one body that's now called NHS England to look after the whole of the NHS, and they are going to be merged further into the Department of Health and Social Care. So you'll get all the slides and you'll get a link to the videos, this one and other ones that we showed today, in an email at the end. So you can watch it again as you wish. So as the video said, integrated care boards are the main statutory body that does the commissioning. Integrated care health and care partnerships provide more input on the wider impact of health and that interaction between health and social care. So the main things are there's a duty to collaborate. So you can put things until now. Commissioners had to put all commissionings, when they're commissioning services, they have to put it out to tender. So you have to invite bids from all these bodies and different organisations. Now you can do that, but only if it's felt to be necessary. You don't have to do it. You can. You don't have to put things out to tender. Okay. There is a duty to collaborate, and there's an increasing amount of joint appointments and committees to try and for people to work together more. Both both within the same sector, so within the acute sector, between the mental health sector, but also across regions. So one of the things that have happened in the last few months is that there's likely to be further mergers of the ICBs. So there's currently 42. The idea is there's likely to be 25 to 28 by April 2026. They're still deciding on which ones are going to be merging and which one's staying alone. There's lots of discussions going on, but they're going to have to decide by September this year to then formally be merged by April next year, is the idea. Again, that this is so to cut admin costs, essentially. The spending review, as I said, 2.8% real terms increase in total health spending, average 3% rise in NHS England funding. Capital investment is slowly increasing, but the big increases happened this year already. And then NHS technology funding doubles to 10 billion. So that's the kind of basics of the spending review. The finances have been confirmed, but essentially there's a big thing coming up in the next few weeks, hopefully, is that there's going to be a 10-year plan released. So there's two big reports due out at some point. So the first one that's likely to come out first is the 10-year plan, which is supposed to come out in spring, but it's been delayed, so it's going to come out imminently. They've decided on three areas to focus on: hospital community, sickness prevention, analog to digital, and you can see the objectives there. It's to cut waiting times. All things that I don't think any of these things are new concepts, so we'll have to wait and see what's the detail of what's going to be proposed. The other thing that's being the report that's going to come out is a Casey Commission, which is looking at social care and how social care reform needs to be undertaken. That will probably take a bit longer to come out, so looking at early next year. So that gives us an idea of how we can integrate health and social care to a greater degree. And this is what we're going to wait for before we do our next set of videos and animations to explain all this. Very quickly, I'm going to talk about payment systems in the NHS. So this will be reiterated in a second in the next talk, but the payment systems change massively. Not massively, but they change almost constantly every year. So they're slightly adjusted and changed every year. So what I thought I'd talk about is the building blocks. So there are 7 ways in which a organisation or a person can be paid for the services they deliver, the healthcare services they deliver. And every healthcare system in the world basically uses a combination of these different ways. So the first one is a block contract. Okay, so that's a lump sum to pay a specific range of services. So you base it on historical data, but it's useful because it's predictable. So the commission knows how much they're spending, the provider knows how much money they're getting. It's also really useful for areas that are difficult to measure. So community services are typically an area that's very difficult to measure activity, and it's also used for times of where there's issues in predicting. So COVID, we all were on block contract because it was too variable, and we needed a bit of stability. So that's where block contract comes in. The problem with block contracts is there's no incentive to do more. So if you're contracted to do 100 hip replacements, then if you do 105, you get paid no more money. So you don't get paid any more money. So you incur the cost of it, but you don't pay more. So there's no incentive to do more. And if you do less, then you don't get penalised. The commission loses out because they're not getting value for money, but you don't get any more. You don't get penalised for not doing as much. Okay, so block contracts, good for predictability, bad for actually incentivising to do more. Capitation is probably the most common at kind of regional level. So it's how ICBs get their funding, it's how health boards get their funding, it's how some of the how they're mooting how regional healthcare organisations will get their funding. And it's a lump sum payment based on the size and complexity of the population served. Okay, it's a weighted population, so it's adjusted for complexity. Now it's how you weight it that's controversial. And variable depending on, and different formulas are used for different areas. So the Cahill formula is used for the bulk of GP funding in the main GP contract, but that factors in age, distribution, so demographic information essentially, deprivation index, intensity of usage, rurality, so how far services are. So all of those are factored into the capitation model. Okay, so it has benefits, but it's controversial in terms of how that weighting works. Pathway of care was used in hospital maternity services, so it's a single payment for a whole pathway of care, as the name suggests, but it means you can have a lead provider that then subcontracts out different parts of the pathway. It was talked about and comes in and out of fashion on a regular basis, so I've included it in here. But essentially you get one payment for, say in maternity it was one payment for antenatal care, one payment for intrapartum care, and one payment for postnatal care, and there was different levels. The problem was that once you started on one part of the pathway, say you were low risk antenatally, but you became a higher risk, you didn't get any more money, or the organisation didn't get any more money in the pathway until you became intrapartum. So it wasn't dynamic enough, essentially, for you to be useful in that particular context, which is why it went out. But it may come back in at some point. So pay performance is kind of built into most contracts. So in GPs, it's a quality for outcomes framework, which can be up to 20% of your kind of main income. In the acute community mental health, this particular sequence are non-mandatory at the moment and only worth about 1%, 1.25% of your total contract value. It's a lot of money, but it's not mandatory to kind of get into the sequence. Per diem is not really used in this country. It's a lump sum payment per patient per day of care. you get more money for level 1, level 2, or level 3 care. So the most commonly used one, and the one that will be talked about later on in the coding bits, is the case-based. So it's payment by results, PBR, national tariff, whatever you want to call it. It is essentially activity-based. More activity you do, the more money you get. So you factor in the diagnoses, you factor in any procedures or treatments undertaken, and any patient comorbidities and characteristics that may affect how much the input that the patient may get, and you have a tariff based on that. And then something called HRG code, which is the Healthcare Resource Group, is what the tariffs are linked to. In mental health services, they are sometimes used for the tariff is based on clustering, though that comes in and out of vogue in terms of how well it's linked to payments. And then you get pass-through payments, which is where the cost of delivery is paid by the commissioning body. So what we have at the moment is the aligned payment incentive model, which is basically a hybrid of various aspects. So you have a fixed element, which is basically like a block contract, which covers the acute activity. So maternity, mental health, community and ambulance services are all done on this kind of fixed element based on historic data and kind of expected increases. And then you've got your variable element, which is your elective waiting list kind of type cases, because that's paid on a kind of as you pay a case-based activity tariff. So elective ordinary day cases, outpatients that have a procedure price, outpatient face first attendances are all paid on this elective activity-based kind of bit. And then you've got the third variable element, which if you don't achieve your sequins or you don't achieve your best practice tariffs, which are where you get paid a slightly higher tariff for meeting certain criteria, which are mostly quality indicators, then you get that taken away. And that's how most of the contracts that currently are. The low value market activity contracts are basically for often for outer regions. So if you've got an area of the country where you don't have many patients come from, then you might have a low value activity contract. So NHS payment system unit price. So there's the payment system. It's called the NHS payment system. It's a massive document that has a list of all the prices for various. It's where the tariffs are all documented. And so there are certain outpatient procedures that have a price attached to it, a tariff attached to it. So they are included in this elective element. Okay. So that is my very quick whistle-stop tour of the NHS in a nutshell. Okay, of how it's structured, how money flows through it, and a little bit how payments are made. As you go through the day, you'll hopefully build on this. There's different people come in and give you more detail on the different aspects of the day, and then we'll try and wrap it up a little bit with the business cases later on, and how you use all this information to build into your business cases. But any questions? Yes, it also means property service, but in this context, it's payment system. I'll hang around for a little bit, but I have a feeling some of the questions will also be answered by our next speaker. So Ansi Brown, Director of Finance and Strategic Commissioning for NHS North Central London, who I believe should be here.
Yeah, thanks. Okay, I'm on the line. Can you hear me?
Yes, brilliant. Thank you. I'll stop sharing. I will. When we send out the information, we'll send out some potential reading material and stuff as well that you can read up on that may be of benefit. I will see you later. I'll leave you in the capable hands of Anthony.
Thanks very much. I'll just put the presentation up on the screen. I'll also, like AK, I'm happy to take questions towards the end. I won't pause for questions as we go through. So if there's anything that you think of that you're unclear on, please pop it in the chat. I've also left my email address at the front of the presentation. I'm always happy to take questions or to direct you to colleagues in your local system if you don't know who to ask the questions to. And then, as always, with any NHS presentation, especially in finance, we've got a list of a glossary at the end with some explanations about some of the abbreviations, acronyms, and so on that I've used throughout the report. Just to kick off, I was thinking commissioning in the NHS at the moment. Every day you look at this, it becomes more and more out of date, given that we've got a huge amount of change happening within ICBs and across the NHS in general. I've tried to stick to the sort of high level facts at the moment. I think that's what colleagues will be interested in. I suppose the key message here is that things are changing on a relatively sort of week-to-week basis at the moment, and so commissioning and the ICB function in the next couple of months will shift towards a slightly leaner function. And in plain English, that means that we will have a huge amount of savings and a bit of a restructuring exercise, to say the least, to go through. We've got ICB or commissioning colleagues on the call. You will know how that feels in terms of actually some of the direction that we've got to follow and some of the targets that have got to be met. But I'll try and touch upon that. I've got a section on governance. We'll try and keep it relatively light because finance it can be really quite complex. I think I'm just trying to bring out some of the key messages here for you. And like I said at the top, if there's anything that's missing or anything you want to ask about, then please feel free. So to kick us off and maybe a slight bit of duplication with what AK took you through, this is what we tend to look at in terms of commissioning in more general. It works like an internal market model in terms of the money coming through from the Department of Health. As AK has already mentioned, it's received then by the ICBs, the commissioners, for pushing out to providers. So that could be NHS providers, it could be local authorities, it could be voluntary sector or private sector as well. And the model here, which I think is quite neatly represented by this commissioning wheel of how we go about decision making at a very simplistic level, puts the patients at the centre and then starts to think about how we can strategically plan throughout the course of a year, and then beyond that, ideally, for spending that money, that public money, wisely and making sure it's going to the right place at the right time as well. So you can see that it's a cycle year on year, much in the same that we have a cycle in finance. In a financial year, there is a commissioning cycle and a planning stage to that, a delivery stage, and then an evaluation stage as well. Moving on, I suppose the key questions are who on earth are the commissioners as well. There's three main commissioning bodies, and the parent body being NHS England. So NHS England deliver at the moment, or did rather, as of April, the majority of specialist services. A vast chunk of those have now been delegated down to the ICBs. So the ICBs received the budget and the responsibility for delivering a whole host of specialist services. So things like renal services, such as I suppose some of the HIV, MS services and so on would be specialist. And then a piece of work was conducted over the last year and a half to push services out to ICBs where appropriate, and to retain things in the centre where it made sense to commission them at a higher level. So you'll see that some of those have been retained by NHS England. Some of them have gone to the local hosts, the ICBs, for delivery. The next one down I put might be a surprise, but the local authority is also a major commissioner here as well for services that your trusts or your practices might be paid by local authorities for services it delivers. The majority of these are screening services or things like health visitors and school nursing that have moved over when the PCTs disestablished and public health moved to the local authorities. So you'll see that local authorities have got obviously a role within healthcare in terms of supporting the function of the NHS, but equally then some direct commissioning responsibilities as well. And then we've got the integrated care boards who basically mop up pretty much everything else then that isn't in the two boxes above. So responsibility for all other healthcare services, so primary care to acute, mental health and community services. And then as of April 2023 took on dental, optometry and pharmacy commissioning as well. So essentially the vast majority of the commissioning is done by ICBs, and therefore the money that flows is sent to ICBs, and the commissioning responsibility and the way the money is spent then sits with the ICBs, and they form part of the integrated care system that provide us it on. So moving to the next slide, I'll just show you all of this at once so you can just see the model. This is governance. We love governance in finance, don't we? So it's given some structure as to how there's control and oversight. The majority of that is done obviously by NHS England alongside CQC, and then we've got the two sort of statutory systems within that the ICB forms part of. So we've got the overall role of the Integrated Care Board, which is simply put like a system convener. It kind of sits at the middle of the system and starts to pull all the different strands or providers together, whether that be NHS, local authority or GPs, and makes decisions and strategic decisions at that on where funding flows and how services are delivered across a particular geography. The ICP or the sort of wider committee is a bit more strategic. To be quite frank, we see the majority of the terminology now referring to an ICB or a board, and that sort of the ICP is a slightly wider selection of people that make up the local system. So when I'm talking about this this paper here, it's mainly about the ICB. So if you think about the bit that sits in the middle of the system and starts to support the convening and where the funding flows, it's probably the easiest way to imagine that in your head. Oops. And I've got, I won't show you this, I'll send it around afterwards. It's another King's Fund presentation about the NHS and how it's changed over the last couple of years and how the funding is flowing. I know that AK has already shown you something relatively similar, so I don't want to repeat what he's shown you already, but King's Fund is always really quite straightforward and simple at explaining complex matters like this. Just encourage you to have a quick look at that then afterwards. I'll move on then a bit to the journey of reform, and in the NHS, if you don't like change, then you're probably better off working somewhere else. So this is only going back as far as 2013, and it shows the fact that PCTs then were disestablished and clinical commissioning groups were established then. I guess what it's actually pulling out for me is that there's not very many years where we haven't had either a current government or a new government come in and think that actually a reform is required. Often it is actually required because it's the NHS is currently or constantly rather learning from some of the lessons from the past and making sure then that new legislation supports pressures and the strategy of the NHS going forward. I think the latest one we've had before the current reforms was in 2023 from Patricia Hewitt, who looked at the ICSs, the system in general. Obviously, you no doubt all well aware that we're waiting for a 10-year plan now as well. So in finance, the important thing with a 10-year plan is that we get some certainty about what we're supposed to be delivering, and more so about the money and what that's looking like over the next couple of years to help us with planning. And then equally so, trust finance colleagues, primary care finance colleagues and so on, across the system will find it important then to use that information then to plan about their longer term sustainability and some of the priorities that they need to push money out towards as well. So it's helpful having direction obviously from the centre, clear direction is absolutely a must, and I think the key part of this then is how do we get that right as an overall system as well. So the latest information that we've got from the blueprints that have been sent out around the functions of the ICBs in future tell us that there's going to be potentially a shift of how some of that's being delivered. I think all will be revealed in the 10-year plan. I think the important part is that we're seeing a shrinking of the ICBs over the next year or so, and then much more of a move back to strategic commissioning. And I'll try and explain what that means as well over the course of the next couple of slides. So just to kind of give you a bit of a view of how on earth the ICBs come together first, before I get into a bit more of the detail. Each of the different systems across the country then are governed by a separate part of NHS England. It's nicely colour coded here, so you can see down in the sort of burgundy colour, red colour is London, and that's my patch number 8. That's north central London. So a small part of the country, but commanding about £3.5 billion worth of national funding. So obviously an awful lot of activity in a small footprint. The other areas then outside of that, obviously different geographies have got different numbers of local systems, and if you count up here and see that it comes to 44, you think that would be the number, but because we're changing on a sort of a month-to-month basis at the moment, and we're consolidating systems within one another, some of those systems then will form slightly larger geographies that are responsible for the overall delivery and funding of its local population. So I think at last count we had 40, and then I dare say that this moves to shrink that number down again, so we can push, I think, more and more of the money out into frontline delivery, but equally then we can start to move ICBs towards a more sort of strategic commissioning function. So I think all of the 4 aims are still true, even in I'm fairly confident, he says, that next year we'll be saying the same things apply to the ICB, in that population health and outcomes are the absolute mandatory must do here. Productivity and value for money will always remain a sort of a golden thread throughout that. So much of my work at the moment is looking at how we're doing in terms of productivity versus pre-COVID, and then year-on-year recovery, and equally then how do we start to address things like backlogs in patient waiting lists, the money goes to the right place within the system, so we know that we need to pull more money out of acute and push it into prevention and community and primary care services, and then the sort of broader role of the NHS within sort of prevention and long-term condition management, and the overlap into things like housing and socio-economic factors that drive patients' ill health. So lots there, but I think in terms of actually the future role, not much changing from those 4 key aims. And if you looked at any ICB's sort of operational plan on a page, you'd see something similar to this, and I've just pulled out the fact that it's still saying the same thing as it would have done previously. Prevention is the key aim, as is population health and integrated care, about how the funding should be managed across any system. So you'll see that most of the discussion at present isn't so much shifting about what the ICB does. It's refining some of that, moving us back into much more of a strategic commissioning role. So that's a plan on a page for an ICB, showing you exactly what's expected in its core function. And then if you looked at the alignment with national targets, and most of these, I think if you pick up any newspaper or go onto the BBC website, you'd immediately see things that would be completely familiar. And alignment between the ICB and the national targets is obviously an absolute must to make sure that we're delivering that sort of the national targets of obvious areas such as waiting list reduction, A&E response, management of ambulance services, through to sort of the empowering and correct management of workforce and productivity levels. So the alignment part of it and the importance of the 10-year plan is obviously quite clear to see. That national direction gives us all within ICBs the steer about where priorities lie, and then how we actually push money out to support those priorities. I'll do a little bit around then how some of that works. This is relatively high level, so please bear with me. It's just giving you then a bit of a feel for how each of the different parts of strategic commissioning work. And broadly speaking, it's separated into a few different levels. So going from bottom up here, the system level is where you've got the overall integrated care system. So you think back to the map of the UK I just showed you previously, all of those different colours are the different areas within a particular geography, and then the ICB will sit in the middle, like the hub and of each of those different geographies. So in London we've got 5 different ICBs, and that's at the system level. Each ICB represents a particular geography. So in North Central London, it's made up of the 5 London boroughs of Camden, Islington, Enfield, Barnet, and Haringey, and we've got the responsibility then for delivering care and providing healthcare services for that local population. Going down a level then after that would be the local authority areas generally. So it would be, for example, the London Borough of Camden's would sit within that place level, and obviously within in place, and then down to neighbourhood level, you've got different patchworks of healthcare needs, clinical needs, long-term conditions, and so on that need slightly different weightings of funding and services to follow. So the way we go about our strategic commissioning is to make sure that we've got as much data to inform where healthcare needs need to be delivered, and then obviously the money to flow and support that. The most important one at the moment, or the one in vogue at present, is neighbourhood work. I've got the other 2 mentioned here as well. Neighbourhoods, if you've not gone into some of the detail here, are more about the very sort of local commissioning level. So making sure that we've got a network of healthcare professionals and organisations that can provide the most appropriate care in the right setting for a particular geography, and it tends to be a part of a local authority, if you like, a very, very smaller level. It tends to be clustered around primary care networks as well. So you'll if you're in primary care, you'll be part of a PCN, and you will have hopefully heard of PCNs previously if you're not in primary care. It allows essentially local healthcare providers and GPs to make sure that they can flow funding and services to the most appropriate level at their locality. So the lowest level being neighbourhood, and then obviously scaling that up, you've got place that I've mentioned before. So it's much wider, and you start to bring in things like district general hospitals and more sort of council-led services. And then finally, after that, we have the system level as well. I often find that most of this is much easier to explain with real life examples. So just to expand on what I've told you previously, this is my local system, so North Central London, where I'm Director of Finance. So I would obviously point towards the fact that we've got a huge amount of, or a large amount rather, of internationally renowned healthcare providers here, and this is just the NHS providers on the patch. So organisations such as UCLH, Moorfields, Gosh, and so on, Royal Free, make up our geography, and we're responsible then for making payments to those organisations for the patients that access services within those trusts. We're not responsible for making payments for patients that come from other parts of London into those trusts. So you'll see in a minute the complexity of how commissioning works. So we don't pay Royal Free's entire bill. We pay for the North Central London patients going there. And equally, we also support primary care community services. So we've got various different community providers here, Whittington, North Mid, and obviously the local authorities as well, providing community services for the NHS as well. And then beyond that, the optometry and primary care and dental services fall within this patch. So I didn't want to make it too complicated, but it shows you the number of healthcare providers in a single system, especially within London. And as you obviously move outside of London, you might have a unitary authority where you've got one or two different provider trusts and 1 or 2 different community trusts, but it all operates exactly the same in that you will the ICB will pay for the population, its local population accessing those services. This shows you in London how complicated it gets, but it gets complicated across the entire country. And I don't want to be massively any more London centric. I'm just using the stuff I'm familiar with. But you can see, obviously, larger organisations suck in patients from outside the patch. So you've got specialist providers in particular on your patch, or larger providers, and people will travel from outside of your particular system into that area. And so out of the £3.5 billion that we have within North Central London to pay for our specific residents accessing healthcare, there is actually 5.6 billion that flows to North Central London Provider Trust. So you don't have to be a genius to work out that 5.6 billion is bigger than 3.5 billion. So all of the other money that flows to those trusts is from either outside the system, so patients coming in from elsewhere, even overseas patients, and also from services that are provided by the likes of the local authority and NHS England for specialist services as well. So it shows you the complexity. It shows you if you're sitting in a trust position, how complex it can get. In primary care, likewise, you've got several different commissioners. And the model is supposed to work by, and then obviously each commissioner being responsible for its local patient population. So, and a complex system, I think obviously within an internal market, it's supposed to drive value, supposed to push the funding to the right place, but then equally make sure that it's being delivered in a productive way. The problem, if you see it this way, and this is the way that the government see it, and this is what we're expecting from the 10-year plan, is that we're going to be given 3 main targets to hit. One of those is moving from analog to digital, which is probably no surprise. The NHS needs to push itself there to move away from paper and I suppose make sure that it's on the journey towards using all of the technology at its fingertips to enhance patient care. But then equally then we need to move away from treatment and into prevention. And I think, we've been saying that for a long time, but it will be front and centre of the 10-year plan, and likewise away from acute delivery into community services and so on, so the right care in the right place, essentially to make sure that we actually don't push the growth within the treatment sector so much that it becomes unaffordable in the long term. So the NHS is slowly moving towards longer term planning, and it's a big surprise that we don't do 3 to 5 year plans every single year. We're moving towards that now. And then likewise, I think in terms of actually having assurance on how the funding is flowing, will obviously enable systems to start to think about, right, well, if I'm going to get X amount in 3 years' time, I can start to plan what that looks like for my local system. This pie chart shows you the fact that the majority of our funding then in North Central London flows to acutes. It doesn't always represent the right place for delivery, of course, as I've mentioned already, and I think that's the challenge back from the centre. It's obviously just paying on a cost per basis, generally speaking, and we're moving more and more towards the old way of actually counting spells of care and paying for those, again, to try and get this right. I think AK mentioned the fact that we've got an awful lot of block contracts as well. They tend to be sat within mental health community, and there have been moves in the past to make sure that funding goes to the right place. But the work happening in terms of the planning round at present is moving as much more towards trying to understand actually how much each spell of care costs us in primary care, community care and mental health, so we can start then to compare how well public money is being used and where it should be going as well at the same time. So historically we've only really counted on a cost and volume basis, on a per spell basis, acute care, and paid for it on that basis. During COVID we moved to a block format, and now we're starting to move away again back to counting spells of care, and we're also trying to stand up community and mental health counting spells of care as well, so we can understand actually where the greatest need is. But the challenge for most systems is how to get the big chunk of acute funding out and pushed into the prevention and community mental health and primary care elements of this pie chart. So trying to change, I suppose, essentially how the percentages work. And then in terms of how we do that, so in finance, we love controls. As I've said, we like some structure as to what we're doing. Over the past couple of years, we've worked really well, especially in North Central, to form system returns. So that will be all the different NHS providers in a particular geography working together to come and land a collective bottom line of financial balance across this overall system. The principles that we use in our geography is that we've got transparency there, that we're all working to a single goal, and that we're holding each other jointly to account on this. And essentially how that works is that each of the different partners within a particular ICS system is given a financial target and submits that collectively back up to a system control total, and then back up to the centre, so we can have at least some alignment about what each of the different providers are doing and any kind of challenges that they're facing throughout the year. And that wasn't a thing about 10 years ago. It was lots of different organisations working individually, and you can see the problems with that you will have overlap, you will have pathways that don't particularly work for patients or work for the finances as well. So system alignment won't go away. Who delivers it might change slightly in the future, depending on what the 10-year plan is saying. I won't go through and bore you with all of the different regulations that we follow. The most important one here is financial balance from a finance perspective, and making sure that we hit that. I think from a clinical perspective, there are other targets rather in here. So one of the ones I look after is the mental health investment standard. So making sure that mental health services grow at the same rate as physical health services is massively important in terms of pushing us in the right direction that I've talked about with that pie chart, but equally making sure then that that funding is invested efficiently and in the right place within mental health services. So we do have clinical and financial targets to hit, but the most important financial target that we have is the statutory break-even duty, and that's on a system and a local basis as well. Beyond that, then this is the if you like the naughty step, and how that oversight that I've talked about at the start can land you either in the direct gaze of NHS England's oversight, or can keep you well away from that and allow you some more local flexibilities. Essentially, we've got 6 different delivery target areas. It's slightly changing with the new 10-year plan coming out. But in essence, the one that I've already mentioned is that is around finance and use of resources. You can just see, obviously, the importance of each of these different elements within this box. And no doubt a lot of them will be familiar to your day job in terms of actually how NHSE come in or CQC come in and provide some assessment of how well a particular system is doing, and then give you a score on that basis. And the scoring part of it is on this next slide, where it ranges from 1 to 4, being 1 and 2 really the best and not requiring any further system intervention, or NHSE intervention rather, to 3 to 4, which is showing, for example, in finance, where you're missing your plan by a large amount, or there's serious or clinical concerns that require a greater level of intervention. And obviously, to translate the word intervention, it will mean that NHS England will impose additional controls and expect to see improvement plans and so on to get you back on track. And that can sometimes mean actually not being able to spend money up to a certain amount, a lot more rules and regulations in place to ensure that balance and realignment of clinical requirements are addressed. And so you can see the importance of trying to stay on the right side of this assessment criteria. And the majority of systems obviously will find themselves between 1 and 2, and 3 and 4. If you've been in a system there, you will have experienced some of the turnaround plans that are required. So that's the last slide. I haven't, as promised, that I've got the glossary and jargon buster here to kind of give you a bit of a steer. Like I said, if there's anything else that has popped up, then I'm happy to take questions. I'll just take the report down, and I'll pause there for a minute in case anybody wants to ask me anything in addition. I don't know where we started from. Okay, hang on a second.
Thanks, Fancy. I think there's a couple of questions in the chat. So about patient choice and how funding works in relation to that.
Yes, yeah. So that's Lucy. Yeah, Lucy, I suppose for with a rigid organisation like the NHS, it's really difficult actually. But we can understand obviously the importance of patient choice. And so what's happening at the moment, I suppose, to give you a kind of a flavour of how it works and then what it means for each different system, the money will need to flow to the right organisation, essentially. So patients need to have the ability to choose where their healthcare services are provided. It's slightly simpler with NHS organisations. So, for example, if you're so if your patient would normally go maybe for optometry in Nottingham Hospital, and they choose to actually go for Moorfields instead, then what would happen is obviously the clinical assessment would take precedence over everything. But then if it was available, the patient could have their services being delivered by Moorfields. All that would happen then is that in terms of actually the service, if it was an elective service, the local ICB in your patch would pay for Moorfields for that service. So Moorfields would deliver the service, and then your local ICB would flow the money to Moorfields. If it was a non-elective service, this is nice and complicated, isn't it? It's in a block contract at the moment, but it will be, I think, as of sort of future years, be moving to the same as elective, in that you would pay per spell of activity. So in its simplest terms, you move the money. If the patient goes to Moorfields, then Moorfields will expect payment for that particular patient. It gets slightly more complicated when you've got private sector organisations also wanting a conversation with us about providing services for our patients as well. So they need to obviously go through a process of scrutiny and checking whether or not they pass different criteria to be a recommended provider in the first place. And then the difficulty you can see, and I think AK mentioned this already, is that if you block an awful lot of money in a particular organisation, or if lots of your money is going out and it's stuck somewhere, then if you start to pay somebody else for services outside that block, you can't just say to Nottingham or Manchester hospitals, actually, we're not going to pay you for the block, we're going to take that money out and pay for the private sector operations. It doesn't work like that. It's on a year-on-year basis, the block. So the difficulty is that patient choice, I suppose, presents a bit of a challenge to finances and the way that the NHS is set up, but we're slowly moving back to something that will allow us to be, I think, a little bit more fluid. What that will mean, obviously, is that there's a little bit more risk passed to the providers there, because there's a bit more uncertainty about how much funding will flow to them. And the greatest thing within finance and with any kind of organisation is certainty on the money flowing through. So it's a challenge. There are rules at the moment that help us move the money around the country, and it should slightly improve, but it's still a management of risk, making sure that patient choice isn't delivered in the right way. Shall I just go to the next one? Okay, there's something about NCL financially planning for the impact of climate change adaptation. Yeah, so South East London ICB. Okay, right. So James, I could probably talk to you about this afterwards, because you're not too far away from me. So we all have so within ICBs, but equally within trusts as well. I'm sure you've heard of challenges around green agenda and making sure that we're spending funding wisely, but equally we're cognizant of our impact on the environment. Each trust has put in a green plan as a system as well. We've got to do likewise. I could probably go into that in a bit more detail, I suppose, afterwards. There's often efficiencies as well to be found within that work. So finance gets involved in that as well to make sure that obviously from an environmental and financial impact point of view, we can have the greatest amount of efficiency delivered there. So we will have a green plan separately as well that I can share with you. But yeah, Southeast likewise will be part of, I'm sure, a sort of a London-wide piece of work around that. So I'm happy to pick that up separately with you afterwards. What does strategic commissioning mean exactly? That's a really good question, isn't it? So strategic commissioning is, I suppose, at the heart of it, the ability to manage population health, to have a particular sort of strategy around care pathway design and how patients access healthcare, and then beyond that, it's the tools to actually deliver that. So I suppose the mechanisms and contracting, and that the ability then to make sure that all of the framework is in place for patients to move to the appropriate place for their healthcare services to be delivered. And you can see that the majority of that is going back to that big commissioning wheel that I showed you at the start, is looking at data, looking at health inequalities metrics, looking at changes in patient flow, in patient need, and then using that data and the cost of that data and the activity then to start to deliver a model that will be sustainable over the next year, and then beyond that as well. So strategic commissioning goes from, it can be from a 1-year cycle to a 5 to 10 year cycle as well. And to think of a particular example that we've got in North Central at the moment, we know that we've got a transfer of services from specialists for renal. We know that we've got massive problems in terms of renal services having the capacity to support patients coming through, and we're looking at the future years of renal delivery and thinking, well, this is going to be either unaffordable or unsustainable from a clinical perspective. So how do we make sure that before patients get to a point where they need high acuity renal services, that there are preventative services or local services in place to stop some of that actually happening? So it's an awful lot of modelling from current data, making sure then that we're taking the right interventions now ahead of sort of 5 to 10 years time, and putting services in place or standing services up and making money flow to the right part of the system in order to strategically commission the services in the right place now, and then having safeguards in place if things do happen, and if those if the interventions don't happen at the current point, how do we make sure that services are sustainable in future at the acute end? So really quite complex, and if you think about the commissioning wheel I showed you at the start, it's really driven by the data and what the data is showing us and the modelling about what's happening in future. So I hope I haven't confused you with that, but that's what I would say in sort of a 30-second précis of what strategic commissioning is. It's looking into the future and trying to use the current information to make sensible decisions around healthcare and where the finances flow.
Thanks, Anthony. And a very, very quick answer, if you could, on are you allowed to prioritise your patch if there's pressure on your services, i.e. reject out of area referrals?
No, short answer is no. You can't do that, and so we don't prioritise anything from a financial perspective. So we don't expect clinicians to say, to use the earlier example, you're coming from Nottingham, so therefore you can't access your wet AMD service at Moorfields. You need to go back to your local provider. That it can't happen like that. So all waiting lists are agnostic to where patients are coming from entirely. So you can't prioritise your own local system. What you need to be doing in that case is just making sure that you're commissioning appropriately. So all the decisions you're making with where the money is going, therefore becomes really important, because you don't have the control in that respect about throughput of patients. And as I've said at the top, the patient sits at the centre of everything we do, even in finances. So we can't pick and choose on that basis. So difficult to manage, but at the same time, we can't prioritise things like that. It's down to clinical decision making.
Thank you, Anthony. So I think we're going to have a break, short screen break now. we're probably running a little bit behind, so we're going to just reduce it down to about 8 minutes, and try and start back at 11:10. Would that be all right with you, Sue? To come back in like 7 minutes, and then we can get back onto. We'll only be running 10 minutes late then. So a quick screen break, and we'll come back with introduction to procurement. So we're going to hopefully move on to introduction to procurement, and we've got Sue Colbeck, who's a senior procurement lead at Cheshire and Merseyside NHS Foundation Trust, who's going to give us an understanding or better understanding of what procurement is and how it works for our organisations. Is Sue there?
I am here. Can you hear me okay?
Well, yes, brilliant. Thanks, Sue. Over to you.
Fabulous, thank you. I think you're driving the slides for me this morning, so I'll let you know when I need to move forward. So if you can move to the next slide for me, please, and I'll just give you the overview of the objectives for this session. Thank you. So good morning, everybody. My name's Sue Colbeck. I'm the Chief Procurement Officer within NHS Cheshire and Merseyside, and I lead on the at-scale procurement across our ICS, which consists of 17 organisations. I've been in procurement personally for 27 years, covering both private and public sector, but I've spent the last 17 years in NHS procurement, either at a local, regional or a national role. The overview of today is obviously just to understand what procurement is and why it matters, learn a little bit about how procurement is regulated, explore how it works locally for you, and some of the routes to market. I want to just give you a very quick overview of value-based procurement, and then finally just exploring funding opportunities around medtech, especially around when procuring innovation. The presentation today is in the context of procurement within an NHS trust as opposed to my role within the ICB, but I will cover a little bit of health procurement off as well as we go through. Next slide, please. Thank you. So procurement is integral to the treatment of patients across all healthcare settings, whether it's a stationery that you use on a day-to-day basis, or any of the medical equipment and consumables that you would use to treat patients. And behind anything that you're using or that you're consuming will sit a contract that's been negotiated by your local procurement team, and that's working very closely with clinical colleagues to ensure that anything that we are contracting and we're committing to is fit for purpose and will deliver value for money. Procurement directly contributes to the bottom line. Teams work tirelessly behind the scenes to ensure that you've got a robust supply chain, so very much that your goods come in when you need them, and obviously they're replenished accordingly, and that will be based on the logistics of your local hospital as well, because they do differ greatly. They will source alternative products for you during supply chain disruption, and they will support you with any of your supplier contract management. Next slide, please. So there's been significant change to UK legislation governing public procurement since the introduction of the provider selection regime that went live on the 1st of January 2024. And changes have affected more than 25,000 public sector procurement professionals across the UK. So biggest reform, and obviously largely driven through EU exit. Your trust will be governed by your local standing financial instructions, and you will have a scheme of delegation that sits behind that in terms of who can raise requisitions, who can approve spend for your budgets. And procurement manage these systems, and they'll approve the purchase orders that are sent to the suppliers subject to your local hierarchy. The key changes in both sets of legislation around the Procurement Act, which went live in February this year, they replaced the Public Contract Regulations 2015, but both sets of legislation are still in place, and I'll touch on that a little bit later when we're chatting about routes to market. But the key change in both of these is around transparency. So there is a requirement to ensure that we publish pipeline notices. So we're indicating to the market what our requirements will be in future years. The risk of not engaging with your procurement team will be a failure to award a contract down the line, which will be a risk of reputation, supplier challenge, duplication of effort and lost resource costs. So all I would sort of encourage is, if in doubt, contact your local team, let them know what you're planning to do. And they will walk you through the process. And as always, the more planning, the more time we have, the more we can support you to get the right outcome. Next slide, please. So this is a really high level sort of indicator of what steps are involved in a procurement process. And you will have local policies and procedures which will be very detailed about what your local team and how they'll want you to support any of the future procurement work. But initially, for us to do anything, we need to identify what is the clinical need. Is this a re-procurement of a contract, or is this a new investment case that's been approved, whether that's we've got capital funds to buy new scanners, or we want to re-procure the hip and knee contract. Whatever it will be, we will identify that need together. As I've said, engage with procurement early. Your local teams will be doing multiple year future work plans, so this should already be on their radar. And choosing the appropriate route to market, which I'll touch on a little later, and that can be around whether what I would call a published tender would be issued, or whether we would use an available framework. And there are pros and cons to doing both, and there are timescales associated with all routes. Then obviously, once the route to market has been chosen, even if that's a mini comp under a framework, procurement will work with you around your evaluation criteria and your award criteria. And then subsequently, then once that's been awarded, subject to your local governance, procurement will support you to manage your contract. Procurement is an enabler. They're not there to obviously do it in isolation. It's very much about working together with all clinical teams and also with finance. Next slide, please. So as I mentioned, there are some common routes to market. NHS supply chain, I think most people will be familiar with. You'll see the wagons that will most likely be coming into your trusts on a day-to-day basis. And again, there'll be, if you've got what we call materials management teams that sit on ward areas, they'll be managing your replenishment on a weekly basis, and those are the goods that get delivered. Most trusts will have a daily delivery, but obviously that'll be scheduled to deliver to different departments on different days. And supply chain at the moment, certainly within my region, for general medical consumables, 70% of what we buy is purchased through NHS supply chain, but we do have some direct purchases outside of that. In addition to that, you have procurement providers who support NHS trusts in setting up national frameworks. So Crown Commercial Services being the main one. You've got Shared Business Services, which is a quango between the Department of Health and Sopra Steria. And then there are NHS services as well. So you've got East of England, North of England, London Procurement Partnership, and the South of England as well. And then there are some private providers on top of that. There's a lot of work happening with NHS England at the moment in terms of streamlining, so making it easier for suppliers to buy from the NHS, in terms of selling to the NHS rather, and where we've got duplication of frameworks, there is a recognition that potentially we've not optimised routes to market, and we've made it difficult for SMEs to bid for contracts in the NHS, and therefore there's lots of work in the background to address that. In addition, we've got direct awards and, as I said, many competitions that will happen under your frameworks. But at the moment, with the new Procurement Act that's been published, the aim is that it's more of a competitive, flexible approach. It was 4 lots of legislation that was morphed into one UK procurement legislation now, and with the aim of what we've struggled with previously is buying innovation. So there is now the ability to go to market and actually design a tender process whereby you can even specify an output-based specification, but prototypes. You can have prototypes designed, you can test it, change your spec, reissue it before you obviously then commit to a long-term contract. So I think government have listened to the needs of suppliers and the needs of certainly the NHS, and there are now mechanisms that are built into legislation that enable that to be more streamlined than it has been previously. There are differences, so there's tender thresholds that we have in place as well, so just something to be aware of. Again, this will be defined in your local SFIs. They do differ from trust to trust, so if you have moved organisation recently and you have been privy to procurement, just check your local rules, they may be slightly different. So, for example, an NHS trust is classed as central government, so therefore your threshold in terms of publishing notices is £12,000, so really low, and that has created a lot of administrative burden for your local team. But an ICB, so myself, we're classed as non-central government, so mine's higher at 30k, still low, but the differences of what we can do up to those thresholds make a difference. And then in terms of what we call a published tender, so if you're not going to use a framework and you want to go out to market, then in terms of when we need to publish that in the I'm trying to think what that's called now, it's changed names since the new legislation, but it was the old ODU notice. Effectively that'll be anything over £214,000 excluding VAT, so again not very high. In between those two thresholds, again, your local SFIs will detail how you can procure. So some trusts will still issue a tender, but they can determine which suppliers they invite to that competition. Whereas within the ICB, anything between our threshold of 30k through to 214k, it's a 3-quote process only. So we've simplified the process, and as again we publish that, and obviously we're open to scrutiny as is anybody else. And then anything below those lower thresholds, it's just be proportionate. We always say, you know, I think some trusts again will say as long as you get a quote in writing, that will be fine. We always insist on 3 quotes again because we've got to demonstrate value for money, but it's proportionality that's the key there. Next slide, please. So when a contract needs renewing, or as I said earlier, it could be new investment that's been granted, procurement will work with you to identify obviously the requirements. So specification of requirements, think about output-based specification. What is it you want this contract to deliver? So there's been lots of case law, particularly under the public contract regulations, that has demonstrated time and time again that it's all about the specification and getting it right. What did you intend to do, and just being really clear on the messaging. Think about what's essential, your must criteria, should and could criteria, rather than a heavily based input-based specification. Input-based specifications tend to limit the number of suppliers that are going to bid, and potentially you run the risk of being challenged. And we would always say avoid, if at all possible, but avoid using brand names. If you can't describe it in any other way, then you can typically say, and we want it to do, you know, such and such as in the case of, and then specify, but always maybe add the words alternatives available will always be considered. You never want to fall foul of that, and again there's lots of case law where that has happened. And procurement will work with you again to establish your evaluation criteria, typically sort of 60-40, 70-30 split, heavily weighted to your quality-based criteria and cost-based criteria. But again, it depends on the marketplace. It depends on whether you've got an open market that's, where it's flooded, stationery supplies, for example, you'd probably just go, 90% cost on that. But anything else that's more specialised, you would probably aim to weight that more quality-based. Next slide, please. So just to give you an introduction to value-based procurement, or as I refer to it as value-based healthcare, this focuses on best outcomes and total system value, as opposed to, I'm just going to go and buy an MRI scanner. So it considers the patient outcomes and cost efficiency. And as I just caught the end of the previous presentation, value-based healthcare supports population health and sustainability. So when the slides are circulated to you later, there's a couple of links there that you can go and have a look at some case studies. And the YouTube one in particular is around a patient story case study that was based at Wirral Hospital. Again, I think I'm coming on to it in the next slide, but there'll be quite a bit of information on that one. It's great to hear from a patient when, again, we've worked on a process and that describes the changes to their health, their personal health outcomes, and it's a really powerful message. So this for me is the future of procurement. An example of my time at NHS Supply Chain, I was responsible there for procuring the frameworks around diagnostics and consumables, and in particular, a supplier approached me with a redesigned urine collection system for women. So there was evidence at the time that suggested there was a high number of repeat tests, particularly around obviously maternity, where there were a number of tests going through, but the actual sample itself was contaminated, and it was typically because of the way the actual sample was being collected. So this was in itself a product that was around about 30% more expensive than your typical urine collection pot that you get at the hospitals. But the evidence suggested obviously cost of repeat tests, there was unnecessary medication costs, so the delay in obviously that sample being tested meant that a patient could be on inappropriate medication or actually just medication for too long because the sample wasn't tested in a suitable time. And again, that when we had a few trusts that trialed that product, there was evidence that suggested over 40% savings across that complete pathway. That was back in 2018, so I am going back some years. What I struggled with as a system leader then nationally is actually the adoption within all NHS trusts, and the main reason for that unfortunately was financial, because we didn't have a sort of a savings methodology that we could evidence to finance to obviously state what those savings were. And again, there's been lots of work on that since then, and we've now got a published methodology that that supports this. But that's sometimes the problem is somebody looks at a unit cost as opposed to a whole pathway system cost. And that's where obviously we lack the adoption for innovation in some cases. Next slide, please. So as I mentioned the link on the previous slide to the YouTube video, and that was related to it's a footwear, and it's the APOS device, and it's funding that was made available via the MedTech funding mandate, which our ICB embraced and obviously asked our trusts to look at ways to implement. So Wirral University was the first hospital, or one of the first hospitals that trialled this across 50 patients, and you can hear all about the patient story in the YouTube video. And again, in terms of that particular that particular case at Wirral, what the evidence suggested is for the patient, so it's early stage osteoarthritis. Obviously, the patient's significantly struggling, but not enough to warrant an implant, a knee replacement, for example. So what the device does in terms of, and I'm not clinical by any stretch of the imagination, but what I know it does in this case is it adjusts the gait of a person when they're walking, and in some cases it delays the need for invasive surgery by 3 to 5 years, and in some patients it mitigates the need for invasive surgery completely. So again, that's just another example of how a product innovation can come in. Obviously, we can support it through, because it is obviously a costly product that wasn't in the initial funding, but we can prove savings throughout the system. So medtech funding, support uptake of cost-saving proven technologies. It's all about the evidence, and again about accelerating access. And there's lots of programs out there that do this. So again, just to guide you to finance and procurement colleagues about how to access these funds when they are made available. Next slide, please. So I think just some general tips when we're buying clinical goods and equipment: early engagement, evidence-based decisions, the total cost of the ownership, so that value-based healthcare that I've just been describing, compliant routes to market, and then obviously, as I mentioned earlier, avoiding brand-specific specifications unless there is a justification for doing so. I think that most trust teams will have buyers, whether they're in med-surg, they're in estates, diagnostics, whatever it might be. So hopefully you've already got a procurement business partner that you're working with that's familiar with your departments, your needs, your requirements. And if not, reach out, because I'm sure they'd love to have a conversation with you, and then you can start to plan future work plans jointly, as opposed to the annual budget round when generally the work plans are designed. So please do reach out. Next slide, please. So what you can do is understand your local needs, define the problem and the desired outcomes. And I say that with a note of caution. Think about outcomes as opposed to desired suppliers, because we have to be open and transparent. Share clinical evidence and best practice. A lot of my work plan across Cheshire and Mersey ICS is actually based on some of the great work that happens within in a trust, where they do a case study and then we look at how we can adopt that across the system. Collaborate on the evaluation criteria and the implementation. So procurement isn't just about the cost of the contract. There are generally other costs associated within your trust, and that's around implementation. So if I take an example of a recent digital system that we've adopted across our ICS, so we've got a PAN lab information management system that we're implementing currently. We got some national funding, and the supplier was aware of how much that national funding was awarded. And interestingly, through pre-market engagement, the supplier was given indications that it was going to be the full funding that would be the cost of their contract. The cynic in me says that's interesting. That funding was supplied for programme costs, including all of the implementation, any local changes we needed to make to our technical infrastructure, as well as then the cost of the contracts, the cost of the LIMS system. So again, it's not just the cost of contracts, there are other hidden costs. So again, just be mindful of that when you're designing any processes. And I always ask about value and innovation. In fact, procurement should be asking you that as well. You're at the forefront, you're absolutely close to the needs, you're the ones that are using the products and the equipment. So if there's any feedback at any point in time, you think, oh, wouldn't it be nice if this did that? And then, especially through your contract management, this is where we get into strategic contract management, that can be passed back to suppliers, and we can help to, in some cases, innovate new products and services. So it's always about communication, isn't it? So make sure obviously you're well stitched into that if you're not already. So final slide, please, and then I'll open up for any question and answers. So there's lots of evidence to state it's not just a statutory responsibility, but good, effective procurement supports better care and outcomes. There is a direct link. The legal frameworks that we work within will ensure fairness and value. Value-based procurement is the future. It's not just about buying widgets from a catalogue. It really is understanding the total cost of ownership. And then collaboration, again, brings better patient and system results. So I'm going to close there if you want to close the slides down, and then I will happily take any questions.
Thank you, Sue. That's great. I think the one question we've had so far is, should each ICB have a system-wide savings methodology? That's from Helen.
Thank you, Helen. So there is actually a national savings methodology that's available through NHS England. So I'll put that in. I'll put the link to. I think you can access it, but your local teams will definitely have access to it. But I'll put the link to that in the chat afterwards. So there is a national methodology. As an ICS, we have adopted that. So we've got a Director of Finance network. And through that and working with our Efficiency at Scale programme, we've adopted that. However, at local trust level, and this is just the nuances of how finance teams work locally, and obviously we're all aware of the pressures on cash releasing savings at the moment. My job is about efficiency savings, and it's also, and the role of procurement is also around how can we mitigate inflation and reduce a run rate. And if we go back to the value-based procurement, how do we demonstrate that, an increased product might obviously be a cost pressure just because you're looking at the product, but actually in a whole pathway, we can demonstrate, in some cases, hundreds of thousands pounds worth of efficiency through reduced bed stays or unnecessary invasive procedures, etc. So that's what's captured in the NHSE savings methodology. My plea would always be, it's been done. Maybe you might want to adopt it and localize it, but it has already been done. So I'll put the link in, and then hopefully you can locate that afterwards.
That's great, thank you. And then a question from Catherine. With the move to hospital groups collaboratives, is there guidance for procurement teams to maximise savings across a number of trusts?
Absolutely. And again, every ICS is at a different level of maturity. So hopefully now, as we're going to see the merger of ICBs, and they're going to see a number of them reduce. That will give the opportunity for those ICS procurement teams to come together to collaborate more. There might be, in some cases, a system transformation where you maybe have a single team. That's happened in some parts of England. We've seen that move. But there is definitely guidance then. I mean, my at scale programme, so there is only me that manages the programme, but then I work with the senior leads across those 17 organisations to design the work plan. Each trust takes the lead on it, and then we actually have a savings target. So we have a joint collaborative target that we all aim to work towards. And like I said, but every system at the moment is slightly at different levels of maturity, but I definitely hope there will be a move to that as we see the system changes over the next 12 to 18 months.
Thanks. Okay, questions coming thick and fast. Now, can you comment on fraud within procurement and how to spot it, etc., and how to deal with it, maybe?
Yeah, absolutely. So you will have your local policies and procedures in terms of obviously how this is managed locally. There will be, within the systems that are used to do the buying, there will be segregation of duties, again, to ensure that we're avoiding reducing any, I say opportunity, it's the wrong word, but any potential for fraud within systems. And we've seen that over the years where a trust employee has set up as a supplier, the paperwork's been validated and processed, and then obviously the employee was actually paying themselves to do services that they were actually paid by the trust to do. And that's in its extremes from a procurement fraud risk that I've ever seen. And again, now we've got, obviously, with the segregation of duties, the due diligence that happens on any suppliers that are set up in the system, as well as obviously having those robust contracts in place. So, you know, the example I've just given you is very, very extreme, but it did happen many years ago. That is obviously vastly reduced. Obviously, we aim to mitigate it, is vastly reduced. Through a tender process, we would always undertake declaration of interest. So again, we understand whether it's a direct or an indirect conflict, who we're working with, again, to avoid any unnecessary say again fraud, but inappropriate activity and behaviour within a tender process. I would always say if you are, whether you're in a buying team or whether you're as part of a project team and you've got suspicions, always, you know, raise it with your procurement teams, and obviously raise it with your local management, who will obviously follow their local policies and procedures in relation to fraud.
Great, thank you. And then from TK Lee, may I how to access information, or how do you access information on G-Cloud services?
So G-Cloud operate a marketplace, so you can register for access to G-Cloud. Your procurement teams will already have access and will already be registered. And G-Cloud's quite quirky in the way that it's set up, that obviously, again, you can go in and outline your requirements, and it will almost do the shortlisting process for you, so that you know which suppliers can obviously meet your needs. But yeah, you just log on to the Crown Commercial website, and even if you just Google G-Cloud, it'll take you through, and then you can request access to that, fill in your user details, and they'll send you a username and password.
Great, thank you, Sue. And you caught us up on time, so that's even better. So thanks again, doubly thank you, because I overran my first session. So thanks very much. Again, if you have any questions, and you can either email us or you can email Sue directly, and we'll be able to help. So next we've got, we always like to try and bring in kind of a story, and so today we've got Dawn Murphy, who's the Associate Director of Finance and Performance, sticking with Cheshire and Merseyside ICS, who are going to tell us about their journey and to integrations to the integrated care system, and how they found it, essentially. So hopefully we've got Dawn on the line.
Yes, I'm here.
Oh, brilliant. Thank you very much. Over to you.
Thank you. I'm happy for people to ask questions as we're going along. So please feel free to raise your hand or put things in the chat, so I'm comfortable with that. So as I've already, I'm Dawn Murphy. I'm the Associate Director of Finance and Performance for Cheshire East Place, which is part of Cheshire and Merseyside ICB. I've worked for the NHS for most of my career. I won't say how long that is, because that would give you an indication of how old I am. And I keep that very close to my chest. But I've worked in mostly providers, community mental health and acute. So that's been quite beneficial for me when I've come over to the ICB. I've been here nearly 2 years now, being able to have that understanding of both sides of the journey. So that's been really helpful. Also, probably a slight advantage, I would say, for me as an accountant. My husband is a specialist diabetic nurse and works on an acute medicine ward and has worked in community as well. So I think sometimes that's helpful as an accountant, because it does help you have a little bit more insight into some of the challenges that people face. You can imagine some of the tea time conversations that take place in our house. So that's just a little bit about me, just so you know a little bit. So if we can just go on to the first slide, please. So this is just an overview of Cheshire and Merseyside, but then sort of into Cheshire East. So there's a little map there that shows you the 9 places that are within Cheshire and Merseyside ICB. We are one of the biggest ICBs in the country. And like I said, we are split into 9 places, and Cheshire East, which is the area that I work in, is one of those 9 places. From an integrated system perspective, we work alongside 1 local authority, which is Cheshire East Council, 2 acute and community NHS trusts. So that's East Cheshire NHS Trust, which has sites in various places, but their main hospital is Macclesfield General Hospital. And then Mid Cheshire NHS Trust. They're both acute and community providers. And Mid Cheshire's main hospital is in Leighton. And then we also have a mental health trust, which is Cheshire and Wirral Partnership, and that supports 3 of the 9 places in Cheshire and Merseyside. So they support Cheshire East, Cheshire West, and Wirral. So Cheshire East is, as you can see, it's quite a big area on the map, but it's extremely rural, which does create some challenges for us as a place. And it has a population of 412,500. So if you think proportionately compared to Cheshire and Merseyside, 2.7 million population, when you look at the size of the graph versus the population, you can see some of the challenges that we face. But I think it's helpful to see that Cheshire and Merseyside ICB covers 17 trusts, 349 GP practices, 9 local authorities and 559 pharmacies. I think that just helps give you sort of a little bit of a context of what's within an ICS now. It's not just the trust sitting over there and the CCG sitting over here, and that constant battle with the local authorities somewhere in the middle having their own challenges. So if you just go on to the next slide for me, please. So I sort of pinched this from the presentation that was last year because I just thought it was quite helpful to what is the purpose of the ICS. I'm not going to read it out because I'm sure you can all read, but I think from my perspective, coming into the integrated care system from a provider, I can see the real benefits about working across that healthcare system. So the local authority, primary care, the acute trusts and the community trusts and mental health trusts. I've really seen that benefit in Cheshire East and really seen that progress in the last couple of years around the sort of that uniformity of working and that patient-centred care. So I can only hope that it continues to drive forward in the vision that was probably implemented. And don't get me wrong, it's not without its faults, it's not without its issues and challenges, etc. And we're still very much in its infancy, but I can see the progress being here now than when I was in a provider 3 years ago, and it felt very much the commissioner and provider battle. Can you just go on to the next slide for me, please? So each place tries to mirror the setup from an ICB perspective. So this is something that's within sort of our ICB documentation. So you've got an integrated care board, and from that you've got an integrated care partnership. So the diagram helps you to see that flow. So the green diagram is showing sort of how the integrated care board works. So you've got sort of your chief exec and your chair and your medical director and what you would see within a trust. But then you've got your links with your local authority and your primary care. So that's that side of the equation. And then we flow into sort of like the integrated care partnership, which becomes a wider organisation network. So Healthwatch is in there. So for those of you that aren't familiar with Healthwatch, they're like the oversight for ICBs. And they're very closely linked within our integrated care partnerships. Social care providers, voluntary and independent sectors. We're quite reliant on voluntary and independent sector within Cheshire East, because when I talk to you about that rurality, our acute providers, even though we've 2 within the area, they're 20 miles apart. So that can be a challenge for people. So we rely quite heavily on our primary care networks and our voluntary and independent sectors as well. So a little bit there around sort of how that works and how things are set up. And I've got some have got some more detailed examples that we'll talk through sort of in later on in the slides. And if we just move on to the next slide to tell you a little bit more about Cheshire East. So in Cheshire East, one of the things, like I said, because of that rurality, one of the things that we've set up, and it's been held up nationally because we've had ministerial visits and demonstrations and been really held up as a bit of a flagship. We've set up what we call a care community. So it's a little bit like the integrated neighbourhoods that everybody's talking about now, that the operating guidance has said we need to look at. We need how we run around that. So we set up our care communities within Cheshire East, and they've mirrored our primary care networks, and we've invested as an ICB in those care communities. So there's 8 of them across Cheshire East. They are set within the primary care networks. They are a collaborative group of GP practices, and we've funded a primary care network administrator. We've also funded a number of PAs for one of our GPs to chair and oversee the care communities. And then we've also funded PAs for another GP to run our GP Confederation. And then we've also funded pilot schemes for our care communities. And what they predominantly do is they look at taking the ICB objectives. So if you think one of the key things that a lot of integrated care systems have been working on is deflecting and managing that activity that's in urgent care. If we think about the ambulance waits that we've got, the patient flow challenges. So we've asked our care communities to work on how they might support that. But rather than us, from a Cheshire East perspective, saying, well, this is what we want across Cheshire East, they're saying what is going to work within each of their areas. Just to give you a little bit of background on that, if you look at numbers 5 and 6 on the map, so that's like the pink area and the pale blue area. So number 5 is Knutsford and number 6 is Macclesfield. And they are quite wealthy areas, quite affluent. So the demographics within that area is predominantly an ageing population. Whereas if you look at number 4, which is a tiny sort of a yellowy brown, that's Crewe. And the demographics within Crewe are very, very different. Crewe is quite socially deprived. A child born in Crewe, the life expectancy is 13 years less than a child born in the rest of Cheshire. So if you think what Crewe might need from a care community's perspective and looking at how we stop people coming into urgent care would be very different than the rest of Cheshire East. We have a large area that's Crewe is predominantly where asylum seekers will go to within Cheshire East. That's where they will be placed. And the GPs there work with the asylum seekers and the team around that, because what they will predominantly do is will turn up to A&E for what the rest of us might go to primary care for, because they're not familiar with that primary care network and how they can access that. They will also go as a whole family into A&E, so that might be registered as 12 contacts in A&E, and it's not the most appropriate place for them to be. So we rely on our care communities to then take the key objective from an ICS, but add that local flavour. And what do we need to do from a local perspective? We had a demonstration from one of our practices. We do patient journeys and stories, and one of the practices did a very big focus on suicide and suicide awareness, because they started to see a steady growth, particularly with younger people, and it's something that they hadn't really been aware of, because the focus is quite, like we say, it's quite an aging population. They're the people that predominantly access into primary care, and they've started to see a growth in suicides with younger people. So they started to do some awareness around that for the local authority, for in schools. So there's a real link into that wider network outside of it just being primary care, the GPs. They really are providing that real focus for us. It's been really helpful having the care communities, and it's extremely valuable for us. In the last 12 months, we've funded a number of pilot schemes, predominantly around urgent care deflections, and we group everything into population needs groups. And we have a population needs group which is called Olive, and Olive is our biggest area of spend at the moment in Cheshire East, because Olive is over 80, wants to maintain independence and living at home, but might have some increased comorbidities around dementia and those types of things. So it's how we support Olive to stay at home, maintain her independence at home as well, and not go into hospital. Could you do the next slide for me, please? So this was a little bit around how the finances work, and they again have changed quite drastically in the last 12 months from an ICS perspective. So for the NHS organisations, so if you think back to the first slide, there's 17 trusts within Cheshire and Merseyside ICS, and then there's us as the ICB. And we have a statutory duty now to work together as a system and to achieve break even. So I'm sure you've all read in the HSJ around the challenges that the ICSs are facing in supporting that, particularly as the government agenda is about increasing elective referrals. Let's try and get our waiting list back to what they were pre-COVID, and look at how we might reduce that demand on urgent care. So what we've done for 25-26 is we've now looked at how we might manage that funding in a better way so that our trusts don't feel disadvantaged by the activity that they are seeing, but without us awarding things that we view as not necessarily doing things in the best way for the system. So not looking at your urgent care and how you might deflect from urgent care, how you might improve your patient flow. So one of the things that we've tried to do is about the organisations coming together to agree how funding should be split to meet the needs of the population. We're not quite there yet with that. And that's probably because the operating guidance dictates very much around how we will contract with our trusts throughout the year. But we are moving towards that. So we meet fortnightly as a finance community. Sue, who's just presented, is part of that as well, with the directors of finance within the trusts, and me and my colleagues across the 9 places, the director of finance from the ICB. And those are the types of things that we're starting to get onto the agenda. So if we look at how community services is funded, for example, across Cheshire and Merseyside ICB, and is there a fair spread of the finances across the ICB going into the trusts, considering we've got to start moving investment into our community services. So we're starting to get there this year. So it might be interesting to do a reflection for next year for you on how we've got there. But just to sort of give you a little bit of a breakdown. So our acute trusts, they are now funded based on last year's outturn. So 24-25 outturn activity. Some funding is activity based and some is on a block contract basis. So your elective referrals, so that's where your GPs are referring in for procedures or for outpatients appointments. That's funded on an activity basis, and if trusts overperform, then there is a view that they will be paid for that overperformance, particularly if it is improving RTT, that's the referral to treatment timescales. The non-elective activity, that has been based on outturn from last year times tariff. So it's an element of activity based, but then it's been blocked. So we're saying we don't expect you to overperform. If you do overperform, you're not going to get paid for that. So that's an indication of saying the government is viewing that as being inefficient. We've got to look at moving activity out of the urgent care. And if you think about that around the ICS and all of those GP practices and all of those pharmacies, if you as clinicians, for any of you that work in A&E, how many people turn up in A&E who shouldn't be in A&E because they've gone there because they've not been able to get access into primary care, or they're not aware of the support that pharmacists can provide. Pharmacists are a really underutilised resource. So that's where it becomes really helpful to work as an ICS. So some of the things that we've been doing in Cheshire East is we've been looking at activity going through into our accident and emergencies, and saying, I'm sorry, I'm just going to have to shut the window because there's some work going on outside. Apologies for that. I wasn't sure if you could all hear a load of drilling. So one of the things we've been doing with with our trusts is looking at activity that's coming through A&E, and are we seeing increases in certain practices? And what I've then been able to do is link in with those practices and say, is there something that's changed here? Why are we suddenly seeing an increase in patients accessing urgent care? And then they've accessed that, they've looked at that, and then they've put in measures to try and reduce that increase into urgent care. So that's been really valuable, because if I think back to when I was in a provider 2 years ago, we didn't necessarily have those links, and it was really challenging trying to get the right people around the table to have those conversations. So that's been real progress for us. Community and mental health trusts, they are still funded on an historic block contract with some year-on-year growth being funded. And like we've said, if we think around some of the guidance that's come out this year about shifting from acute services into community services, it's cheaper to provide care in the home. And actually, for a lot of people, it's probably what they want. We don't want people to go into, I'll answer that question in a minute. We don't want people to necessarily go into hospital. You've got an increased risk of infection. You've got an increased risk of deconditioning. We've just recently, my mother-in-law is 85 and has dementia, and has just had to spend 6 weeks in hospital following a fall. And she's now home, but she's quite depressed. She's quite down, and her baseline has dropped from a dementia perspective. So if we could have avoided that, that would have been really helpful. And so just got a question I'm going to pick up. If you then follow up patients from A&E, how is that ongoing activity paid? Is there any additional outpatient follow-up payment? So if a patient goes into A&E and they then A&E indicate that there needs to be a referral into a service, then they are advised ideally the patient, it should be referred back through the primary care network, and then the trust would get paid for a first attendance for that. There isn't additional outpatient follow-up. That's blocked. That's done on what we call the block basis, and that's because again we need to look at being more efficient. Prime example again, just because I like to try and relate to things, is I've had my gallbladder removed, and I was seen upon discharge and told everything was fine. There's nothing. I don't need a follow-up. Whereas historically there would have been a follow-up for me to go back 6 weeks later for them to say, is everything okay? Have a look at my little keyhole scars, and yeah, I'm fine, I haven't got, and they go, all right, okay. I don't need to travel into a hospital to have the stress of trying to park, take time out of work for the consultant to tell me. So that's where we put PIFUs in, which is patient initiated follow-ups. So actually for a lot of procedures, I understand from a medical perspective, if you're on a medical pathway, that might be slightly more challenging around follow-ups. But a lot of surgical procedures and a lot of elective surgical procedures, you don't actually need a follow-up. I had a hysterectomy, I had a follow-up. I didn't need that follow-up. I know I can, if I've got PIFU and that's explained to me as a patient, so I know if I've got any concerns, I've got a route for ringing back in and going, would it be possible for me to come and see? I've had some surgery 6 weeks ago. I'm a little bit concerned about my wound. I'm a little bit concerned about this. So again, it's about if we continue to pay for follow-ups, then we continue to drive that activity back into hospitals. And actually, there's better ways of dealing with it. You either don't need a follow-up, you can put PIFUs in place, but you can also add advice and guidance. If we do really effective discharges into primary care and support within primary care, and again, it's look at how we might shift those finances to support that movement of our activity. So I hope that answers your question. The finances for primary care organisations, local authorities and other system partners. So if we think back to those diagrams where it indicated other people within the partnerships, there isn't an obligation for them to agree their finances with us. However, it does work to work as a system. It really does support it and not cost shunt. So some of the things that we found in Cheshire East is the local authority have made a decision to save money. So an example there is they have a school they have a number of children who have the additional educational needs and have what we call ERCPs, which is a statement that's put in place around how those children might be supported with their care and their learning. And there's a health link to that as well, because these children will need speech and language therapy support. Some of them will need occupational therapy support, and some of them will have need physio support. And so what has happened previously in Cheshire East is a lot of children have gone out of areas. When we say out of area, they've gone out of Cheshire East. Because Cheshire East is on the border of Greater Manchester, a lot of them have gone into the areas within Greater Manchester, into a school within Greater Manchester. So we haven't, as a health provider, provided their healthcare. It's the healthcare providers in Greater Manchester that have supported them. Cheshire East Council have realised that that's extremely expensive for them. And if they were to invest in extending their special school within Cheshire East, they would have a significant saving to their financial bottom line. But what they didn't do was consult with us on that. Not that they had to consult with us, but we weren't even aware of it happening. And then all of a sudden, all these children have come back into area. They're now in a school within Cheshire East, and we now have to provide the healthcare for them. So that's a big hit to us financially, and also a challenge, because if any of you are familiar with AHPs, they're areas that are challenging to recruit to as well. So that's been a real challenge for us. So in order for the council to generate savings, which they're going to do, we're all doing it, it's shunted costs into the ICB. So working as that partnership and working across the system, we can be more aware of those things and start to have those conversations and start to look at how we might link in with that. And it's not that we would want to stop them doing something like that, particularly if we think, if you had a child, you would want your child to go to school near to you, you would want them to be in your area. And actually, from a primary care perspective, that's much more supportive for the GP, because the child is being cared for by the staff that are in their area, that are in these care communities that we talked about on the previous slide. So it's back that system working. But that's a bit of an example for you about how the system has benefited probably from a patient care perspective, a family perspective, but from the finance across the NHS hasn't necessarily helped. So Greater Manchester may have seen a saving, we will see a hit. And at the moment, we're not geared up for moving money through and flowing through from ICB to ICB. So let's just give you a little bit of an understanding around sort of how the finances work. Can I have the next slide, please? So I wanted to provide some working examples for you, because I think sometimes when accountants talk, we talk very much about the finances, and I'm very keen to talk more around the pathways and that side of things, because they're things that you can see the benefits from. So I wanted to just provide some examples. So working across the care communities and implementing changes to pathways. So I talked a little bit about that when I talked about Crewe, and how the needs in Crewe are very different than the patient needs in an area like Macclesfield or Knutsford. If you were to Google Knutsford at the moment, that's very much high on the political agenda, because we're trying to work with a practice in Knutsford because they're wanting to improve the premises that they're providing on. They're no longer fit for purpose. They're old buildings, and that's gained quite a lot of ministerial exposure because one of the patients of the practice is Esther McVeigh, who is an MP. So as I'm sure you can imagine, that's gained quite a lot of traction and quite a lot of political focus because she's got behind the practice on supporting that. Whereas potentially if we think about people in Crewe, they might not necessarily gain that same traction and focus. So it's key for us to make sure that our care communities are linked into everything, and we link into our care communities. So community services, secondary care and primary care, implementing changes to support better care for patients. So one of the things that we're working on there is around, I'll have a look at that in a minute. So one of the things that we're working on there is around supporting patients on our heart failure pathway. So at the moment, we have a little bit of a postcode lottery. So there's a better service in one of our hospitals than there is in the other. And that's due to some of the challenges that we have around our fragile services. But one of the things that we'd like to do, what we're looking at there is streamlining that pathway. The acute providers, so the consultants, the cardiac consultants, the GPs, and the community services have all started to work together to look at how we might redefine that pathway and change it so that people won't necessarily go into A&E. We will pick them up earlier. So there's a risk of heart failure within a certain category. They will be managed within primary care, but with secondary care consultant support, with specialist nurse support. And that's a real key indication of how working as a system can hugely support modifying and changing those pathways. The challenges we've got with getting that off the ground is obviously the finances, and that's why I'm linked in with all of that pathway and trying to support that. Again, that'll be one to watch and see if we can get that off the ground, because that's real system working. I'm just going to have a look at some of the questions before I come on to the next one, if it's okay. It's difficult for patients, though at times it's not always easy for them to get an appointment with GP. Yes, currently follow-up from AA attendants. GP's not always happy that they have to put another referral, but I can see the point you make about discouraging. Yes, yeah. And again, like you say, that's as a system, that's something that we can perhaps work on, but it's still around that fact that we've got to stop people going to A&E. It's not appropriate just because you can't get a GP appointment, because a lot of the time, even if you go to A&E, you're still not necessarily, they're just going to say, well, you need to go back and see your GP. And as much frustrating as that is, hopefully that would encourage people to then think about going to A&E when that's not necessarily where the best place for them. Do we expect joint financial planning to be part of the upcoming 10-year plan? So what we're looking at as an ICS is that we are looking to create a 3-year plan as an ICS, but that's for the trust, the 17 trusts and the ICB. But we would be expected as an ICB to consider what's happening within primary care and local authorities. We wouldn't necessarily have joint year planning with our local authority colleagues, but we would be speaking to them and saying, what are you looking at? Because local authority do 3 to 5 year plans. So we can be talking to them about what their plans are and how we can play that into our plans so that we know about the things that implicate. So we've got to get better at that. I wouldn't have thought that we would be doing joint planning with them because the legal frameworks that we operate on are quite different. But that's not to say that that's not something that the government may introduce it in time, but not at this point in time. So I'll just carry on with the examples, then come back to the rest of the questions. The primary and secondary care working to support fragile services. So what we've done there is in one of our trusts, we've got some real fragile services in that the trust doesn't doesn't necessarily, it's a district general hospital, so doesn't necessarily have the capacity coming through A&E to warrant that service being attractive from a staffing perspective. But in order to operate safely, they have to have the number of medics on the rota, but they can't necessarily get those medics on the rota because the activity isn't coming through. So it's been a real challenge. So what I've done is I've looked at that activity with the trust. We've looked at where we can see it going into our independent sector, but also crossing into borders of other areas. And we've worked with the trust to say, actually, if we could bring that activity back into the trust, and therefore the trust is getting the money that's supporting that activity, it means that they become more attractive as an employer, and the funding is there to support. And our primary care colleagues have supported that journey and started to look at, when they have the conversations with patients around where the patient might like to go, because we've still got right to choose, they're having the conversations to say, you know, we're now working very closely on the pathways with our local hospital. Would you be happy for me to refer you into our local hospital? And a lot of patients have then chosen to go into the local hospital. And because the waiting times are quite similar than they are in the independent sector. So that's really helped bolster those fragile services within our one of our trusts in Cheshire East. We've also got the advantage of we've got shared roles across the local authority and the ICB. So in Cheshire East in particular, we've got our head of urgent care. It's a shared role. He works 50% for the ICB and 50% for the local authority. His role within the local authority is around discharge planning, transfer of care, discharge to assess, and his role for us is supporting urgent care and that flow. So he works very closely with the trusts. He's on all of the bed management meetings. He supports all of that. You know, when we're looking at getting patients out, they will link in with me if they need that support around how can I approve something to get a patient out of hospital quicker. So there's some real advantages to having those shared roles as well. So just go back to, I think somebody's followed up. Can we imagine that there will be more areas where PAM system pool budgeting will be suggested as necessary or best practice? Interesting question, James. So if we think about the operating guidance and what's come out recently around ICBs having to reduce their staff down by 50%, that's around integrated neighbourhoods and setting up an integrated neighbourhood approach. So I think that's probably what you're sort of looking at there. But whether we would look at the budgets being aligned like that, then that's not. Go on, James, because do you want to explain it a little bit more for me?
Well, no, I mean, I will use the. Sorry, hello, Dawn. I'm James. I use the example of my area of work. Would have mentioned in the chat earlier that I work around sustainability and green planning. It's an area where there's no allocation comes down from NHSE to support us, and it is a PAN system requirement to work to an ICS level green plan, for instance.
Yeah.
So as I'm sure you can imagine, there's lots of things that we can do together. And to support what we do together, it helps if you have pooled budgets. But that is a choice. It's not a requirement. No guidance tells us we need to do it, although it's blindingly obvious it makes a good practice. And I just wondered whether you think there's going to be any direction in the future that for initiatives such as sustainability, but not limited to sustainability, do you think there's going to be more push towards mandating pooled budgets, so that we don't get into that kind of weird tit for tat of you've got more resource than me, so why should I put this much into the pot, etc., etc.?
Yeah, that's a really good point and actually a really good idea. And I think that sometimes that you can really see the benefits of that, but then when you've got that pool budget, that's when it sometimes does become that bun fight. So there's the pros and cons for it, and it's how you might set up the legal framework that supports that. But if we think about some of you'll be coming in an ICB, you'll be well aware, you know, we've got to cut 50% of our staff, and they're looking at actually should trusts manage certain processes? Because if you think from a sustainability perspective, the trusts have got staff that are looking at the green footprint and sustainability. We've got staff that are looking at that. And actually, like you say, well, if we changed that and we said we had one provider or two, so Cheshire and Merseyside is quite big, so, and we're looking at splitting into 2 areas initially over the 9 places, which would be the Cheshire devolution and the Liverpool City region. So if we had one provider within each of those taking the lead on that sustainability and green, because if you think the Liverpool City region would have a very different view on sustainability than the Cheshire and Warrington, which is very, very leafy green, very rural. You've not got the transport links that they've got in Liverpool. So that, I think that where you might start to see those changes, when we start to see the changes in the ICB and we start to see things going into a more centralised managed area rather than things being in 9 places and then in 17 trusts. If you think from a Cheshire and Merseyside perspective, it is really inefficient, that, and actually everybody's trying to do their own thing, and really we're all heading in the same direction. So would it not make more sense for everything to be? So I think that's perhaps where things would go. As an accountant, I would be pushing for that, definitely. So it's a really good point, that, James, and one for you and I to watch, I think.
It is, yeah, interesting. Thank you, Tom.
So that brings me to the end of my presentation anyway. So thank you very much to everybody for attending and listening. I hope you've all found that helpful. Like I said, try to give a bit more of a flavour to finances and link it back to yourselves. And I'm happy to take any more questions if anybody's got any.
That's been wonderful, Dawn. Thank you so much for your session there. It's been really helpful and insightful, especially in light of all the changes that are going on in the NHS at the moment. So thank you so much for taking the time out to share your knowledge with everybody today. I'm hoping that we've answered all of the questions on the chat. I tried to sort of assist.
So I'm just going back forward on the pub, which is from James. Anna, we talked about.
Yeah.
Yes, it looks like it.
That's fabulous. So with that great timing, we're going to close for lunch now, and we're expecting everybody back at 10 to 1, if that's okay, where we will be covering costing, PLICs, that's patient level costing, and coding just before lunch, and then we'll be going through that both in different settings, mental health and acute. And then we'll have a short coffee break. Yeah. Feel free to stay on and listen.
I can't, unfortunately, but enjoy the rest of the day, everybody. I hope you. Yeah. I used to do PLICs, and it's how you really connect your numbers to your patients. So I hope you get something from it. But my emails are in the pack. So if anybody's got anything they ever want to ask, I'm a face, so I'm a with the register, so I don't mind anybody dropping me an email if they need any help or support, and I can always point you in the right direction.
That's fantastic.
Okay. Enjoy the rest of your day, everybody, and thanks for listening.
Thanks, Dawn. Thanks, everyone. We'll see you back at 10 to 1 then. Well, thanks, Steve, and I'll hand over to you now. Thank you.
Lovely. Thanks, Pam. Nothing like bigging us up, exciting and informative.
Of course, always.
Hi, everyone. Thanks for having me. So, as Pam said, my name's Steve Lee. I'm one of the heads of finance in Leicester with a responsibility for the costing team. So we predominantly look after the Trust's internal patient level information and costing system and our national returns. So what I'm going to talk to you today about is what costing is, why it's so important, how we go about understanding the patient journey and costing it, the system that we deliver that through, and probably most importantly and the most exciting bit really is how we can use that information to help improve patient care. At the end of the day, that's why we're all here. It's a quick session, half an hour, so I'll try and rattle through and then hopefully leave 5 or so minutes at the end for questions. I don't know whether I can see if hands go up or not, so feel free to shout up if there's anything that can't wait until the end. So what is costing, first and foremost? So if you take it in its dictionary definition, it's the quantification in financial terms of the value of resources that are used in carrying out a particular activity or producing a certain thing, a widget. So in our world, in the healthcare setting, this relates to how much it costs us to deliver our clinical services, and on a more granular level, each of those individual patients that come through our doors. Across the NHS, in the acute community mental health sectors, PLIX has been implemented and standardised as an standardised approach for costing. So we are all reasonably consistent in the way that we deliver that activity. So I think you've got a session at 3:30 to talk about understanding budgets and kind of traditional financial reporting. Costing is very different to traditional financial reporting and kind of budget management. From a budget management perspective, you'll usually be split up into cost centres across your organisations, which will be an area that provides a particular service or an element of care. So you might have a bunch of cost centres for wards, you might have a bunch of cost centres for theatres, for medical staff, for management and admin. That's great for being able to monitor spend compared to your plan and your budgets, which we'll learn more about later on. But the way that costing information differs is that it kind of removes those budgets and it looks at the overall costs across each of those cost centres and the elements of those costs that go into individual treatments and delivery of patient care. We do that for those direct cost centres that might provide that care immediately to the patient, those wards, those theatres, etc. But we also bring in costs from the support services, the imaging, the pathology, theatres, and then those corporate areas and things to create a true fully absorbed cost, and we're able to compare that to income as well. So it's quite different. So why do we do that? Why do we take all of that time to take all of that ledger information that's been prepared by financial management and kind of represent that data in a different way? You'll all be well aware of the kind of financial challenge that the NHS is facing at the moment, in particular in relation to productivity and ensuring that we get the most bang for buck that we've got. If we cannot measure our levels of productivity and how much it costs to deliver those individual elements of patient care, how can we improve it, or how can we know that it's improving? So it's really important for us to be able to build those patient costs, and we'll tell you more about that as we move through the session, to allow you to then use that to make decisions and measure performance. So PLIX and SLR. We've already mentioned that PLIX is patient level information and costing systems. SLR, which I'll also refer to throughout the slides, is service line reporting, which is pretty much an aggregated version of patient level information and costing data. In essence, the way that we produce this data is that we try and trace each of the individual resources that a patient will consume from the minute they come in through our front doors to the moment they go home. And we'll do that by looking at different information systems, different activity feeder data sets, and using that to try and understand what's happened to those patients. Again, we'll cover a few more examples down the line, but we'll do things like look at the systems that we use to capture different diagnostic tests, to capture the drugs that patients are issued, or how long those patients are on a ward for, that kind of thing. So once we are able to trace those resources, we can put a cost alongside those resources, and ultimately understand and get an itemized bill, I guess, for each of those patient costs, what resources they've used, and start to do some analysis on helping us to understand where we might be able to improve those or what's driving those costs. The great thing is that because we do it at a patient level, we can then aggregate that up to analyse a vast range of kind of different levels within the organisational structure and within our reporting structures. So whether that's service lines, clinical management groups, particular consultants, particular healthcare resource groups, or primary procedure codes, that kind of thing. We'll cover that a little bit further down the line. So really simply, how do we do it? It is a complicated process, but if we can kind of break it down into three elements really. So the first is to bring in our core information that's needed to be able to do the process. So that is understanding what patients come through our doors and how much money we spend. What we'll then also bring into the sausage machine is all of those different activity feeder systems that tell us as much as possible about what's happened to those patients when. At Leicester, I think we bring in about 35 different systems into our database that helps us understand what happens to those patients. The key ones are ward stays that tell us which wards those patients have been on, how long they've been on those wards for, potentially the complexity of their stay whilst they're on those wards. We'll bring in information to tell us about how long they've been in theatre for. That might be your time in anaesthesia, your cut time, your recovery time, and also the number of staffing that are in theatres to treat those patients while they're in there. Mentioned diagnostic testing, so we bring in records for every test that patients have, whether that's pathology, imaging, or other diagnostics. We bring in drugs issues, we bring in therapy contacts for things like physio, OT, and then there are also costs in there for things like high cost devices where we know there are significant unpaid costs that are attributable directly to patients. Once those kind of three sets of information, the core activity, the financial ledger, and the cost driver information are churned through the sausage machine. They're linked together, so we'll create links between the patient activity and the cost drivers based on patient IDs and dates, and then we'll create links between the ledger costs and those drivers based on the information that's held within each of those different activity feeds. That churns out then an itemized bill for every patient. At Leicester, we pop in the corresponding income for that based on tariff levels, which is all supported by that underlying activity data. And as mentioned earlier, we can aggregate that to show the position at various levels. So depending on where you are in the country, what software you use, and locally what reporting solutions you've implemented, the data may look different to the examples that you see on screen, but this is just a flavour of the kinds of way that you can access some of the data. So the chart that you see from the dashboard on the left hand side is a depiction of one particular patient who's come through our hospital. They've had a length of stay of 35 days. And because we cost on a daily basis, you can then see the value of each of those resources that have gone to that patient for each of the days that they are present within the hospital. So really granular level information, which when you aggregate it up and you start to look at comparisons across the different data sets, you can start to tease out some really interesting information. At the opposite end of the spectrum, you've then got some of the summarized information that we've got here. So that particular patient within cardiac surgery or cardiology, I think. our snapshot data that we've got in the tables on the right hand side show the overall I&E position for that service, so a significant loss within that particular service at the time we took the extract. And then you can see things like the performance of your top 5, bottom 5 HRGs in terms of profit and loss. So it can help to direct you to areas of particular concern or where you're performing well. And there are so many different ways in between that we can analyse that data. We'll talk a little bit more as we go through about how we do that and what use cases there are for that data. So the first one that we've got on here is to aid understanding of your economic drivers. So we mentioned earlier that with traditional financial management and budget reporting, that will give you a really good indication of where you are spending beyond what you have planned to spend, or where you're not spending to those levels, or how your performance compares against that plan. What that traditional financial management model doesn't do is tell you why you're performing in that way against plan. PLIX, because it's linked to activity drivers, can give you really good insight into what's driving those particular overspends, underspends across the organisation and within your services and for treating your different groups of patients. So that's a really, really valuable thing to be able to then make decisions on the back of. We've produced this data to a set of national standards, and that means that we can compare the cost of services and treatments that we perform as an organisation, either internally between your different clinicians or externally against peer organisations from the national data set. The great thing is that the granular level of data that we've got in there can tell us how each clinician treats similar patients in different ways and what that implication is in terms of the cost and the financial kind of outcomes for the organisation. So really, really useful stuff. It's really good for providing some context to other information that's banded about within the organisation. Often some of the metrics that are put out there and are available to services need triangulation to some other data sources to fully understand them. What PLIX can do, because it's got a number of different influences and drivers within the creation of the costs and the outputs, it can sometimes shine a light on some things that might not be immediately visible for those other metrics. If I was to give an example of something internally here at UHL, there's a big focus on productivity. We might use some top line measures to look at theatre productivity, which might include your average number of cases per list. If we were to look at that in isolation across the organisation and see that rising, you would think you might be becoming more productive. What that doesn't tell you is the complexity of those patients that are being treated. It doesn't tell you about the value of the income that's associated with the treatment of those additional cases that you're putting through lists. It doesn't tell you whether you're putting those additional cases through a list at a higher cost or not. And all of those things can kind of be pulled together from the data that's available within PLIX if it's built correctly. Data can be used to help with tariff setting. So lots of the tariffs are nationally produced. This data does go in to form the basis of those national tariffs, but we can also use that costing data to negotiate local prices to ensure that if you're negotiating a new contracting arrangement, that you're covering your costs, you're not selling your organisation short and that kind of thing. Something else that we're seeing more and more of within UHL is assisting with business case development. So quite often within a business case, the services are easily able to demonstrate the expected changes and perceived benefits of that business case from a patient outcome point of view, but not always from a financial point of view. So Plix can help to do that and help to model those things by understanding the value of each of those resources that goes into each of those different elements of care. Again, another quick example from UHL at the minute, we're looking at some AI interventions within imaging, the outcome that they will have on the number of patients that will require invasive onward investigations and treatments. And we're looking at modelling the kind of current pathways of those patients, and then based on research that's been undertaken by one of our clinicians, what we expect those costs to be if we were able to use that kind of AI enhanced review of the diagnostic data. So really positive stuff there. And we've got a few examples where we've done that previously as well. You can also use the data to help track performance over time. So again, with the complexities of the work that we do within the NHS, it can be really difficult to tie your traditional financial reporting back to the activity that you're undertaking and how that's improving or declining over time. Granular level patient information and cost data can help to do that. And if we've got any time at the end, I might share a little example of what we're doing with that. So a bit more on how it can be used within the organisation. There are so many different ways, and trying to cover that in 30 minutes is a tricky one. Because there are so many use cases for the data, but a couple that we're looking at in Leicester at the moment as well are things that you might not always necessarily associate with costing and identify inefficiencies. So in the past, we've looked a lot at clinical variation, whether one consultant does something different to another, and whether there are things you can learn from that benchmarking data. But we're trying to tie this into more and more initiatives. So one of the team that we have over here is looking at identifying frequent flyers that go through A&E and the rest of our urgent emergency care pathway, tracing those overall costs, identifying those patients, flagging where there are commonalities in there to look at whether our teams can provide intensive support to those. We've rolled out a kind of a pilot to look at what interventions can be put in place for those patients, and done some kind of cost benefit analysis there to say, yes, it's worth investing in those teams to work with those patients up front and prevent those urgent emergency care people. On a similar vein, we've been looking at things like the links between patients who don't attend in outpatients and then their subsequent presentation in our emergency pathways, linking this with particularly people from highly deprived areas, and again, what the cost implications of those patients not attending their planned care activity and then kind of rocking up in A&E, and again, do we need to put interventions in for those patients? I've been working with Sanjay, one of the clinicians here, to start looking at how we can evidence and quantify the benefits of preventative care to ensure that appropriate funding goes towards that in the future. And we've also been starting to look at helping to assess the performance of big capital developments that we've got at the organisation, such as the East Midlands Planned Care Centre. So how does the activity that's going through that huge new investment compare in terms of productivity and finance compared to our older buildings that are across multiple sites and that kind of thing? All of that wouldn't be possible without that really granular level of information that we build from the bottom up. So hopefully some really useful things that you can take away, think about within your organisation and say, can we talk to our costing teams about whether we can use this data in a way that provides real value to the organisation. So the last one is a bit of a plea really on here. So it's just about engagement. So me, my team, most of the rest of finance are not by any means experts or anywhere near in caring for our patients, and in most instances our care professionals and even many of our managers are not experts in NHS finance. But if we can work together to produce really robust costing outputs to inform decision making, then hopefully we can improve the quality of care given and the financial sustainability of an organisation. It's a bit more about why that's important from my point of view. So care professionals and managers out there on the shop floor hold the key to understanding how we consume our resources, and you'll also have the influence and ability to change how we deliver our services. You tend to know what data is recorded out there on the shop floor, and you can help support us to ensure that costing data is more accurate and reflective of how those services are delivered. You'll also usually have a really good feel for where processes could be improved, where there might be clinical variation or where other opportunities lie. We can then hopefully help you to evidence or disprove those hypotheses about a service or a treatment, and help to support your case for change within that area. We might also be able to identify new areas of opportunity through some of that internal analysis and wider benchmarking. And as I've mentioned probably a couple of times, it helps to pull together a wide range of information that's not all usually available within one place. So hopefully a really, really useful tool. If you want to know more, there's lots of information out there. So there's lots of information through One NHS Finance, through the Healthcare Costing for Value Institute that the HFMA put together. Really, really strongly encourage you to reach out and speak to your finance and costing colleagues at your organisation, or if you are aware of the finance and clinical educator network members at your organisation, they'll be able to point you in the right direction if you'd like to know more. I think there's a list of those all on the One NHS Future Focus Finance website. I'd really strongly encourage you to talk to your boards or ask your boards about PLICs in your organisation. Make sure they're aware of the benefits of it, and that they support the costing teams across the country to deliver what is potentially really, really powerful information. So I think that's it, and I think I've got 5 minutes spare, which is unlike me. I normally waffle on forever. So yeah, a couple of minutes for questions if there are any.
That's wonderful, Steve. Thank you so much again for your time in sharing your expert knowledge in this field. I think we've kind of answered the questions in the chat as we've gone along. So if there are any more questions that you might have in the audience, if you'd like to either put your hand up or put anything in the chat whilst we wait for our next speaker to arrive. We'll give it a few moments, Steve, to see if anybody has any more burning questions.
Yeah, no worries. I'll hang around for 5 or 10 minutes afterwards, just in case anything that comes through on the chat as well.
Oh, there's one that's just come in from Lucy at Sherwood Forest and wants to ask if this is just being rolled out in inpatient settings, or is it being used in outpatient settings as well?
It should be across the board. So the mandated kind of areas from NHSE cover all acute services, so it should be your A&E, your emergency care, it should be inpatient activity, outpatients. There are then other bits and bobs in there as well, but it's also mandated for community and mental health, and I think you've got a speaker in a second who's going to talk to you a little bit more about that as well.
That's brilliant.
Should cover everything.
Brilliant. Yeah, so with that streamlined transition, let's welcome Claire Jacqueline. Is Claire there?
Yeah, I'm here.
Hi, Claire.
Hello.
Steve, I think there are. I think there's one more question that's come up on the chat. If you don't mind answering that on the chat, that would be great. And
No
we'll
problems, I'll
get
take a look.
Claire, and we'll get Claire to start her talk so that she can finish at 10 to 2. That's brilliant. Claire, I'll hand over to you. Thank you.
Right, thank you. Can you...
Welcome again.
Oh, thanks for having me back. Are you all now able to see my screen?
Yes, thanks, Claire.
In
We
that
can
case,
see the
I shall
screen.
start my presentation.
Thank you. I think somebody's got their microphone on. So if they can... I'll see if I can try and mute them.
I've just muted them now.
Oh, brilliant.
Yeah.
Thank you.
That's fine. Thanks for listening to me today. I'm Claire Jacqueline. I'm from Humber Teaching Foundation Trust. We are a mental health and a community health teaching trust. Costing for the acutes is what I'm, not for the acutes, from a mental health perspective is what I'm here to talk to you today. I firmly believe that you can cost anything with the right information, but there needs to be a reason, a purpose, a so what, why. There's got to be a reason for doing it, because taking the time to cost does take time and effort, and there's obviously a trade-off for the rewards that you need to seek. The session is going to cover about what is a little bit about Humber, what is costing, why we costing in a mental health provider and how that's different to in an acute trust, patient level costing and understanding the patient journey, and how costing information can improve patient care. So very similar line up to what Stephen just presented. As I said, we are a mental health trust and community health. We cover all age groups across a population of about 765,000 people. As a trust, we employ about 3,600 staff. We have about 80 different sites. Our turnovers, as you can see on the screen, and we cost about 180 different service lines. And obviously, when you take it down to the number of patients and number of activities each of those patients received, that number grows and grows and grows. So there's a lot of detail in the costing system. What is costing? Well, costing quantifies the financial value of resources that are consumed when carrying out a particular activity. So our resources will be our nursing staff, our occupational therapists, psychologists, particular consumables like our dressings or PPE or syringes, etc. And the activities in my trust generally work around care contacts, whether they be group or individual with patient, admitted patient days, supporting activities. So we cost not just the contacts, but the things that support us to deliver care, because we have quite a lot of involvement with liaising with other bodies, whether that be schools or whether that be the police or even other clinical staff. So that there's quite a lot of supporting activity that we do, particularly because in mental health and community health services, for that matter, a lot of that is done in the patient's own home. So we will have to travel and go to visit that patient, which takes time away from actually being able to make certain appointments that you would maybe have in a clinic in an acute hospital. Why do we cost? We cost obviously because the NHS is a public funded body, and we need to explain how we are spending the money, and so that we can use the information to make more informed and evidence-based decisions about the people that we employ, the places that we deliver that service, and the actual services themselves that we are providing. The places in mental health can make a big difference to the sort of outcome of care that a patient receives. Certain patients will not want to be having to go to a very busy hospital. It might affect their own values and beliefs, I suppose, in the fact that it might be not the best place for them to receive care. So how we deliver care to different types of patients is not necessarily the cheapest way of doing it, where you have one site where everyone visits. We have to spread those around locations, which makes it a bit more difficult in mental health. Why do we cost? I suppose Steve mentioned earlier around traditional view of costing, where we were looking at actual costs versus budgets in our financial ledgers. So if team A spends £10,000 less than the budget, but team B spends £10,000 more than the budget, which team is doing better than the other? And traditionally for financial management, the one that's spending less always looks better. But from a costing perspective, there isn't enough information to answer this question. So if I add a little bit more detail to the same example, and now I've added a number of patient contacts in there. So now patient, or the team A that was delivering costs cheaper overall against budget, now looks more expensive when you're looking at the average cost per activity than team B. But even now, I can't tell which team is doing better. There's no information on the type of contact delivered. There's no information about outcome. There's no information about the duration of the contacts. And a lot of the costing information and submissions we make tends to be about the total cost divided by the total number of activities. And for costing in mental health, I don't think it always gives you the true picture of the delivery of the whole patient care and the whole patient pathway and the outcome for that patient. Going back to why do we cost? It's so that we're providing value for money as well, so we can understand whether we are providing the value for money. Value is using Kaplan's model, is the outcomes divided by the cost of delivering those outcomes. And obviously, the better quality outcomes we can do for the cheapest cost gives us the best value. And we obviously want to improve that equation within our own trust. By having a costing system, we can certainly calculate this cost bit. By having a PLIX information system, we hope to pull in mental health the outcomes to be able to work this out. But we're still in the early stages, I suppose, of developing PLIX in mental health. And we have a way to go on bringing outcomes into my costing model at least. And I'm sure that's probably the same across the board in mental health trusts. Why do we cost? To understand if we're providing care fairly and addressing health inequalities. Health inequalities are the unavoidable differences in healthcare across populations between different groups and society. So it might be to do with the socio-economic status and deprivation. Are people unemployed? Is the area low income? Is housing poor? Is their education poor? It may be to do with protected characteristics like age, sex, race, or vulnerable groups, maybe like Gypsy Roman travellers or rough sleepers, and sort of geography, whether it's urban or rural areas. And this has a massive impact on the health status, the life expectancy, and the access and availability of care for our patients. So as part of the costing work that we do, we want to be able to see if we can understand whether we are delivering care fairly to all. This is a paper that I thought was quite interesting from the King's Fund, and it's just a few charts from there to show the differences around the level of deprivation. So if you're in deprivation area 1, that area is the most deprived. Deprivation area 10 is the least deprived, and there's stark differences between the level of health, good health and poor health, between those boundaries. And so as a trust, we want to understand how we are delivering care to make sure that it's fair to all. So this is an example of some of the data that's in my costing system. It's 2 teams delivering care. If you look at the count of patients in each of the areas, the team A covers more of a deprived areas than team B does. If you look at the costs, then, although it's not, my screen has just frozen, so hang on a moment. Right, okay, sorry, I'm back up with you. So the cost, when you look at that, tends to follow the same patterns of the numbers of patients within there. But when I start adding in the average cost per patient in each of those deciles, it tells me a different story. I would hope that this would be a fairly flat picture, or, as I've said, that the areas that are more deprived, I would expect maybe more care needed, that the costs would probably slightly increase as I went across. In my team B, I've got a very big difference in the patients in deciles 3 and 4 compared to deciles 1 and 2, which are the most needy. I'm spending more than double in patients 3 and 4 than I am on patients in deciles 1 and 2. And so as a trust, we've had to then look at what are the barriers, what's causing this? Are there barriers to entry? Are the patients in deciles 1 and 2 not able to attend the clinics or see staff when they are able to, maybe because they're working and can't take the time off because they'll lose the pay if they're on something like a 0 contract hour. Maybe there's just no transport for those because they're rural and they can't get to us, and so we've not made arrangements to get to them. It makes us look at how we offer services and trying to resolve this, so in the future that this becomes more of a flat line and everybody gets an equal opportunity to receiving care from our trust. You can cost anything with the right information, and we cost at the most granular details that we can, so every contact, every bed day, every drug, every supporting activity, but the data doesn't have to be perfect. Up until recently, I had no contact information when a patient was admitted to a mental health ward, and so we used to use an approximation using the clinical note types recorded against the patient by staff and use an estimate for each of those sorts of activities. So whether it was they've given bloods or taken bloods for tests, or whether they've done a HCR20 report and had to do something like that, each of those types of clinical note had a different level of information behind it, so we could start breaking down the costs of patients within a ward. So this came out of one of my mental health wards, and it shows 13 patients on each of the charts, one for the average cost per occupied bed day and the other is the total cost per patient. Actually, if you're looking at this particular ward, none of the patients in this occupied bed day are in the highest spend patients on the right hand side. The ones with the highest cost per bed day are all within their first 5 days of admittance of a ward, where they're being assessed, they're having a lot more activities happening to them, and a lot more notes were recorded, so we got a more expensive cost per bed day. So that's that. And the patient that was admitted to the ward for longest time frame was not the most expensive patient to treat. They were the 5th most expensive in that particular unit. If I didn't use clinical notes and use nothing, all patients would have exactly the same cost per occupied bed day. And obviously the one that would have been in the longest admittance would have then shown as the highest cost. But because of the way that we cost, it gave us a bit more information. So you can cost anything with the right information, but there's difficulties in making comparisons in mental health services. To begin with, we have a difficulty in making sure that the activity that we cost from is recorded and reported correctly. Unlike our acute peers, we've never had a payment by results, so we had nothing really to push the recording of data to be correct. And we've also, because of that, we never had any clinical coders, so there was nobody to really make a decision on what type of illness that we were really treating or record that within the systems. So grouping and categorizing what you're costing wasn't really as easy as we thought. Sometimes we'd just do it by service lines, but in each of the services you may have different illnesses within there. So our older people CMHT may not just do organic sort of illnesses, they may do functional illnesses as well, and it's a mixture. But defining and being able to compare then mixes between teams and the types of patients they were seeing was fairly difficult to begin with. But that landscape is changing. But the NHSE attempted it with mental health care clusters, initially to break in patients into different groupings to be able to cost and compare against. That's been scrapped now, and they're moving into the mental health and neuro development resource groups, which were initially launched in March 2024, but it's still being developed and it's still early in the development of that stages. So I've just put a slide there which shows you what the resource groups are currently, but these are going to get broken down further into different levels of severity. But that's something that you can see on NHS Futures on the announcements there. As a part of the development, they're obviously looking at the different levels of severity. So in my trust, we've been looking at making sure that we are increasing the type of activity that we record. So does this patient have their accommodation status recorded? Do we have their ethnicity recorded? All things that will affect the cost of delivering care if they have more needs than other patients. So the difficulty in costing mental health is measuring and costing outcomes as well. And so how do we show that we've made a difference to the patient? Because patients may be with us for years. It's not necessarily just a short few days in a hospital. They can be with us for a lifetime. So we use a number of things: PROMs, patient reported outcome measures, which are things like questionnaires that ask about your health and well-being. For examples of this could be recovering quality of life, the REQUAL or goal-based outcomes or dialogue. CROMs are used in the rehabilitation to evaluate and track a patient's health status and recovery. Things like Health of the Nation outcome scales, HONOS, which is a method of measuring health and social functioning of people with severe mental illness, and that comprises of sort of 12 scales that measure behaviour impairment and symptoms and social functioning. And things like PREMS, the patient reported experience measures. Do we gather information on the parents' views of their experiences while they're receiving care? And obviously these indicate the quality of care the patient perceives that they have received for themselves. But for costing, how do we incorporate these metrics to demonstrate whether we're improving patient outcomes for the most effective cost? Back to our value equation here. PLIX brings together healthcare activity information with finance information into one place. Pay in My Trust is the largest cost within it. It's about 80% of our costs. And so how we allocate this really matters to us. We use a two-stage approach. Other trusts may just take total pay divided total of activities, but we don't use that. We work out a pay cost per minute for every single staff member we have, because often it is one staff member that may be going out to visit one patient, and we work out their pay rate based on their clinical available minutes, and we apply that pay rate then to every minute that they have recorded against patients, whether that be around contacts or work to support the treatment of that patient. It's unlikely to allocate the full cost of pay because no staff member records 100% of their clinically available time, but it does provide me with some information. And what's left of their pay that we haven't allocated by what they've recorded directly to patients, we allocate as an overhead to their team. So if one staff member goes off sick after doing a contact, we don't allocate that full staff member's costs to that one patient. So we think it gives us a fair reflection of pay, and allows us to monitor and compare the staff resource usage. So staff A member is recording 51% of their time versus staff B member that's recording 75% of their time. Actually, if they're doing completely different roles and one does more of a managerial role, 51% might be wonderful and 75% might not be great if they don't have any of that managerial percentage. So it really depends on knowing your team and understanding your teams. But the main disadvantage of doing this, it takes time and effort, because we bring in information from not only our ESR information, but we're bringing information from our agency staff, our student nurses, any social care staff that have recorded information in our system, so we can identify who's done what, where, and to whom. This is an example of that resource usage table. It's not a perfect science because it takes up to work out the available clinical time. It's based on the staff member's whole time equivalent worked and applies the standard number of hours times an average number of weeks in a month times a deduction for holiday, sickness, etc. So here I can see on staff member R, there's 110% recorded in August, but I suspect that they've done a lot of overtime in August, but it's not been paid until September. And so we just know to look at the how this phases over a period of time and not always look at something in a month in isolation. The other information then that comes into our data obviously is because I found if we record what we do, I can start looking at things like did not attend, and actually why would I show still 61 minutes for a did not attend appointment, so our staff member has done nothing and waited for that patient for 61 minutes and we've not done something else. We've spent quite a lot of time working with did not attend and changing the way that we do, so we're making sure that we notify the patients that we're coming and reminders so we don't have as many DNAs. This table at the bottom looks at the travel time versus the total time recorded by patients, and actually staff member M here has spent 31% of their time that they've recorded against patients travelling, which seems a lot when D is only doing 8.9% of their time travelling. So we need to look at how we plan our routes to patients to try and make it that we can spend more time delivering care. So there is a massive focus on improving productivity within our trust. One of the projects that we've looked at is looking at how much time we spend doing note-taking and associate administrative elements of our work, which detract clinical staff from doing patient care. So we've started to implement lots of things like voice recognition software that transcribes and summarises consultations between clinicians and patients. It allows us to write up notes or even write up letters and converts medical speak into easy language for patients to understand. So it'll have the medical term, then it'll have in brackets something that the normal person would understand. And it allows us to update automatically into our EPR or electronic patient system the information that it hears. Obviously you have to check it, but it's certainly a lot quicker than people typing things. And we have a number of other schemes that we're using the AI for to make life easier. Since COVID, a lot of our staff work more flexibly, and so the use of our estates has changed significantly. Where everyone used to have an office before, now we use things like room booking systems to say which team has used a certain piece of estate for a particular length of time. So it allows us to track the sort of the overhead estate costs to the right teams that have used it. We obviously use HR and payroll costs, use whole time equivalents to allocate them. And there's different guidance provided by the NHSE that shows us how we should allocate the non-pay costs to the cost of delivering patient care. So we follow those guidances. Ultimately, if you add up all the granular costing detail, you can aggregate it back to view the data in a variety of ways. This is an example of one of my patients' journey through 12 months. This patient cost 132,000 to treat. They saw our GP services, our CMHTs, our physios, our crisis, our psychology teams, and also unfortunately had inpatient admission. But you can see that data in a variety of ways, and I've just included a few in here. So I can see it by month, what activities have happened. I can see the patient bill, and obviously I can see the patient, what staff members and who's seen the patient and when and what's happened with them. We can use the data to compare teams as well. So team 1 has the highest average cost per contact. These are all similar teams, just over different locations. Team 3, this one has the highest cost per contact, but it has the second lowest average cost per patient. So are they able to deal with the patient in a smaller time frame and help that patient on with their normal life by doing something different to the teams. Team 3 only records a certain portion of their time, 37% of their time as contacts, but Team 5 does 64%. It's sometimes to do with the way that we've recorded. Team 1 attracts the highest level of overhead. Team 4, the lowest. Is this caused by the team's base, the location, potential error in the allocation? And part of the data is always developing, so there's stuff that we need to add to these charts to make them make more sense to people and answer more questions. Costing information is not perfect, but the more it's used and shared and reviewed, the better it becomes. So if you get one thing from out of this today, is please go back to your costing teams, review the information, point out if you think there's something missing that could make it better and more useful to your services. And we can use it, obviously, to make better and more informed decisions on, so we can improve in our internal processes. When we started going through PLIX, the data wasn't as great, but we found issues around data validation and then data entry, and we sorted some system issues to make things better with that. We looked at the number and frequency of DNAs, and we've put in things like AccuRx, which sends out text messages to patients to remind them that we're coming and to make sure that they're home. We've reviewed the type of care that we're giving to some patients. We had one team that was having looked at patients that would be receiving more care and costing more, and then looked at them to see whether they would actually be better with a different service being offered by our trust, and reassigned some of the patients. Part of the things that we've improved around is also the guidance and training on how to record information, because if it's not in the system, we can't pick it up. And obviously for a clinician, seeing the patient is very key, but making sure we have a true record of what we've done with that patient has a massive impact on what we do and how we report and what information we can glean from that. We've done a lot of capacity and demand and productivity work with this. So we've looked at teams that look like they're costing expensively in our national cost collection when we compared against our peers. We've done capacity demand analysis. We've looked at what staff they have, how they should be working. Is there a better way that we could work? And we've redesigned some services using this to make things more productive. The ultimate aim is to release time from doing non-clinical work back to being clinical, and freeing up that process. And so we're able to explore the variations between clinical practice. I showed you that within a couple of teams where I've got different costs and different activities and different processes and methods in there. So it does improve the patient care. It does enable you to see comparisons and see variations and highlight potential areas of concern, particularly when I was looking at the things like around deprivation, and it opened a big can of worms as to why we couldn't get patients in the most deprived areas to engage with us. It also allows us to review the patient journey for planning purposes. Internally, it allows us to look at it for normal budgeting purposes, and also be aware of the impact if there's going to be a national health awareness campaign on referrals, and then ultimately the demands on our services. This information can be shared wonderfully with your ICB for them to help plan their spending as well. But the main area at the moment for us is looking at the focus on productivity and to see areas of overlap and duplication to streamline, to change what we're doing. So, and with that information, you can work with other organisations to provide a better patient care across providers. So we've done bits of work in the past with our acute hospital around frequent flyers that turn up in A&E that have a mental health issue rather than a physical health issue. So that's all I was going to say. Is there any questions? And I've not kept track of time, so I may have overrun. Apologies.
That's brilliant, Claire. We're a few minutes early, and also I think we've answered all the questions in the chat as we've gone along. So that's great. So thank you so much for such an expert and informative insight into the world of costing in a mental health institution. I'll just leave it open for a couple more minutes to see if there are any more questions. And whilst we do that, I'll just see if Richard Sawyer, our next speaker, is available.
Hi, Pam.
Hey,
Hi,
Richard.
Claire.
How are you?
Yeah, good, thank you. How are you?
Very well, thank you. And yourself?
Yeah, good to see you. Talking to you from sunny Devon at the moment.
Wonderful.
Yeah.
Excellent. So, if Claire doesn't mind staying on in the background to answer any questions in the chat, should they come up, that would be really helpful. And then, well, thank you again, Claire, and we'll see you again very soon. And at this point, I think I will hand over to Richard if you're ready. Thank you. Brilliant.
Yeah, absolutely. Hi, everyone. Lovely to see you all. And thank you for having me. You've had a lot of presentations sort of mentioning well, lots of the lovely Plix data that a lot of organisations have. So every trust has that. What I'm going to talk to you about today is what can we do with the data. And as part of One NHS Finance within the Finance Innovation Forum, so I program manage that. We've developed a end-to-end framework called EVO, and I'm going to talk to you about that for the next sort of 20-15 minutes. Just going to share my screen and hopefully you can see that. Okay. So I think sort of in the first instance, EVO itself sort of tries to integrate existing internal project support, informatics, facilitation, and more by enabling you as clinicians to focus on retrieving the data and presenting evidence to validate clinical assumptions. And it does this in a very sort of lean, agile way. And it is laser focused on just getting to a point of change, any change, however big or small that might be. So this sort of structured process enables a small multidisciplinary team to make decisions and get to a change, but also goes further to help teams measure that change. So in the face of obviously immense financial and operational pressures, it uses value-based healthcare principles. They're key, and I'll talk about them in a minute. And essentially it allows finance teams to sort of strengthen the co-ownership of decisions and become ambassadors of evidence-driven transformational change, using the data, leading with clinical assumptions about how to change specialties or services. And we'll go into that. So what is it? It is actually a book. It's about this thick. It's free of charge. It gets sent to your trust. Your board must approve the application. You need sort of senior responsible support from your medical director, your director of finance, and your sort of equivalent transformational change or improvement director as well. And I'll go into sort of the roles within that, but it's really important to get that in your trust so that the teams on the ground have the protected time to do the work over this sort of 20-week process. So over that 24-week process, a trust would look at 3 specialties. And to be very clear, this is an entirely trust-owned implementation. So there's no one coming in to the trust doing a dance and then leaving. This is all about levying and using the existing talent and skills within the trust already and giving them the authority to make decisions based on the data that's retrieved. Okay. So you can see through the broad element of what it is. And what I'm going to do now is go through the value-based healthcare bit. So you've heard a bit about value, but I'm just going to summarize it because it's really important when introducing topics like this to be clear about how you're talking about it. So value is defined in many different ways, and as a result, it's It's regarded as a concept or theory of measurement rather than an actual measure itself. So for the purposes of EVO, it's defined as outcomes or quality relative to the costs or resources. And that's basically to say it's widely acknowledged that focusing solely on cutting costs without maintaining or enhancing or measuring the quality of care can lead to false savings and harm the delivery of effective care. So as healthcare providers, we can't continue to make decisions about quality and cost separately. You'll have heard, SIPs and QUIPs and all of these, never the two shall meet. So as mentioned earlier, this framework sort of focuses on the sustainable quality improvement, and EVO uses this equation throughout to bring together cost improvement and quality improvement and the finance and clinical teams that are expected to deliver both of these under one numerical measure of improvement. And that's called the value impact comparison score, or VIC score. And I'll go through sort of the broad sort of high level sessions that you go through in that 20 weeks of how you can sort of realize and get to the point of change, but also do the really important thing that's not widely done, which is then use the measures that you've created through that process to literally measure the impact of that change, factoring for quality, and that's clinical outcomes, patient experience and safety, as you can see here, resources, risk, strategy, all of these things are factored from a qualitative perspective into a quantitative measure. And in the VIC score, you've got a percentage improvement at the end that you can demonstrate and share with stakeholders and your champions, they're called, the senior leadership team that applied in the first place. So who takes part? So there's sort of three disciplines, as I've gestured to. There's finance, clinical, and project. I should say up front, there's a bit of a space theme going on in this. It's broadly for a bit of fun, really. You've got to have fun with these things. And what we found is that coming in, clinical and finance colleagues have very set ideas about what the others' priorities are. And in some cases that can be adversarial, and it's difficult to agree what the biggest priority is, isn't it? Quality, productivity, efficiency, cost reduction, all of these different languages and all of these different definitions of those. So we use space to sort of bamboozle everyone, and ultimately that's been pretty useful as a vehicle to get to the understanding of a single measure and appreciation of the possibilities and priorities of change, which is value-based healthcare. So you can enjoy it if you choose to. Okay, so you've got the three core disciplines: finance, clinical, and project. And you've got the champions, and these are the individuals that sort of the senior responsible officers of that, and they'll make that application on behalf of the team. But they won't do the work itself. You've got this sort of core team within that, and they're made up of the leads. You'll have a finance lead, so the head of costing, so that's going to be the data lead. And you've got three clinical leads, because remember, they would do three specialties all at once in parallel. And then you've got the sort of two project leads here. So that's your PMO, so that's your project manager. And very separate to that individual is the facilitator or improvement lead. And you'll have a number of other participants in here as well. So specialty nurse, specialty finance business partner, informatics. But in sort of agile methodology, it's very clear that, you don't want to sort of scale up the team to be too large. So between 7 and 9 is the optimal way. And this core team will have the delegated authority to make decisions using the data from the board and the champions when they start their work. Okay. So this is the sort of broad timeline. I'm not going to go into too much detail here, but I can talk through what this looks like. So this is your 20-week journey. The launch, it's your kickoff meeting. All three specialties attend, the champions, the leads, everyone in that first bit. Everyone understands what their functions are, and you can see that the launch is the kickoff, and the landing will be the sort of show and tell at the end of this. And we've seen through a lot of pilots we've run that that's really a helpful beginning and end, because clinicians and anyone competitive alike in finance really want to sort of deliver on what they set out to demonstrate the ability to make change when they know everyone else is doing the same in the privacy of their own specialty over the next sort of 20 weeks or so. So that's been really helpful. And then you got 3 sessions after the launch. So it's the formulate, evaluate, allocate, and decide and plan. So in formulate, there's only 2 things that will happen in that first session. Bear in mind, we've got 3 simultaneously. But essentially, what will happen is the leads in that meeting will decide on the value measures or metrics. And this is essentially having a sort of using one of our value tools to establish what good looks like in your specialty. And you're going to have a list of them. We have a lot of we have a growing number of what that looks like. So if you're interested in more detail, we can show you an example of what respiratory good looks like based on the value criteria, safety, clinical outcomes, patient experience, etc. But you're going to set that and decide that in your team yourself at your level for your trust. And the other thing is you're going to have, there's various sort of feeders for this, but you're going to come up with 3 hypotheses or clinical hunches. What you think is, presents the most likely and most impactful opportunity for clinical transformation. And that's it for that first session. In between those 2 sessions, between formulate and evaluate, allocate, you'll go away, and the finance team, and supported by informatics and BI, will collect all the data that is relevant to those 3 hypotheses. That's a really important distinction, because typically you end up with these sorts of meetings ending up swimming through a huge data lake of data, and you end up in difficulties with data accuracy and quality. With this, we're leading with the clinical assumptions as the experts in the field, and they know their service best. So they'll come back with the data and evaluate, allocate. The objective there is to look at the data for those 3 hypotheses only. And there's a single objective at the end of this, and there's lots of sort of branches that you can, sort of logic branches you can end up in. But essentially the objective is to come up with one clinical piece of change, one clinical transformation. At the very least, generally we're finding teams come back with a load, but the only objective is to get to one opportunity for clinical transformation that's validated by the data. Fantastic. And then we have the 3rd session. And this is all about prioritization. And you'll go back to your formulate, you'll grab your value measures, and you'll put them together, and you'll use those value measures as indicators of what good looks like to rank and prioritize all of your options. I've got some screenshots, but they're a little busy. So if you're interested, there are 3 animations on the Evo website that explain it a lot better than I'm doing to you now. And you can look at them at any time, and that explains this in a lot more detail. Once you got to the end of decide and plan, you'll have a project plan, you'll have a decision tree, and you'll also have a stacked prioritized list of things that you can go to change at that point. And they'll be prioritized for risk, strategy, quality, and cost and resources, and capacity to change as well. That's all in one sheet. It's going to be really powerful taking that to your board. Then you've got essentially the landing. So it's the show and tell of what was discovered, what could be changed, what's the most accessible to be changed. And then beyond the landing, we've got the actual transformation itself. Now there's PDSA cycles, there's various other implementation and change protocols that exist within trusts already, within the transformation team. And we're working with the HPCA and some other organisations to see if we can provide an out-of-the-box implementation of change, because what we found is that taking these changes, once they've even been made, there's loads of opportunities in trusts. The changes themselves, we can get to that point. Actually implementing the changes, particularly at larger acutes, is a challenge without the sponsorship and ownership of the board and requiring sort of reports back. So we're working on that development at the moment to try and provide that support and bring the accountability of the board forward to implement real change with that team. Okay, and we're seeing that in smaller acutes already anyway. Once the change has been implemented, we will have our PLIX data. We will be measuring these, and this is sort of the adjustment from PDSA to PDSA plus. It's the inclusion of that patient level activity and resource data there. So there's one final meeting at the very end of this process, which is your impact assessment, and that impact assessment will involve everyone meeting up for 1 hour, reapplying to a third value tool to produce the value impact comparison score, and making a direct assessment between the specialty and change area before Evo started and after the change itself. And we'll be able to see the improvement against all of the what good looks like factors. Again, you can have a look at the animation for more detail. So these trusts are ongoing, various stages at the moment. We've seen some really impressive outputs and wins here with the project, particularly most recently North Staffs. So in their adult mental health services, they've gone through this process and recovered 676 hours through the identification of text reminder service, which equates to about just over $250,000 of realised funds by March 25, which was a few months ago now. But they did that work in October, which is really good. And in the same trust with acute and urgent care, essentially triage moved from an average of about 160 days down to 30-day average, which is a really good improvement. And all actual direct triage moved from around average 2 weeks to everyone being seen next day moving forward. So it's fantastic, and there's presentations that have already been made and will be happening in the next week, in the next sort of month, and a couple of weeks at the Leadership Summit to articulate some of these improvements. Okay. That's a demonstration of a different implementation around adult memory service pathway redesign. You can see some of the numbers and benefits that was done from an earlier implementation of EBO a few years ago. So we work with lots of organisations. That's not even half of them. I need to update that slide. Apologies for it being out of date, but this is based on existing and impressive work. Notably, the Nottingham University Hospitals with the WAVE programme. That's been in train for many number of years, and we've worked really closely with Richard and Scott and the team there to try to bring EVO to and make it accessible, this type of work to organisations up and down the country. I don't need to give you the process for the application, and that's probably me finishing early at that point, but I'm happy to stick around for any questions, and I hope that's all right, Pam. Thanks.
That's been fantastic, Richard. Thank you so much. And thanks again for spending some time with us this afternoon. We do have one question, I think, that's come through from Anna McLean in the chat. So we've got a couple of minutes for questions, if that's okay. Do you want me to read it out, or are you happy to pick it up?
Put on the mute. No, I'm happy to. So if you've already completed QI project and have data, you can apply this process retrospectively. So I think you're talking about the production of the VIC score, and yeah, in principle, Anna, if you have, it's very important to compare sort of apples and apples, as it were. But we've done some work with the WAVE programme where we've retrospectively applied the VIC score to some of their respiratory and sterile services work, which have demonstrated a fantastic and notable improvement in terms of percentages of what they achieved. The clinical teams really appreciated that, and there's a video sort of talking about that because they're able to talk quantitatively about the improvement that they've made. The process of doing that would require the clinical team and the finance team sitting down and clarifying and defining what good looks like in terms of improvement metrics. If I can find a slide very quickly, I can show you what that looks like. But yes, it is absolutely possible. In terms of the scale and your second part of that question, this is specifically at trust scale. If you don't want to do 3 specialties all at once, and you're worried about the resource, which we are hearing quite a lot, you can do it in less. We're not totally prescriptive about this. There is significant benefit in doing and learning 3 at once. When we think about system implementation of this, we are looking to work with a number of systems in the next sort of 6 months in developing this up. But my guessing your question is, it's already large scale. Can we do this on a smaller scale? And what you've got under the belly of this 187-page project management manual. It's 3 tools. And very simply, those can be accessible. It's what does good look like? Let's measure it and put that into a structured format. Get to our decision, validate data. How do we prioritize all of these options for change or the changes that can be made? And then do the change, and then let's measure the impact that change has had using the 2 previous tools. Those 3 can be used within any project to genuinely get a measure of how the impact on value-based healthcare as set by the team itself. That's the very lightweight version, and it can be jumped onto any sort of existing improvement methodology if it wants to. EVO is the whole thing end to end. The value improvement tools are being worked up and developed so that actually they can be used quite easily in isolation as well. I hope that helps and answers that question.
That's brilliant. Thank you. Thank you ever so much, Richard. I think we'll see if the next speaker is available, who is Coral Nicholson, who is going to do...
There.
Hi, Coral. How are you? Lovely to see you again.
And you?
That's brilliant. So we'll say thanks again to Richard. I'm sure he'll be there in the background in case there's any questions on the chat, Richard. Appreciate your time again. And I will hand over now to Coral, if that's okay. Thank you so much, everyone.
Thank you. I'll try and share my screen, should I? That'll be... let's try this. Will this work? Thinking about it.
Yay. Looks like we're good to go. Yes.
Okay, let's hope it works, because it always looks different, doesn't it, when you are on this type of call. Anyway, I'm sure it'll be fine. So today I'm giving a talk on the introduction to clinical coding. My name's Coral Nicholson. I'm currently the senior finance lead for service development at Specialised Commissioning, based at NHS England. Who knows what I'll be doing in a year or two's time, but anyway, that's where we are at the moment. So firstly, what are we going to cover? So what is clinical coding? I'm going to quickly go through the different types of code. So ICD-10, OPCS, HRG, TFCs. I'm sure there's loads more codes than this, but I'm just going to restrict it to those 4 codes, and then go through why is accurate coding important. So firstly, what is clinical coding? So it's the translation of medical terminology as written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking medical attention into a coded format which is nationally and internationally recognised. This has gone, I've clicked the wrong button, which doesn't help. It's not letting me move on to the next thing. Let's try a different button. A different button. So what's the process? So the patient goes home after, of course, they've been in hospital. I should have put that first, shouldn't I? They've been in hospital. Something's happened to them. They know what the diagnosis is. They have a procedure. And then they go home because they're better, in theory. Let's take it like that. So we have a patient administration system. So the admission has to be coded. And the coders study the records. And they use coding standards to code each and every patient. So there are 2 types of codes initially. Is this going to work? It stopped working again. Working. So
maybe there's just a timing difference.
I think so.
So
I'm being impatient, aren't I?
That's okay. Maybe if you start explaining it, it might magic it along.
Yeah.
That's brilliant. Thanks, Coral.
So there's you can either have a diagnosis code, which is the ICD-10, so that's the International Classification of Diseases, or you've got something called an OPCS code, which is basically the procedure or what is being done to the patient. So there's a massive long list in this thing called the code to group. So if these slides are circulated after this call, you can click on that link and it will take you to the HRG4 Plus grouper. And if you select the code to group, it literally has a tab with all the diagnosis codes and all the OPCS codes. So I'll give you an example of coding something. So my daughter was diagnosed when she was in my tummy with a ventricular septal defect, which is also known as a hole in the heart. So there she is at 3 months old, and there she is before. The first picture is when she was taken into hospital at 3 months old, ready to have this hole in the heart procedure. So she had her procedure patched, her hole, sorry, patched. And there's the before and after pictures. And then there's the picture at 6 months. So she came in and she was diagnosed with a Q210 ventricular septal defect. So that's the ICD-10 code. And the procedure that she had at the Royal Brompton at the time was a K13.1 percutaneous transluminal repair of defect of interventricular septum using prostheses. Sounds very complicated, but yeah, it was patching a hole in the heart. So why is accurate coding important? I'm going to come back to my example in a minute of Amelie, her name is, my eldest. But I work in finance, and so it's often used, or it's always used, as the basis for payment. You can see it's not working, can't you? Because I'm trying to talk and it's not coming up. But yeah, we use it as the basis for payment. And this is going to drive me nuts. Okay, it's going to work again on a different button. So here we go. We'll try this now. So what we do is we take the diagnosis code and we take the OPCS code. And when you go into that document that I talked about, the code to group, there's a tab on there called the code to group. And you select the either one of those. It's pretty obvious when you look at each one. Most of these will be OPCS code driven. And let me just explain a little bit more about healthcare resource groups, so the HRG. Basically, you know, procedures that hospitals do, which have similar sort of amounts of resource that go into it, can be grouped together and designated an HRG. And anyway, the list of HRGs is found in the Annex A. And again, there's the link there to the 2526 NHS payment system. And this is all the HRGs are listed, as much as you like. So going back to my example, when you put in the ICD-10 code of a VSD and an OPCS code of the transluminal, whatever it was, basically a patch hole in the heart, it comes out as an EC14. And then you have 3 different types there, A, B, and C, of varying degrees of complication. And obviously, if the patient is one with more complexity, then the hospital will be paid more. And if they're of less complexity, then they'll be paid less. And I'll go into that in a little bit more in a minute as well. Anyway, today the good news is she's a teenager and she's always on her phone and she looks exactly like that. It might as well be an exact picture of her, these teenagers. Anyway, so going back to the scope of HRGs, so we have an HRG for elective inpatients, emergency inpatients, any like direct access and outpatient diagnostic services. So all these different types of scans, they all have their own HRG. Direct access and outpatient nuclear medicine services, chemotherapy delivery, external beam radiotherapy, all of those things have their own HRGs. But outpatients are not coded in the same level of detail because, well, one of the reasons is the sort of level of information that's captured on an outpatient is nowhere near as detailed as that for an inpatient. But we have basically 4 HRGs linked to outpatients. WF, the O1s are when a patient sees a single professional, and the O2s are when the patient sees a multi-professional, so more than one professional. Tends to be a consultant. And the B's are the first attendances and the A's are the follow-up attendances. And then every single outpatient then has to have a treatment function code. So in the case of my daughter, we were seen in paediatric cardiology, which from memory is 421 or is it 621? Anyway, one of those. That would be the treatment function code. And of course, we had a first attendant seeing for the first time, and then we had the follow-up after the operation. Anyway, so which HRG? So as I say, there's a whole long list of HRGs, and per this code to group document that I'm talking about, but a lot of information goes into it to establish which HRG. Remember, we've got A, B, and C in the case of the EC14s. Some have all different letters, but this is just the example I'm giving. So for like admission method, so if a patient comes in as an elective, so it's known, then of course that will be one cost is assigned. But if they come in as an emergency, those that amount linked to the HRG tends to be much higher. Length of stay will impact on the amount that a hospital gets paid. The age of the patient impacts because paediatrics tend to get paid more, for example. Anyway, we get all this information, we put it into the grouper, and it spits out the HRG, and therefore the HRG drives the amount of money that a hospital will be paid. I accept that there is quite a lot of complication these days in because the national payment system has changed considerably, I'd say, since COVID. But the general rule with something like elective, as it stands at the moment, is we want hospitals to be doing more elective work. So in theory, we're paying on a variable rate, but there are complications, there are complexities. I accept that. But I'm just giving you the basic, this is how it should work. So going back to this, I've already showed you this. So this is the day case elective rate. And then you've got, it states what the long stay trim point is. So for example, on the EC14A, that's the most complicated or complex type of patient we could have for this. It would be expected that after that their time in hospital for a procedure such as that patch that I was talking about, they'd be in for 11 days. So then we've got the non-elective, and you just get to see the comparison between firstly the costs and secondly the trim points. So as you can see, the EC14s for an emergency, 14A rather, is much higher. So instead of 11 days, it would be 61 days that the patient would be expected to stay in. And then anything over and above the trim point would be paid at that per day long stay payment, 318. And that will be a marginal rate. So hospitals won't then continue to recover. It'll be harder for them to cover all their costs if the patient stays in much longer. So then again, carrying on with which HRG, we put in the primary diagnosis, as we've said, we've put in the procedures, comorbidities. So as I've said, if a patient is more complex, the hospital will attract a higher amount for a patient like that. So for example, if you have a patient that has diabetes compared with one that doesn't have diabetes, there's going to be more, they're going to have to take more things into consideration, and it might be more complicated to manage a patient like that compared with one that doesn't have that comorbidity. And then you've got something called interventions, which are procedures. I'll just give you an example of the interventions there. I'm not sure why I picked these ones. I just buttock lift. But anyway, they're examples of things that a hospital can do, but it isn't driving the HRG in its own right, but they've still used resource to go into it, and so should be recompensed for it in theory. So that would go some way to increasing the amount of income that a trust would receive. And laterality is all about basically the more information that a hospital can provide, laterality being, you can state where on the body that a particular procedure would have taken place. In theory, there'll be more money attached to giving more granularity in detail of data in theory. Anyway, put all that information in, and the grouper will spit out an HRG. And of course, we need to add in the market forces factor. So a hospital based in London, say, would be to have their MFF applied on top of the HRG income that they will be due. And of course, a hospital in London is going to be more expensive than a hospital up north. So market forces factor just tries to take into account that, really. Anyway, going back to the value of recording all the comorbidities linked to a patient. So this just gives the three examples of the EC14s linked back to my daughter's example. So you can see what goes into increasing the amount of income that that a hospital could possibly get. So the base HRG is the EC14C. That's the simplest and the lowest complication, really. And as long as you have a primary diagnosis of a Q210 ventricular septal defect, then the hospital will receive, in theory, 3,701 for an elective and 5,962 for non-elective. And of course, MFF, I've put in 16.1% there because that is the trust that my daughter had her operation at, which was a London trust. Anyway, then tier 1, as you can see, we've got a comorbidity and complexity score rating now of between 4 and 8. So the patient's becoming more complicated. And in this case, it's down to the secondary diagnosis. So if somewhere in there, there would be, I mean, there's lots of things that go into this. I'm just giving an example of what can drive this. But if, for example, a patient also had a Q208, other congenital malformations of cardiac chambers and connections, or a Z880 personal history of allergy to penicillin, that would drive the elective and the non-elective price up. And then similar with the tier 2 HRG, you can see the secondary diagnosis is getting more and more complicated. So other secondary pulmonary hypertension or a personal history of allergy to anaesthetic agent. I mean, it's going to be pretty difficult if you're having open heart surgery. So I hate to think how that's dealt with. And Z877, personal history of congenital malformations, deformations, and chromosomal abnormalities. So all these things can lead to a higher income in theory for the hospital. So when it goes wrong, and it does go wrong sometimes, but most of the time I'm sure it's relatively straightforward. But this is an example that my old boss, she's now left, but she used to tell me all the time. I used to laugh at this. So years and years ago, and we are talking years, so about 20 years ago, she had the case of, she was studying the data and she was thinking, and of course, it was far more expensive than it should have been. So what should have been coded was the diagnosis code of K028 other dental caries, which is probably like a clinical way of saying a filling or something. It's probably a bit more complicated than that, but you know what I mean. And that would have grouped to the CB02 non-malignant ear, nose, mouth, throat, head or neck disorders. But what actually was coded was the OPCS code K028, other specified other transplantation of heart, which groups to an ED05 standard heart transplant. Now there's a big difference in the cost. So these got mixed up, and something that should have cost around, so I mean that's an expensive filling, so I'm sure it's very, it's something far more complicated than that, and I'm just simplifying it. But anyway, something that should have cost around 1,700 cost closer to 110, hence why she was querying it. So it is important because it does drive how patients are coded, and obviously the income that gets attached to them. And then here's just another slide of, why is it so important? It's especially important to me. So parliamentary questions, we get those in at NHS England. And we're forever having to sort of run data extracts and trying to, provide evidence of whatever the question may be. We get freedom of information requests. Again, we need to use that information. For me, it's the basis for, as I work for a commissioner, it's the basis for how we sort of implement new services. and then you've got the epidemiology studies and the etiology studies, so very much looking at sort of causation of diseases and whether there's any links, and you know, looking into trends of diseases and outcome measurement, clinical audit, health trends, financial flows. Obviously, that's an important one to me. Case mix planning, again, or if the information we're looking at is total nonsense, how can we plan services around total nonsense? So yeah, it's very important, clinical coding, very important. So I was just going to give you an example of how I use coding, especially. And I mean, it's a shame, but clinical policies are currently on hold, or any that cost any money are on hold anyway. But in theory, in the good old days when they weren't on hold, I would receive the policy proposition, which would detail what the policy was, a policy being basically a new treatment of some description, whether that be a new drug or a new device or a new procedure. And then I would receive the integrated impact assessment as well, and that would detail what would the patient receive currently, because I would then have to consider, you know, is there any savings linked to this, or is it going to be a direct increase in cost? And anyway, I can guarantee I'll have loads of questions, and then I would meet with the commissioner and a clinician. Usually the clinical fellow helps us out, and they tend to be the middle person going to and from NHS England to the clinician who'd be the lead clinician wanting this to happen. And 9 times out of 10 with a new policy, I have to run a data extract on all that lovely data, sus data, with all the coding. I need the coding to see, you know, what the patients have been diagnosed with and what their treatment has been, because otherwise I can't work out what the current treatment position is. Anyway, then I do a lovely finance model. They really are beautiful usually, and complete all the paperwork. And that stack is not an, you know, that we have stacks and stacks of paperwork linked to any policy. But anyway, and then in theory it would go to CPAG, and CPAG is the Clinical Policy Advisory Group. This is at Specialised Commissioning, by the way. We used to have £13 million available every year that we would assign to new treatments, and we would tend to get around about sort of 9 policies, and then we would rank them based on their relative clinical benefit, and then we'd overlay the cost, and we would never let the costs are done totally separately. So basically, when we're discussing the clinical benefits, we do not have the cost in mind, but we overlay that afterwards. So because we just want to be very clear that we are ranking based on clinical benefit without being influenced by what the cost is. So it is a good process, because the cost still has to be taken into consideration, but it's laid over the top afterwards. And of course, anything that comes out at the highest clinical benefit but the lowest cost will pretty much be funded in the good old days, and obviously vice versa. So anything with low relative clinical benefit but high relative cost, chances are you're not going to have enough money to fund that by the time. But if for some miracle, when we've put them all in that square, and it just so happens that we've got a low cost year, that if we can lay it out and make it, you know, come within that 30 million, then in theory we could fund it. But I've never seen that happen so far, because normally a lot of them are quite expensive. Because we're talking about specialised commissioning, we're talking about you know, treatments that tend to be for patients where they've come to the end of their treatment pathway and they've got no other options, and that tends to be fewer, because we're talking about specialised commissioning. It tends to be, you know, low activity numbers but high cost, because they tend to be new treatments coming into the market sometimes. Anyway, and then I'll just say what else we all do as well: clinical policies and service specs, service specifications, where we state the sort of level of quality that we're expecting trust to provide for a particular given service. All of this requires data, accurate data. And that's it really. Any questions?
Thanks, Coral. That was amazing. I always enjoy these sessions because it helps to refresh my knowledge as well. So I think we've started to answer some of the earlier questions in the chat as we've gone along.
I think you're quite. I think you're a bit quiet as well. Are you just quiet to me? Maybe you're just quiet to me, of course.
I think. There you go.
Yeah,
Is that
you've got-
better? I
Ah,
think my
yeah,
microphone was
much
out
better.
the way. Yeah, no, thank you so much. I remember one of my colleagues who was a clinical coder, and she had this massive thick book of all the different codes, and I was like, wow, that's like a completely different language. So it's amazing what you do and what all the coders do in organizations. We do have one question that's actually literally just come through on the chat, a new one from Neil Mani. I'll just read it out for you if that's easier. How much difference is there between tariffs for a single professional versus multi-professional in outpatients department? Do multi-professionals only have to be 2 or more? Can it be from the same specialty but different health professionals, e.g. for a consultant and the specialty nurse, or does it have to be more than one specialty disciplines? So I think this is about MDTs and multidisciplinary clinics, because there is a subtle difference, isn't there, between multidisciplinary tariffs, isn't there? So it's very technical, so I'll probably hand that one over to you.
I don't know whether I know it. I mean, I can show where it is in the Annex A. Although I was trying to work out how to stop share. How do I come out of this and stop sharing it?
In your share, can you see your share button in the top right hand corner? If you just click on the X, that should stop sharing.
There isn't an X.
No.
Let's try. Yeah, I mean, that's what I mean. It's a bit strange because there's. Right, hold on. Let me just come out. I think I'm gonna escape and hope that's gonna work. No, that hasn't worked either. Oh, I'm sorry, everybody.
It's okay. Well, we do have a coffee break after this session, so we'll see if we can try and answer that during the coffee break, if that's okay. Oh, there we go. It's done it.
Has it done it now?
Yes, done it.
I was just going to show you just going back to that. It's going to quickly show if you can see that. It's gone back onto the other thing, it says here.
We can now see a spreadsheet with lots of different codes.
Good. So this is the code to group that I like talking about. And I'll make it a bit bigger, although it's 100 already. But so the bottom it says OPCS. So these are all the procedure codes. So excisions, biopsies, you name it, they're all listed there. Diagnosis codes on the ICD-10 codes. Again, anything you could ever imagine is listed here. And let me tell you, it's annoying when we find a new disease, which doesn't happen very often, but any of these things new, because what we do tends to be new treatments. When they don't have a code, it's so annoying, but it's lovely when they do have a code, and most do have a code. And then the code to group, I was just going to say, so that's the code to group tab, which you won't be able to see. But like going back to my example of my daughter, so you can see the HRG is driven by the OPCS code K131, and there's the HRG EC14. And then there's a whole load of complicated rules that I'll have to tell you about another day. But then going back to this question on, so now we're on the Annex A. God, that document keeps going. So Annex A, if you go to outpatients, here's the list of all the different treatment functions codes down the left-hand side, and then you can see the difference between so these are the first attendances on the left, and then the follow-up multi-professional on the right. So you can see it goes from 88 to 134 and to 283. I mean, I don't know what the rules are. I'd have to look up. It's in the guidance, but the specific rules as to whether it can be say for example, 2 consultants in the same specialty. I don't know whether it applies to that. I mean, it definitely applies to different specialties. But yeah, I'd have to check the guidance. Sorry.
That's okay. Hope maybe we can do that in the coffee break or something.
Yeah.
We do have James that would like to ask a question. James, if you'd like to go ahead.
Thanks, Pam. Hi, Coral. I've been loving all these sessions today because it's taken me back to something I did quite a few years ago in the NHS, and I always loved all this clinical coding stuff. One of the things I remember, though, and sorry, this is probably more specific to general data rather than specialist, and it's specific to PPR, which I know not everybody is using at the moment. But we used to get a lot of patients who are misattributed to the wrong commissioner, or there used to be a lot of talk about poor or low coding and how that would affect what providers were able to claim back in terms of funding. And there was a lot said back then about initiatives that would try and completely kill off misattribution or would completely try and improve coding to a point where that was no longer a debate between providers and commissioners. Has that happened? Is it better now? Do we know? Have we cracked it?
It depends. I'm not sure of what are you talking about, the distinction between commission, who funds it, ICBs or SpecCom?
No, so I mean, sorry, more specifically, I know it's not the coder's fault, but if in the records or what was picked up from the records, it suggested that a patient was registered with a doctor in, say, North Central London. Actually, they'd since moved and they were registered with a doctor in North East London. Of course, the wrong commissioner would receive the bill. So there was always this talk about making sure that records were up to date and that what came through in the coding and what came through in the charging mechanisms was always sent to the right commissioner. And I just wondered whether we'd tightened up on that at all in the last 10 years or so.
I mean, I'd imagine so. To be honest, I work for NHS England now, don't I? So I don't work for a trust anymore. I used to work for a trust. I don't recall that being one. We had lots of other issues. That wasn't one of them. I mean, I'm sure it was in a small amount, you know. I mean, all I would say, and maybe I'm speaking out of turn, but I do feel that, you know, there was up until COVID, obviously, there was a huge link. You know, a main link, wasn't there, with PBR? So of course there was I feel, I might be speaking out of turn, but I feel that there was a much bigger incentive to make sure that everything was coded accurately, because it really was based on what trust would get paid for exactly what their coding said. Now we are moving away from that more and more with like fixed contracts and so yeah. I mean, that's my personal view. I might be wrong, but that's the feeling that actually, if anything, we're not as hot as we should be, because it shouldn't just be for, as I've said in today's presentation, it's not just about the finance. It really is about how we shape services going forwards. It's as important, isn't it? Really, we don't know what patients we've got. We don't know where there's a gap in the service, etc., etc., etc.
Yeah, of course. Okay, interesting. Thank you.
Thanks.
That's great, Coral. Thank you so much. And I think from what you were saying, there's also a link to other kind of benchmarking that appears in model hospital and health data in terms of depth of coding and also like morbidity rates and things like that. So I think that gets captured through coding as well as the finance. So it's a big world, isn't it? So at that point, I'll say thank you. We do have a question in the chat from Deepak, but I think that's in relation to mental health periods of care, and I'm not sure whether you're able to answer that, because we did have a previous speaker talking about mental health coding. So what we'll do is we'll reach out to Claire to see if she's still available to answer Deepak's question. But in the meantime, I'd like to say a big thank you to you again, and look forward to seeing you again on the next Demystifying Finance. And at this point, I think we now have a short coffee break, and we're due to be back online at 3 o'clock.
Up next, I'll just share my screen. Bear with me.
Thank you.
We're all doing all right on a nice sunny day.
Thank you, George,
right.
and welcome.
Thank you very much. So my session is to go through primary care finance. What I will be focusing on will be general practice finance rather than pharmacies and dentistry. Obviously, they are two pillars of primary care, but the bigger one, the one that we obviously have more dealings with and are more complicated, is general practices. So I'll run through fairly quickly, or as quickly as I can. I'll squeeze it in as close as I possibly can to half an hour. I'll stay around afterwards for questions. So if there are any questions, feel free to pop them in the chat. If I don't get to them whilst I'm presenting, I will come back to them afterwards and respond to any then. So what are general practices? Well, general practices are small to medium-sized businesses, and their services are commissioned by NHS commissioners, and they are there to provide medical services in an area to a population. Mostly, general practices are operated as partnerships, so there's more than one general practitioner within the practice that offers those services. They can be individual GP, so an individual GP can hold the contract, but generally we see that there are more than one GP that holds that contract, and they work together as business partners to deliver those medical services to their locality. There are some partnerships which were previously at a much smaller scale, which have now merged or taken on additional contracts, and they are now termed as super practices. So they offer services to a much larger population across many locations, and again, that just enables them to share the resources over a wider area. Limited companies can hold contracts, but generally most of them are unincorporated individuals or partnerships. And if they are unincorporated individuals or partnerships, then those partners are jointly and severally liable and responsible for the partnership's dealings. So unincorporated businesses, as already touched on, they're the sole practitioners or partnerships, and they're the individuals that are partners, or the self-employed individuals are self-employed. They have to report their earnings on an annual self-assessment tax return. They don't get paid via PAYE. They can have GPs which are employed by the practice, but they aren't the partners or the owners of that contract. So they will just be salaried GPs rather than GP partners. If they are an incorporated business, then they have limited liability. As I said, some limited companies can hold contracts, but generally most of them are unincorporated, and LLPs are an alternative option. But again, generally we don't see many LLPs holding GP contracts because of the restrictions that are in place with who can hold a contract and how you'd go about moving from an unincorporated business into a limited company. The novation of contracts becomes much more complicated. So we don't generally see many limited companies or LLPs. The downside as well for limited companies or LLPs is that the accounts are publicly available. They're freely available on the Companies House website, so you can find a limited company or an LLP, whereas for an unincorporated business, you can't see any of that information, because all the individuals have to do is submit a tax return to HMRC, which isn't freely available. If you're a partnership or a self-employed individual or a member of an LLP, you are self-employed for income tax purposes, and you will pay tax under the income tax regime. If you're a limited company, the company itself is a separate legal entity, and that will pay corporation tax to HMRC, and then the retained profits are sheltered from income tax unless the individuals, the shareholders of that business, draw that money out of the company. So there's three different contract types within general practice. First is a GMS practice, General Medical Services. That is a nationally agreed contract. So as things change across the nation, those services are the funding and the services that are offered change within those practices under a GMS contract. PMS practices, they're again reducing in number. They are personal medical services. The reason that these are reducing in number is because those contracts are locally agreed, but they do get uplifts which are linked to the General Medical Services contract. because they aren't on a because they're on a locally agreed contract rather than a nationally agreed contract, there is some element of risk there, which is why we've seen them being phased out in some localities. But obviously there are still a few in there. And then there's a third one, the alternative provider medical services. And again, this tends to be where you've got additional contracts that can be up for grabs for practices to effectively take on for a short period of time, for a longer period of time, or alternatively, they've been novated across into a limited company. Limited companies tend to be the ones which we see holding more alternative provider medical service contracts. There's a link there for an acronym buster. We love an acronym in the NHS. There's thousands of them. That is quite a useful link for things like this. If you hear someone say GMS, PMS, APMS, you can sort of find out what those are, and obviously the other terms as well on that link as well. So I'd recommend having a look at that as well. Within a practice, there's several different income streams, and this is why they are more complicated, and one of the more complicated areas of primary care finances. So you've got the main contract income, the global sum. You've then got PCO administered income, enhanced services, primary care networks, which I'll come on to in more detail later, QOF, premises dispensing, other non-NHS, other NHS, and reimbursements. So if you are on a GMS contract, you get paid based on the number of patients and the weighted patient numbers in your practice. So we're all registered at a GP practice. That GP practice that we are registered at gets paid in 25-26 £121.79 per annum if we don't go and see them at all, or if we go 100 times, they still get paid £121.79 per annum for us. They get paid based on the weighted patient numbers. So what that means is we're all registered. We all have different localities, different areas that we're in. The weighted patient numbers are there to effectively adjust the raw patient numbers, so one individual, and either increase or decrease that weighting based on whether there is more disease prevalence, the rurality of the practice, the age profile of the patients that are listed at the practice, the sex, various different things to affect the weighted patient. So if you are a university practice with a lot of young patients, you will have a much lower weighted patient number than if you are a rural practice with a lot of elderly patients who have a greater disease prevalence because they will require more services. So therefore, the weighted patient numbers are much higher for those. You'll get the global sum payment on a monthly basis, and it changes each quarter based on who has registered or deregistered with that practice each quarter. So as I've sort of said there, the practice patient weighting is based on the Cahill formula. So it looks at patient age, sex, number in nursing and residential homes. There has been talk of formula reviews. It's never amounted to change. And this was put in back in 2004, I believe, when this formula was originally introduced. It's never changed since, despite there being mention of it perhaps changing, and it is outdated. It does need to change, but as of yet, nothing has. Potentially with a new contract coming in the near future, over the next couple of years within this term of Parliament, there will be a change to that, but that's speculation. So as I said, the university practices do tend to lose out under the Cahill formula because of the fact that their patients don't have quite such a high disease prevalence. What practices could also do is opt out of out-of-hours services. So out-of-hours services where you would have access to a GP at any time of the day. So if you needed a GP at 2 a.m, you could call your practice and they would have to provide you with a GP. That opt-out cost is 4.75% of the practice's global sum, temporary residence and London waiting if applicable. And that is a bargain. Basically, the cost of practices offering the out of hours charge, out of hours service, is significantly higher than 4.75% of their global sum. So generally, I personally haven't ever seen anyone not have the out of hours deduction. I don't know of any that do, and that is purely because it is such a bargain to do that. The PMS opt-out cost is linked to the same GMS contract cost as well. Temporary patients, so this is based on historical claims over the 5 years prior to 2004. Again, it's outdated, so this is for people that were perhaps on perhaps traveling and needed access to a GP. They could call a local GP practice which wasn't their normal GP, and they would be listed as a temporary patient, and the practice would get funding for that. And if you have been a PMS practice or know of a PMS practice which is transferred over to a GMS practice, a GMS contract, then they should have put a claim in for that income as well. PCO administered income. So this is for locum cover. So if you've got a GP that goes off on maternity, adoption leave, sick leave, they can claim for the costs of employing a locum GP to cover those sessions that the GP that is away would have been doing instead. They can get paid the amounts that are listed there. Those are ceiling amounts, so they can't go higher than that. If the cost is actually lower than those, then the practice can't claim the ceiling amounts. They can claim how much they've actually incurred. They can also claim on top of this, if they have locum insurance, they can claim through their locum insurance, which is an external provider. But these are the NHS funding ways, funding amounts. So I won't spend too long going through these. And again, you've got other ones in there, payments for locums for suspended doctors and the retainer GP scheme. So this was brought in for GPs that were looking to leave the NHS, whether that be to retire or had just effectively didn't want to be within general practice anymore. You could apply for a retainer scheme, which was funding to effectively pay for that GP to remain in practice, and that is to cover their sessions up to 4 sessions a week, and the reimbursement rate is there, £16,000 per year for retained GP. Enhanced services. So this is where a practice gets funding based on the services that they provide. So if you go to your practice and you have your annual flu vaccination, the practice gets paid for that. They do rely quite heavily on the flu vaccination income. It's quite a big part of their funding streams. There has been quite a lot of competition in recent years from pharmacies, from supermarkets. The practices obviously get paid for it. They would benefit heavily from people going to see them for their flu immunisations. So they do try to push that quite heavily. They get paid for various different things. The item of service fee for those vaccinations, so flu vaccinations, shingles, rotavirus, etc., is £10.06 per dose. The only change to that is that it has increased from £10.06 to £12.06 for this current year. So they do get paid more now for routine childhood vaccinations. So they're the ones which they have to have. I think it's up to before they go to school, they get paid that £12.06 for those vaccinations that they have to have. They do get paid different rates for different things. So weight management, if they see a person who is overweight, and they can refer them on, and they get £11.50 per that per referral. They have also introduced a new advice and guidance enhanced service. So practices are going to be paid £20 per every referral and advice and guidance request. So this is where they effectively ask for a second opinion from a consultant, refer it on, and they will get paid £20 per item of service per service that they provide for that one. And that will be capped per each ICB. So each integrated care body will have a cap on how much they can spend. So we yet to see how exactly that will be structured across each ICB, because I dare say there will be people that will make more applications and do this service more frequently, so they might have to cap it for different practices. National Enhanced Services, so these are the Direct Enhanced Services, National Enhanced Services. They're amended to suit local conditions. What you will then have is locally enhanced services. So these are the ones which are offered depending on what is occurring in each locality. So you won't see these across all locations. Some of them you won't see in many at all. Some of them you will see quite frequently across various different localities. But again, it varies significantly because of the locality and the various different diseases and disease prevalence that is in each local area. So primary care networks was a big thing, and that's a big change to how general practice is funded. So 5 years ago, 6 years ago now, July 2019, these were introduced. It was originally set up as a 5-year service, and it was to enable, again, practices to work closer together to develop networks, to share their workforce, and basically to be able to provide better care to the area. That has expanded quite significantly. And what PCN is, as I said, is effectively a group of practices which work together within the community, and they offer various different services. They build on those existing services that the general practice provides itself. PCN itself, in most instances, isn't set up as a separate entity. We are seeing more and more now go down the route of incorporation, but sometimes, or most frequently, we're still seeing those practices having a lead practice which receives the primary care funding, the PCN funding, and that is then distributed out to each of the member practices, and they can have issues with workforce. So this is for additional roles and responsibilities. So what you have is an individual who is employed by a practice but works across different practices. So there's a potential supply of staff, which is a vatable transaction, whereas if they are there to provide healthcare services which fit the medical exemption, then they wouldn't be, but because it's a supply of staff, then there is a chance that it could lead to VAT issues. So it's important to consider how that workforce is structured, who holds the employment contract for those individuals which are employed or work under the PCN, just to make sure that there aren't any issues there for VAT. There's your core funding and different funding streams for primary care networks. There are obviously more funding streams than this. These are the main ones that you'll sort of see as standard across PCN. So core funding, participation. Participation funding is paid to the practice directly rather than the core network or the network group. The participation is there for them effectively being part of the primary care network. The other aspects are there for the practices or for the primary care itself, which is then distributed to each of the practices as well. Additional roles and reimbursement schemes. So the ARS scheme, as I've sort of touched on already, that is for various different people. So you can have people like a mental health practitioner. You can now have a GP, which is within the ARS scheme, so they can employ a GP. The restrictions are quite strict though, so you can't have a GP that has already been in practice. They have to be a newly qualified GP, and it has to be their first substantive post qualification. So there are few and far between GPs which are available which fit the criteria to be reimbursed under an ARS scheme. So yeah, as I've already touched on there, GPs can be covered in there. You can also now cover practice nurses, and that will be available again to nurses who haven't previously had a job within the PCN or the member practices within the last 12 months. And as with all of the funding within general practice, it will be reviewed again. It'll be reviewed again during the 25-26 year, so this current financial year. And there is a new 10-year plan coming out for the NHS, so who knows what will actually happen. That is due to come out, I believe, next month, so there may well be further guidance to come out, which is in relation to the AARS and other primary care network funding within that as well. Quality and outcomes framework. So you can see on this slide that the value of each QOF point does increase or has increased over the last 5 years. The caveat with that is it looks like a practice would receive more funding. However, you can also see that the average list size has increased as well. So the increase in funding, the increase in the pounds per point, is exactly the same as what the increase in the average list size is as well. So if a practice didn't change their list size, achieved the same amount of points, they would actually be worse off year on year because their list size isn't keeping pace with the average national list size. If a practice was in an area where there was a new housing development and average list sizes increased by more than the national average, and then they achieved the same number of points, then they would actually be better off. You can also see there that the available points has dropped for 25-26. That funding, which was attributed to those 71 points, has moved back into the core funding. So that core contract, the £121.79, which we touched on earlier. Premises reimbursement. So these vary depending on whether the practice owns the practice premises which they operate out of, or whether they lease it. So if they own the practice, then they receive notional rent, and that rent is reviewed every 3 years. It's based on the market value for the rent for the building being used as a medical centre. So they get quite a good amount in there. Strongly recommend getting practices to review their notional rent every 3 years, because generally it does increase every 3 years. It doesn't normally reduce. If you've got any parts of the practice which aren't being used for medical purposes, then that can affect the notional rent valuation. So just need to bear that in mind. Cost rent is now being phased out. We don't see very many people on a cost rent scheme. They tend to be more on an actual rent scheme. So that actual rent scheme is based on what the lease says. So the lease will say exactly what the practice is required to pay for those rent and the service charges, and they will have to pay stamp duty, land tax on the grant or renew of that lease. That isn't reimbursable. It's only the annual lease payments which are reimbursed. You can also see in some practices where they actually get an extra reimbursement, so they'll receive more than what they pay for their lease payments, and that will be because they'll pay for things like the building maintenance, etc., which is written into the contract. So it all depends on what that lease says, and what is written into that will then depend how much they get as their rent income. Premises reimbursement. So business rates, so their council tax and their water rates, they're directly reimbursed. They have to submit a claim for that, so you need to make sure that those claims are submitted on an annual basis. If they did receive a refund, which we saw from a lot of councils a few years ago, they received a refund, then that money would be due back to NHS England because they've been directly reimbursed the cost. And then dispensing and personally administered drugs. So some practices will dispense their drugs and they'll have a built-in pharmacy. Other practices won't, and they are termed non-dispensing. So non-dispensing practices do receive a reimbursement plus a dispensing fee for administered drugs, whereas dispensing practices receive that, but they also receive a reimbursement for dispensing over-the-counter drugs. Dispensing practices are generally VAT registered because the sale of the drugs is not a VAT exempt supply. It is taxable, so they will be partially exempt. They'll have services which are both taxable and non-taxable. Makes VAT returns very fun. And what they have to do on a monthly basis for both non-dispensing and dispensing is submit a claim to NHS England, and then they will receive their reimbursement. And what you would generally see is a much larger claim over the flu season, because obviously they've got to buy those drugs to deliver the flu campaigns. And one thing that we tend to see, or have seen in the past, is where practices haven't perhaps claimed for the right drugs, they've claimed for the incorrect drugs, and the difference between what they've been reimbursed versus what the cost has actually meant they've lost out. So it's important for practices to make sure that they know the right codes to use when they're submitting their claims. Generally, if you are a dispensing practice, we would expect to see a drug margin, a profit on their drugs of roughly 28 to 30%. Other NHS income sources, I won't spend time going through all of these. Again, they vary significantly. The main ones that we have seen recently, the winter access funding, transformation funding, and we always see things like training grants, depending on if they're a training practice, appraisal income if one of the GPs is doing GP appraisals. So we'll tend to see those sorts of things. Non-NHS income. So this is for services which aren't related to NHS, so CPD trainer allowances, private medical fees, shotgun licenses, HGV licenses, medicals and reports, so people needing sick reports or sick certificates for work or holidays or whatever it may be. Medical students, so training people at universities, as examples. Reimbursements, so these are direct reimbursements, so CQC fee, which the practice have to pay to be registered with the CQC, they can claim that back and that's directly reimbursed. They can claim reimbursements for PCN staff costs, for staff training on some instances, not on everything, but on some instances. These are the sorts of things that we tend to see. VAT, I won't go into that in too much detail. I've already covered most of that off anyway. If you are dispensing, then they would be VAT registered, but they are complicated and pretty horrendous to try and get your head around. So I'm not going to go into detail on that on a nice Tuesday afternoon. That would bore you to death, I should imagine. And then that's me. So those are my contact details. If there are any questions, please let me know. But I am a couple of minutes early, so if there are any questions, please do let me know.
Thank you so much, George. That was a really informative talk. I remember my days back in GP fund holding many moons ago, so it's bringing back some memories. There are some questions actually in the chat. So what we might do is just see if our next speaker is available. And if our colleagues are happy for you to answer them on the chat individually, would that be okay?
Absolutely, not a problem at all. I'm happy to do that. That's great.
So I'm just going to see if our next speaker is here.
I am indeed.
Fabulous. Is it Deborah?
It is, yeah.
Thank you, Deborah.
Thank you so much for inviting me. And like you said, I'm getting hotter by the minute. I must admit, I actually wish I was in the office for a change rather than at home, I must admit. So let me share my slides.
Thank you, Deborah. And we'll thank George again for his wonderful presentation. And I think he'll stay in the background to answer some of the questions in the chat for us, which are a little bit technical. But I do think I know the answers to some of them, but I'll leave it to the expert.
I think that's always best.
Yeah, hand over to you now. Thanks.
Thank you very much. So first of all, thank you all for hanging on. It's been a very long day, and I've dipped in and out of the day, and some of the content is very detailed. So thank you for holding on to until my presentation starts. So to explain a little bit about myself so that you know that I'm actually aware of what I'm doing. I've been a finance business partner at Croydon University Hospital for, well, it was since the Olympics came here. So it's 2012 that I joined. I actually started in the finance department of St Helier in my early 20s. I did actually originally put there in 1991, but my daughters told me off and said that it just it was too distant a date for me to put down, and that I shouldn't admit to being in the NHS for that long. But I'm proud of working in the NHS. I'm fully qualified, certified chartered accountant, and I really enjoy it. I've included this picture because we have lunchtime diversity events, not every day, obviously, sort of quarterly, just to bring everybody together. So it was the aim of this is to show that we're not boring, and we are normal people, even though I'm the one in the middle wearing the straight out of Croydon t-shirt, which I'm sure some people don't like, but that's me. So the aim of this session is to provide an understanding of the key principles of setting and managing a budget. It's mainly aimed at budget holders, but you will obviously gain some knowledge even if you're not, so you can be aware of what goes on around you. Moving on to the next slide. So briefly speaking, the finance department is responsible for bringing in and setting up as many contracts as possible to bring in the most money to the trust. And then we have to make sure that that money is used to provide the best benefit to all of the patients. So contracting is obviously a very big part of it, setting the contracts up ready for the start of the year. As various presenters have said, since COVID, a lot of the contracts are on block. I know at Croydon, we have a slightly different setup because we have Croydon ICB and we're the only hospital in that area. So they contract directly with us. So it's a little bit easier, but most, I don't know the percentage, but a very high percentage is block, it's fixed. Everybody knows what they've got to achieve at the start of the year. So the finance department obviously have to set budgets from that income that's achieved so that we can make sure that we don't spend more than we receive the income that we receive. Our trust has values: professional, compassionate, respectful and safe, as I'm sure a lot of other trusts do. I think all trusts do. We provide community services as well as the trust-based hospital services. Within the finance department, you'll hear a lot about SFIs, which are standing financial instructions, another acronym to add to that list. And it's basically levels of authority and signatures to make sure that, not as though they're any less capable, to make sure a ward clerk doesn't sign off £1 million contract. So there's obviously levels of hierarchy within the NHS that the finance department and procurement put in those controls. Yeah, so I know that you've done a little bit of this earlier on, well, quite a bit of it, and how the funding actually flows down to us. I found this little slide, which is quite a nice, easy flow chart. So obviously we're all taxed, we pay national insurance, and a small amount of the NHS budget comes through patient prescription charges. As was already said earlier as well, the GDP, that the government spend 11% of GDP on health, which when we've heard in the news about the MOD spending increasing to I think it's about 2.5% or 3%, you can see how big a budget we have compared to those. NHS England at the moment receives the funding, disperses it down to the ICBs. The NHS trusts and foundation trusts receive most of that income via contracts. Then you've obviously got primary care services that can go out to independent contractors, general practice, community pharmacy, dentistry, eye health. And then there's acute care is obviously the biggest, receives the biggest share of that spending. Okay, so within the finance department, we've got three main areas. We've got management accounting and planning, which is where I sit. And the reason management accounting or business partnering is often the main point of contact for budget holders is because they produce the monthly budget statements that come out to budget holders. So they get to see invoices that are raised, payments that are made, payroll reports. So in management accounting, you get to see a bit of everything, which is why it's important. If you get stuck on anything at all, go to your finance business partner or somebody in management accounting team, and they'll kind of know a bit of everything. It's not to say we're jack of all trades, we're certainly not that, but we do know a lot about a lot of different things. So we would prepare the annual budget alongside the budget holder. We'd report on a monthly basis. Obviously, a main part of our role is actually getting to understand what the clinicians do and how the service runs on the ground. There's nothing worse than a budget manager, somebody like myself, saying, well, why don't you just take that band 5 nurse off of long days because they're costing too much? Because they clearly don't understand the bigger picture, the safer nursing standards, that just anything at all. So I always encourage my team, and I liaise with my budget holders as much as possible, set up meetings, but also go over there informally, chat to them, what are the issues, because by talking to your finance team, they can then help you. There may be better ways of doing things that they can help you with. You can help them, because when they're talking about your area and providing narrative on how overspent you are, for example, then they can say it with some degree of knowledge, and they can actually verbalise the issues for you, or should I say with you. So it's really important to set up you're not, I wouldn't say friendship groups, but it's very important to liaise with the budget holders and the budget holders with the finance team. We provide the monthly information, and we provide costing for business cases, which I see is your last item today. Although some finance departments actually have their own sort of business case costing team, it is done by the finance business partners at Croydon. We often have to go out for tender, especially in these trying financial times. If a contract comes to an end, you know, it's the worst thing to do to just automatically offer an extension of contract. You should be aware of when your contracts are coming to an end and go out to tender with the help of the procurement department. And we also help and cost and monitor SIPs, which, as we know, is a big issue in the NHS at the moment. Croydon have a massive target, and I think it's across the whole country, really. It's quite a hard year, I would say, one of the worst ones that I've seen in my nearly 40 years. So there's also the business services department, which set up the contracts basically to get as much income in as possible to the trust, with the commissioners and with various other external departments. They're also responsible for SLR reporting, which you've heard about today, benchmarking, PLIC submissions, all very important. I've provided just over here a little breakdown of what a couple of those acronyms mean, if you wanted to read those. Financial services are the ones sort of at the front line, really. They make sure that the employees are paid. They make sure suppliers are paid. Obviously, some trusts are outsourced to probably SBS. You might have heard of them, just to cut down on some of the sort of admin costs. They also deal with petty cash, trust charitable funds, capital funding, and cash and liquidity. So like I said, sort of out of all these departments, the one that should know the most about things is the management accounting team, and you should hopefully know who your point of contact is. So a budget, you know, to give the technical term, I think it's a plan quantified in monthly values spread over the year. A budget isn't profiled equally across the year, or it shouldn't be, because obviously things like utilities, there's peaks and troughs during the year, so you should be able to phase your budget to meet the increased demands over winter and things like that. So without a budget, you're not going to know what the plan is. That the budget has to match the income that the trust receives. It should be perfectly balanced like this is. So if you go over your budget, you're basically spending money that you haven't received to provide that service. So something's going to drift. And in times where the finances are very tight, budget holders, if they are overspending, absolutely must know why they're going overspent. Did they sit down with the management accountants at the start of the year to set a budget that they are comfortable with? All budgets, when they're set, should be signed off, so that the budget holder is fully aware of their budget. There's no point just saying here's your budget and it bears no resemblance to the service that you're looking to provide. So planning in this way enables the NHS to deliver services within its financial means, and obviously we've got legal and financial duties to spend the money from the taxpayer as efficiently as possible. We have to set the budget, monitor it. We have to forecast it towards the end of the year. Once again, bringing in, you know, winter months and how that always goes a little awry. And we have to make sure that the spending remains within agreed limits. I mean, many years ago, if a trust were to overspend or need more money, it would just seem to appear. But this year particularly, there's just nothing extra around, so it's a lot more serious than it used to be. So budgets enable the NHS to plan, to identify the expenditure, to be able to get the activity that we've contracted to provide, to be able to control expenditure and to make sure the trust gets the best value for money. And it makes the budget holder accountable, because like I said, they should sign the budget off at the start of the year. They're the holder of that budget, and they need to know exactly what's going on, and be accountable to provide a balanced budget at the end of the year. And budgets are critical to organisational success, because if enough work was done at budget setting, we should have the funds to be able to provide the contracted activity levels. So there's just 2 slides on how budgets are actually set. This is our little hospital. I can't remember why they were all gathered outside, but it's a nice picture of us. So once activity levels and contracts are in place, the expenditure budgets can be set. As a previous presenter said, direct pay costs account for about 75 to 80% of the total expenditure, which when you think about it is huge, which is why pay awards and strike action and anything like that puts it, you know, it seems like a small amount that you might be asking for, but it's millions and billions of pounds when you consider that it's 75 to 80% of the overall pay, and that the NHS receive what is it, about 190 billion. It's massive. So as a quick query, just to check that you're all awake, on top of the salary that staff receive, the trust pay an additional 25% more for on costs. So can you put into the chat what you think the on costs means? So A, B, C or D? Except I can't actually see your answers, which is a bit of an issue. Okay. Oh, a lot of B's, all B and C. Lovely. So it's actually B. So when the finance department, which may be different, talks about on costs, it's about it does work out about 25%. I think it's 14.8% for NI or yeah, for NI contributions. And then if you're in the pension, which let's face it, the majority of the NHS are, it's about another sort of 10-11%. So it works out that although you're costing your trust, I don't know, 25,000, the actual cost, sorry, although you're taking home a set amount, the cost to the trust is actually 25% more because we have to pay additional things directly related to your employment. So thank you for engaging and answering that question. At the start of the year, all staff are recosted individually, and if they're not, they should be. You have to change it for the expected pay award. As in this year, there were changes to NI rates, there were changes to the upper and lower earnings limit. There were lots of changes, and if you just roll forward the budget from one year to the next without doing those sort of changes, you're just setting a rubbish budget to start with, and there's really no point in it. And the problem is that if budget holders, clinicians, whoever's got a budget, sees that they're not being set properly at the start of the year, then all faith is lost in the system, and budgets are definitely not kept to. So engagement and communication, setting the correct budget at the start of the year, then you're all on the same path and it just makes things a lot easier. Obviously, when we cost our staff, especially ward-based nurses, you have to include out-of-hour working rates, Saturday and Sunday enhancements. If you're a band 2, for example, because it does change according to the grade, if you're a band 2 nurse and you work on a Sunday, it's actually a 60% enhancement. On Saturday, it's 30%. And as you go up the scale, the enhancement percentage is less. So you have to cost every single staff member at the start of each year. Now, when you go down to non-pay, so basically you'll have a budget for pay, which is obviously all your staffing, and non-pay, I mean, it's laughable really, is literally everything that isn't pay. So it's drugs, medical and surgical, maintenance, it's just absolutely everything. You can break it down into 4 sort of categories. Operational, so your utilities, rent, maintenance, all of those sort of things that you might have sort of contracts in place. It's a regular bill. Capital costs. The NHS has a capital budget as well as a revenue budget. So there are capital costs, and NHS as a whole provide funding, as we often see in many budgets, to I don't know. I mean, I used to work at Epsom St Helier, and I've heard that they're going to redo that every 4 years for about the last 20 years. But because obviously there's a limited resource there, but those capital costs are things like the machinery, building, technology, supplies and materials, manufacturing materials, office supplies, and then services that you receive, consulting, outsourcing. We have to pay fees for psychologists to, I can't remember the word, but there's lots of outsourcing and insourcing services provided, marketing. Additional funding is also received at the start of the year for non-pay inflation. It's normally, I think it was 2 or 3% for non-pay, and a smaller percentage, 0 point something, for drugs. But that is received in centrally, and once again, your budget manager should disperse that into the budgets, especially the ones where you've got contract lines. So going on to budget holder responsibilities, just at the bottom, you can see there, ask for help. Communication between finance and the clinical teams is so important. Quite often, the finance department are worried about talking down to clinicians, because obviously you're all very clever, intelligent people, but quite often the clinicians just want it broken down simply, cleanly. Am I overspent? You know, what can I do? Their time is limited. They need summary information. So it's a case of setting up those lines of communication. What do you need from me? And sort of how can you help each other? So I put down that your responsibilities would be to fully engage with the budget setting process. If you're not approached during budget setting, then contact somebody and say, why aren't I being involved? Because the more you're involved, the more your budget is likely to be correct at the start of the year and be something that you're happy with. If you receive a budget statement monthly, if you're with SBS, then you'll have like a portal that you can go into on sort of the third working day after a month finishes, and your budget statements should be there or thereabouts by that time. So we aim to finish as early as possible, obviously always balancing quality of data against timeliness of receiving it. There's no point it being 100% accurate and you receive it practically as the next month is starting. So we try to finish as early as possible. So make sure you look at that. Make sure you understand the data that you're sent. And if you don't, honestly, just contact the finance team and say to them, explain this to me. And especially because, as we know, it's 75 to 80% of the cost of your department, check your staff listing. With medical staff rotating quite a lot, unless HR are properly involved in the recoding of staff to different areas, you can quite often be left with juniors in your cost centre who may be rotated on quite a few months ago. So just check that you're familiar with all the names that you see on your staff listing. If you notice anything odd, then just contact management accounts. And you can use the information that you receive from the budget to help make future plans. If you want to develop something, then you can approach us to do with business cases, or research and development team are always happy to help. There's various people out there, but it's just a case of knowing who to go to. But like I said, go to management accounts and they'll point you in the right direction. So pay, if you're a budget holder, then you're responsible for completing staff change forms, obviously making sure that you submit leaver forms on time, because otherwise you'll be paying for staff who have left the trust, and that's very heavy on resources to reclaim that money back. So being in touch with all the staff, everybody who's leaving, if somebody's changing their hours, if somebody has gone up a grade, and obviously there should be controls within your trust for those sort of grade changes, because unfortunately it's not just a case of Joe's doing well, let's put him up a band. There's many forms and many systems involved in that sort of thing these days. Non-pay, just make sure most trusts are no PO, no pay, which basically means that you have to raise a purchase order. So raise the purchase order when the goods are received, you receipt the purchase order, and then it's all matched up automatically in the SBS system to the invoice, and then they're paid in a timely manner. And then SBS AP team don't shout at us for bringing down their payment days. So so once again, ask for help. Communication between finance and the clinical team is very important. I've only got 3 more slides, so hang with me. I'm getting there. So this is a typical budget statement. Obviously, I've taken the name out of it, but this is how we do it in our trust. Each trust is different. This is at month 2, and the reason you can tell that is This bit is to do with in month. This bit is to do with year to date. And you can see at the bottom that this is 2 months worth of that. So you can see that this is month 2. So just to give you a really brief overview, generally speaking, you'll have pay at the top and then you'll have non-pay at the bottom. A cost centre is something that's unique to the area. Ward coronary care will be a cost centre. I don't know, you know, all the different areas will have cost centres and they're unique to you. So if somebody says to you, what's your cost centre? Your first response should be, why do you want it? Because you don't want them charging anything to you that you're not aware of. That's your private cost centre, should just be your costs on there. Here are account codes. They used to be called expense codes, one and the same really. And these are unique across the whole country. So everybody who's on the SBS system, these are set account codes. And what this basically means at a trust level is you've got all your different cost centres that then roll up into directorate level, and then finally up into trust level. And then there's one cost centre at the top that brings together all the costs. And because everybody's using the same account codes, that it's just one big budget statement at the top. What you should never do is, I don't know, say like you want to buy a bladder scanner and you know that they're £3,000 and you see that you've got a bit spare on furniture and fittings, but you don't actually have enough in medical and surgery. So what you can't do is give the furniture and fitting code and stick your bladder scanner there, because then you're not properly showing at the top level what we're spending our money on. As a manager, as a finance manager, I would say to you, yes, that's fine, as long as you don't spend your furniture and fittings budget, but you do need to code it to medical and surgical. So always make sure that whatever you're buying is against the correct account code. So this funded whole-time equivalent, basically one whole-time equivalent is somebody is a agenda for change employed person who works 37.5 hours. As we know, medics work 40 hours split into 10 PAs. So you've got your morning and afternoon sessions. So for doctors and medical staff as a whole, one whole-time equivalent would be 40 hours. But for the purpose of this cost centre, these are all agenda for change. So there's 37.5. So this is the budget that we've got for the staff that we need to run this area. Contracted is the actual people who have contracts. So you can see there's a bit of a gap between the two because we've got some vacancies. Worked is, and I know not all trusts have these different categories of whole-time equivalents, but we do. So worked basically would be lower than contracted if somebody was on maternity leave, if they were on long-term sick, because technically they're not working. They're contracted and they're paid, but they're not working. So they wouldn't be included in this stat. And also, if you can see bank nurses, bank staff aren't contracted, but they do work and they are paid. So the worked column we find picks up all the temporary staff and the permanent staff and takes account of staff who are not on the ward or the area at that point in time. Paid, I've always found, is a little bit, it doesn't really provide any useful data to me. It basically shows that when staff work at the weekends or out of hours, which, you know, in most clinical areas is normal. So that's sort of the whole-time equivalent data. This column shows your annual budget. So you've got your pay and you've got your non-pay. And then, like I said, this little bit is the current month. And this bit here is the year to date. So you should always be interested in the bottom right-hand column, because that will show you your year-to-date position. And you should always be aware of, you know, as soon as you read this, you should be looking at these bottom lines. Has anything skewed it? Is there anything odd in the actual column? You know, if you were to see £20,000 next to furniture and fittings and you know you haven't brought anything, then generally speaking on this sort of report, anything that's blue, you can just click on it and it will take you to the detail. Our system, you can always click through and you can actually see an image of the invoice that has been charged there as well. So it's a good system from that point of view. Now, I do have 4 questions for you. One is, what is the total annual pay budget? So you can write that in the chat if you want. But yeah, what is the total annual pay budget? Remember, it says pay. What is the year-to-date total position for this cost centre? I shouldn't have picked up that one earlier, should I? Because it now says, what is the account code for furniture and fittings? And also the pay line for nurse band 6 is underspent by 14,123. Do you know why? So I would like to think that you're going through your answers. Shall I have a quick look? Oh, yeah, that looks good. And quite correct, James, not fully recruited to budget. I think they had 1.83 vacancies there. So we'll just go back. So the total annual pay budget, so I have put the answers on the next one, is 1.3 million, which is relatively standard for a ward. It's normally about 1.3, 1.4 million for a standard sort of 24 bedded ward. What is the year-to-date total position of the cost centre? So this is that bottom right column. If you get confused with the brackets, it's generally, you know, just look to the left and you can see, well, I've got a budget of 223, I've spent 213, so I'm underspent. So underspent has the brackets. Some trusts are different, so just work through the numbers there to work out what the variance is. So obviously this is a lovely looking cost centre to me. This is underspent and non-pay is, you know, overspent by £152. In the scheme of things, that's fine. What is the account code for furniture and fittings? So it's 7350, that one there. And the pay line for nurse band 6 is underspent. And as James said, you've got a budget for 5.83, you've got 4 in post, and so you've got a favourable variance in month and year to date. And you can also normally see, so if that's band 6, you'd expect to see bank nurse costs at band 6 to cover that vacancy. But in these times, a lot of the areas are trying to cover vacancies at a lower grade. So I would say that this is probably more to do with the band 6 vacancy than the band 5. And then very quickly, right at the ends of the presentation, I realised that this was actually called Understanding Budgets and Spreadsheets. I looked at last year's one and they didn't cover spreadsheets. So I thought I'd just do this quick slide. Basically, you either love Excel or you don't. I love Excel. And it's the main tool that you'll come across. Some people find it, really daunting, but the more you play with it, the better you will get. There's loads of help available from your IT department. I'm sure One NHS Finance provide beginner Excel, but being able to have a massive sheet of data and do a pivot table, which is really easy, and sort of pick things out and do a graph, it's fun, to be honest with you, but that's the accountant in me. But so basically, don't be scared. There's a back button, so you can undo anything, or just close the file and not save it. So don't be scared and reach out for help and get yourself literate on Excel, because it really is a great tool for analysing data. So I thought I'd end with a little quote, and that is, a budget is telling your money where to go instead of wondering where it went. And I think that summarises budgets quite well, and in our personal life as well as at work. So that's the end of my presentation. I can stop that and I can look in the chat for any questions or stay on for a little while. But does anybody have any questions now? You're not all asleep, are you? Because that wouldn't be good.
So, Deborah, thanks so much for your talk. That's
all right.
a brilliant topic, very close to my heart.
I love budgets, yeah.
We've tried to answer some of the questions as they've come through on the chat, but I think we might have AK ready to do the next session. So if that's the case, it'd be great if you wouldn't mind staying on and just answering those last few questions. I think we've got a question about run rates. So if that's okay, Deborah.
Yeah, no problem. Thank you,
and there might be
everybody.
some questions that come up during, over the next half an hour or so. But thank you again, and hope to see you again very soon.
Thank you.
Thanks. I think we should be on our last session now on business cases, being run by AK. See if AK's back.
Yep, I'm back. Thanks.
Fabulous. Thanks, AK. I'm going to hand over to you now.
Thanks, Pam, and thanks for chairing today. So I'm back. So we're going to talk about business cases. It is going to be a whistle-stop tour of business cases and a whistle-stop guide to business cases today. There are slightly longer sessions available on the YouTube channel that might cover it in a little bit more detail, at least. So when we're talking about business cases, we're going to be talking about every organisation has a slightly different process for business cases and has a slightly different kind of forms. But what we're going to try and concentrate on are the principles behind business cases, and we're going to try and follow what is the current Green Book, which is the government's guide for public sector business cases. It's called Better Business Cases. It's also called the 5-case model. It's a way of doing these business cases, and all your organization's kind of business cases are based on this. There are specialized business case courses, but for most of us in healthcare, unless your day-to-day job is building big multi-million-pound business cases, it is probably not that useful to do the big cases, because we don't follow the process in its entirety. So what is a business case? There are two kind of ways of looking at a business case. It is either, and the most common use of it is as a way of asking for money, essentially asking for resource. And it's a way of, you're asked to put in a business case so that the senior executive board, or the management, or whichever committee looks at it, or the commissioners can weigh up and work out and prioritize which where to invest their money, how to allocate their resources, essentially. The other way of looking at business case is a way of looking at how you've come to decide on the path you've chosen. And I'll come to that in a bit, in a little bit. It is very important that you understand the business case process within your organization, because everyone is slightly different, as I said, and some are very shortened, some are very prolonged, and you may end up targeting a whole different pathway. So, for example, you may be better off, rather than going through the usual business case pathway, if you may be better off targeting educational funds or targeting some of the other pots of money around. So sometimes it might be specialist commissioning, if that's where the most benefit is. Sometimes it might be the ICBs. Sometimes it might be internal. Sometimes, if it can all be done in-house with a rejig of job plans and resources, you may not need a full business case. So it's really important to know what the process within your organization is and get people involved early on. So the next bit is, do you actually need a business case? As I said, sometimes if you're just looking at an options process, if the money's already been allocated, you might just need a much smaller process of which option to go down. How is the best way of doing this within the budget that we've been given to do this in? Sometimes it's not a single business case, it's a whole program. So a program is a whole series of business cases that kind of are interconnected and interdependent. and over a period of time, you need them all to be approved in order to get them through. And because there's a whole program, you might need project management, and you might need a whole team to kind of help run that. So you need to work out what exactly you need. Is it smaller? Is it bigger than the standard business case process that we're going to be focusing on now? So just take a few seconds. You don't need to write it in the chat, but just think about what kind of things need to be in a business case. So what do you think should be in a business case? It is all the who, what, where, when, why, if. All those kind of questions need to be answered. But we're going to try and do it in a structure. We're going to do it in a step-by-step structure for this. So you've got your strategic case, which is the kind of the why almost. You've got your economic case, which kind of ends up with the how. And then the commercial case, the financial case, and the management case are the rest of them. I'm going to focus on the strategic case and economic case. We will touch on elements of the commercial case and financial case, and very briefly on the management case, because the commercial case you really need specialist input for, as you do with the financial case, and that's where contacts in procurement and finance is really important. So what drives a business case? So what is the main kind of question, or what is the main kind of focus of a business case? And the biggest, I've looked at business cases. One of the things we used to do is we used to have a session where people would pitch business cases, a bit like Dragon's Den, and we pick holes in their business cases or suggestions for improvements and different ways of looking at it. We used to have one of those sessions, and when we looked at business cases, one of the biggest issues with business cases is it's very clear when a business case has been written with an answer in mind, with a solution in mind. And the best business cases are there to solve a problem. And that is probably the main driver of most business cases. You have to show there's a problem that needs solving. And then you show the options available, and then why you chose the kind of route that you've chosen. So that's the key thing, solving a problem. In a small number of business cases, there may be an area where you can improve quality without it being dire already. You can improve quality, and that might be enough to, if it can reduce, you can demonstrate a reduction in costs in other ways. Okay, so you can improve quality and reduce costs. And if that's enough, then and you've got a very strong business case, then that might get you some funding. But most of the time, you need to show there's a problem, particularly in these kind of more limited areas, limited financial climate. Sorry. So again, it's all about quality over cost, and it's about showing that there's an improvement in quality. It's worth the cost. That's from the first session this morning. There are various stages. So if you're doing a big business case, okay, officially there are 3 stages to it. In most organizations, it's either a 1 stage for small business cases or 2 stage for slightly bigger business cases. The 3-stage business case is unusual in the NHS, apart from ones that need NHS England approval. But essentially you have your strategic outline case, and most of the time you go straight to a full business case. If it's a big building, new building, or a whole new kind kind of like a new A&E or new build, then you might have to do the 3 stages: strategic outline case, outline business case, and full business case. And the kind of things you do at each step is, the first step is you kind of put your context in and your case for change. You do a strengths, weaknesses, opportunities, and threats analysis, and you can have an idea of the indicative costs. In the second bit, once you've got through that hurdle, you do your preferred option, show value for money, and how you're going to procure it and how you're going to implement it. And then the full business case is basically the dotting the I's and crossing the T's part of it. As I said, we're going to concentrate on most of NHS business cases being a 1-step or 2-step process, and so we're going to kind of put it all together. The strategic case is the context. Okay, so what is your reason for needing to change? So you've got to align it to the organisational aims and ambitions. So whatever your plan is or your key priorities are, you've got to show why this business case is going to align with that. Okay, why is it really important that this one does that? Then you've got to do your case for change, which is basically your evidence to show why you are not doing as well as you could, showing why there's a problem. Okay, and you need to have evidence for that. And this is where often we struggle, people struggle. And then so that can be via CQC reports, that can be via GERFT, so getting it right first time reports, or evidence from the model hospital or model health system, which is a kind of benchmark. Again, it's another benchmarking tool. CQC probably has the most kind of influence. A little bit from GERFT and model hospital. NICE and Royal College recommendations have probably not as strong as they used to be, mainly because there's so many of them that come out from so many different Royal Colleges that they often take time to implement. Mortality reviews and root cause analysis are other ways of doing it to show your rationale for need for change. So just to give you an example, this is from the model health system. This showed that my trust was desflurane is an anaesthetic drug, an agent that is really bad for the environment. We were one of the highest users of it, and we used this to get money from a sustainability fund, so a environmental fund, to get other equipment that we could use as an alternative to using desflurane. So you can use these things to drive and request money from other pots of money there. This was from an ICB sustainability fund that we got money for. Okay, this is again from this is a few years old now, but this is again from Model Hospital or Model Health System, and it shows that the black line is our trust. So the number of patients that get discharged or have a length of stay of less than 2 days after having an appendix or coming in to having an appendix out is very low. And when you look into that in more detail, it's because the patients have to wait 2 days to have an appendix out because we don't have enough emergency capacity in our theatres. So we can use this to go, right, we need to increase our emergency capacity. You can do a bit more work based on this to then find out what the problem is and then go from an options appraisal to kind of go, what do we need to do to improve our emergency capacity? Okay. So the next bit of strategic case is then looking at what your existing arrangements are. So what is the current state of play? How you see it changing in the future. So it's like a demand and capacity assessment. Okay, so what's your current activity levels? What do you foresee it? And you can do that in a minute. We'll show you looking at historically how things have changed and where things go from now. Your scope is what realistically is what you're trying to do. So if I was looking at that thing about theatre capacity, my scope is improving staffing for emergency theatres. This business case would not be to build new theatres because that's outside of the scope of what I can realistically achieve. So it's about being realistic of what you're going to be achieving. And linking into that, your spending objectives would be looking at what kind of staff you're looking at. So it's staffing, we're looking at more anaesthetic staff, more theatre staff. Are we looking at more surgical staff? So what are your spending objectives going to be? The terms here are constraints and dependency. Constraints are my theatre estate. So I haven't got any more theatres that I can use in hours because they're all being used for emergencies or electives. So that's going to be our constraints. Dependencies are other projects or other business cases that might be dependent on this business case. So what's dependent? You know, if this only this business case gets approved, will other business cases actually work? Benefits and risks are benefits are good things that might happen. Risks are potential, as it says, risks. There's another word called disbenefits, which are potential unintended consequences that are bad. Okay, so disbenefits is another word that you might hear in this context. I don't like it, but it is a word that's used in the Green Book. Okay, demand and capacity modelling is essentially by looking at your current activity over the last few years, looking at how it's changed, and then trying to forecast how it might change in the future. Now, you might be able to factor in different things like population growth and all these other things that might help, particularly if you've taken on, like we've suddenly taken on a whole load of work from a whole load of work from neighbouring hospitals as of like April. So then we can factor that in to increase our demand and capacity modelling. And then you can use that demand and capacity modelling to look at how much that actually would need, how much more activity you would actually need to deliver. Depending on the finance arrangements, you may or may not get increased costs. That's the grey bit on the side. So this is taken from a historic, probably about maybe 8-9 years ago, when imaging was paid for separately as unbundled, so it wasn't part of the main tariff, and so you got paid extra for these extra imaging modalities, and how much extra income you'd get from that to justify the extra resource that you'd be delivering. So the economic case is very much about, I think, is about your options. This is your options appraisal bit. What you've got to remember is that the people reading your business case do not know the detail. You know as a person writing the business case, you'll know your area inside out. What you don't know is what things that you think are obvious may not be obvious to other people. So the long list is your opportunity to think of all the different potential solutions, even the ones that seem ridiculous, and put them down so that you can show people you've thought about them. Okay, and then your assessment criteria. So it's basically a list of your, if you think of your job descriptions, you have essential, criteria, and desirable. Essentially, that's what your assessment criteria is, and you can weight them how you wish. Okay, your critical success factors are your essential, and then the other things that you might want are your desirable, and you can weight them accordingly. And that's how you get from your long list of all the weird and wonderful potential options to your short list. Okay, you realistically need about 3, ideally 4 options for your short list, and it must include a minimum or do nothing option, just to show what the status quo is. Okay, and then you do your economic appraisal, which shows the qualitative benefits. What are the, for each option, what is the potential quality improvements? Okay, versus the cost of each option. So economic appraisal is your qualitative benefits, and then the cost appraisal is the cost of each option. So you can compare each option by cost and quality improvement to show that, to compare and contrast essentially. And that's then how you then justify the option that you've chosen. Now I know some people struggle to think of options or solutions. Then so we can do it this way. You can do an options appraisal based on the what, how, who, when method, and you have your do minimum, intermediate, and maximum option. They're all interdependent, and what you do then is, and the one I'm going to use, everybody's from different specialities and different areas. So the one I tend to use is HS2. So we're going to use the kind of railway line kind of analogy. So the problem is improving capacity on the rail networks between London and the rest of the country. Okay. So the minimum option, what's the scope, is improving the capacity between London and Birmingham. Okay. The next level is to improve capacity between London, Birmingham, and the north west. And the final option is to improve capacity between London, Birmingham, the northwest, and the northeast. Okay, so they're the three options. How is whether you refurbish the lines or you create new lines. Okay, so how might be in clinical medicine, how often you want a clinic, or how often you want a theatre list, or how often you want to run, how are you going to achieve it? So in the minimum would be to refurbish the existing lines, the maximum would be to build a whole new line, intermediate would be to do a mix. Okay, you might want a weekly clinic, every other week clinic, or a once a month clinic. You know, that could be how. Who's going to deliver it? So is it a consultant led? Is it a specialist nurse? Is it a combination of the two? Is it multidisciplinary? In the clinical world, in this example, it'll be local, national, international contractors. Okay, but who is delivering that care? Okay, and then when? So when is how you're going to roll it out? So it's either going to be you're going to do one at a time, in staged. It could be big bang all at the same time, or it could be doing two and then maybe one later on. Okay. Funding is all about where the money's going to come from. Is it going to come from your budget? Is it going to come from commissioning? Is it going to come from savings from over a period of time? Okay. In this example, it's public-private money, essentially. And what you then do is kind of colour in red the ones that are non-starters because they don't meet your criteria, your key success factors. You put in yellow the ones that you think are doable, and your green is your preferred. And in underneath, you kind of put down your rationale for why you think each one, or why you've chosen that, and what your rationale for each of those things are. And that way, you've shown that you thought about it and you've come up with a good solution and the rationale behind your solution. And that is probably the key bits to your business case. Up to this point is the important bits. So this is a summary of the strategic and economic case. The commercial case is all about procurement. So as we talked about and we heard about earlier, it's about the whole life cost and how you work that out. And there are different ways of procuring stuff, depending on you want to put it out to tender, to open to all bids, or do you want to be a bit more selective and do a kind of an appraisal and then choose and do a direct award. But your procurement teams would be the ones that know, where it sits best. So when it comes to personnel requirements, this is where HR comes in with templates. So they give you an idea of the kind of working time equivalents you need. So for example, one clinic might be one PA's worth for a consultant. It might be, do you need, how many working time equivalents do you need to have an extra nurse on a ward, or an extra person working 5 days a week in the community? They'll tell you the kind of working time equivalents for that and how much do you need to allocate for that. And then finally, you've got contract issues, which is all about making sure that if you want to purchase a bit of kit that's already under contract, so for example, we buy our syringes on a trust-wide basis. If I wanted to buy a fancy new syringe that's got special things that I want, then I need to make sure it doesn't breach the contract terms that we have with the existing supplier. So if we have an existing supplier that makes that a similar version of it, it may not be as good, but a similar version of it, we may have to then either go with that or wait till that contract finishes and then feed into the procurement process for the next one. The other issues are intercompatibility. So, you might have contract issues in terms of, so some bits of kit come in with built-in computers that maybe were made of one make, and all the rest of your IT is made of another make, and then there can be interoperability issues. So it's just working out what they are going to be. How are you going to pay for this? As I said, where the money's going to come from, savings loans. So if you say you're going to save money, over what kind of time period is this actually going to be achieved? And then finally, how is it going to be delivered? So that is in terms of big bang, pilot, trial, gradual rollout, step by step, phased. How are you going to deliver it? How are you going to roll out whatever it is you're going to try and roll out? When we talk about impact of service delivery, it's very much about two things. Are you doing a business case that's going to impact other services, positively, negatively? If it's positive, highlight it. If it's negative, just be aware and try and mitigate for it. Is it during the rollout process, are you going to have issues? If there's delays in the build, how are you going to kind of maintain your service delivery while the rollout's happening? So, for example, when we moved our transplant services from one site to another, there was a potential we might needed to ask a neighbouring site or neighbouring hospital or organisation to cover our emergency transplant service for 24 hours while everything was moved around. So what is the impact on your service delivery during that kind of transition phase? So we've got our PAS rollout, so we're changing from one patient kind of information system to another to kind of underpin our EPR this weekend. It's a massive change. We've got all kinds of business continuity issues. We've got extra staff coming in. It's kind of a massive issue, massive thing that's happening this weekend. So you've got to factor all that in when you're doing your plans. And if you think about it and show it in your business case, people will judge you better on it. It's always worthwhile to get input from all the people that are maybe affected by your business case. Get them to be involved, make them part of the solution. The more people you contact and get on board and support the business case, the more likely it's going to get through. A lot of business cases are almost decided whether they're going to get through or not earlier on in the process. So if you've got, what you don't want to be is allow them to be blocked or put up barriers. So if you get them involved, address their concerns and their issues, then they're much more likely to support it and help you get it through. So finally, couple of tips. Timing is important. So small, particularly capital business cases, towards the end of the financial year, there's often underspends, and you can try and find out. It might be useful to get. They're often a call out for one-off capital spends towards the end of the financial year. If you want a whole new service, you might be better off starting at the start of the financial year, just because you can predict and the commissioners can be involved early on in that process. Remember that discussions can start, months earlier in the process. So it's trying to get that available. Just trying to get that kind of factor that in when you're trying to plan your business case. It's also it's important to think about. Business cases, the kind of funding is always allocated on a kind of particularly on an annual basis. So if you're looking for a new post, then it may be that you've got to factor in the time it takes to advertise and then recruit and the notice period. So if you're going to take over a year, you need to factor that in, because your costs may be for this year and may not automatically be factored in for the following year. They're just worth taking that into account. As I said earlier, digital transformation funds, education funds, or system funding, specialised funding, that becomes less of an issue at the moment. There are often, about January, February time, there are often calls and messages sent to your operations teams and via the management teams for projects that might be suitable for this extra capacity, extra funding that is there. I know that NHS Resolution do a lot of patient safety related funding bids, or they had done in the past, and they normally get disseminated out via the trust leadership teams. So your operations teams might know where the best place to get that is. And finally, sometimes it might be worth combining with a larger business case to do that, especially if it's related. So a small amount on top of a massive build is worth doing. So, ideal business case, problem being addressed or intended benefit is really clear. Potential options should be considered. Demonstrate value, has a feasible implementation for plan. You've got some contingency in there, and you've got some realistic timelines. So that is my business cases in half an hour. Really, really quick overview. Any questions? As I said, I'm happy to kind of, if you email me, I'm happy to answer more specific questions. I'm also the standard thing I say to all people on these calls is, if you want me to have a look at a business case, I can do. I'm happy to just send it across. I'll put my email address in the chat. You'll get links to all these stuff. There's some extra slides on there that you might find useful later on when you get the slide pack. I'll stop sharing now. I'm not sure that's stunned silence or if that's just people bored and waiting to go home. Okay. I'll hang around for another 2 or 3 minutes, but if you have any questions you want to ask, thank you for coming along today. I hope you enjoyed it. I hope you found it useful. Please, you'll get a feedback form or link to a feedback form in your email that you get, and links to all the kind of information. If there's anything more you would like us to cover, we're trying to put together some more resources and stuff. There's a glossary of finance terms on the One NHS Finance website, and some more other links as well there. So thank you very much. As I said, I'll hang around for another few minutes if you have any questions. But otherwise, enjoy your evening.